Hello, hello. Check, check. good morning to everyone.
Very good morning to all. Actually, at the very outset, I thank the organizing committee, Tasneen and Kaveri, for inviting us. Feeling honored and privileged, rather. And the second scalbase, first also, we have attended in anatomy department of Guwahati Medical College last year. And actually, in our days, there is no scalbase surgery there. But I think by seeing and accumulating this, we came to it. And today's first session is the foundation session, actually. Foundation by the pillar, actually, the anatomy, the imaging, and the pathology. And the foundation is the skull base, and this lateral, particularly lateral skull base, is always a very tough, this particularly anatomy and also the relations. Therefore, a good decision making and good skill is necessary. And particularly anatomy is a 3D imaging should be in the mind to get it. And also imaging from the SRCT to the high molecular level imaging gives a good roadmap. And thirdly, of course, the pathology is known as a behavioral block, because the behavior of the tumor you have to know. And with this combination of the three, we have to make some blocks, and that block can be now digitalized. That digitalization block, one block to another, and the combination of the blocks, we can get a good modulated corridor, rather, for a safe journey to skull base. Lastly, but I think the skull base surgeons, he must have very good leadership, and he must be a teacher, also a good teacher, and also he must be a scholar also. I hand over the microphone to Dr. Kudusan.
I'd like to, on behalf of the chairperson sitting here, to thank the organizers for having invited us for this session. And Dr. Fukan has already given us the basis of this session. So before we wasting any time, so I'd like to call upon the first speaker, Dr. Diksha Sharma, who is assistant professor in the Department of Head and Neck Surgery at Borooah Cancer Institute, to give her presentation.
Good morning to all of you. I am Dr. Diksha Sharma from the Department of Head and Neck Oncology at BBCI, and today I am going to talk about the applied surgical anatomy of lateral skull base and temporal bone. So why is the understanding of this anatomy so critical? Firstly, this region forms an important interface between the intracranial and extracranial compartments. It has a dense concentration of certain critical neurovascular structures, so even lesions involving the smallest of structures can produce profound neurological and functional deficit. Oncologically, it provides multiple pathways for the tumor spread, and definitely due to the complex surgical anatomy, the surgical access is quite challenging. So coming to a general overview of the brief general skull base anatomy, so this is basically formed by 5 major bones, that are the frontal, ethmoid, sphenoid, temporal, and the occipital bone. So Jones et al. Has classified the whole skull base into 3 major regions: the anterior, central, and the posterior skull base. And a lateral skull base majorly occupies this lateral part of the central and the posterior skull base. Coming to the anatomy of lateral skull base. Again, Irish group in 1994 classified our skull base region into 3 regions to understand better the patterns of tumor spread. So lateral skull base is formed by this region 2 and region 3. There are various important structures related to this area, like the tympanic cavity, important neurovascular structures, important spaces like the ITF and parotid. Also, it is closely related to important neurological structures like cerebellum, posterior cranial fossa, cavernous sinus, and the cranial nerves. So let's discuss about the region 2. So this region 2 basically extends from the posterior border of the orbit to the petrous part of the temporal bone, contains important anatomical spaces like the infratemporal fossa and the pterygopalatine fossa, and associated important neurovascular structures. Now coming to the discussion of these major structures, First, we start with the space with which we as head and neck surgeons are quite familiar with, the infratemporal fossa. So this region is located here and it is bounded anteriorly by the posterior wall of maxilla, posteriorly by the mastoid process. Laterally, we have the zygomatic arch and the mandible, and medially, we have the lateral pterygoid plate. Superiorly, it is bounded by the greater wing of sphenoid. So this area clinically provides a key anatomical corridor and a pathway for spread of tumor disease due to its various important communications. As we can see, superiorly via the foramen ovale and foramen spinosum, it communicates with the middle cranial fossa. Anterosuperiorly via the inferior orbital fissure, it goes to the orbit. Anteriorly, we have the posterior wall of maxilla, the disease which it can erode the posterior maxillary wall and come into the maxilla. Medially, we have the pterygomaxillary fissure with which it communicates with the pterygopalatine fossa. So it also provides route for perineural invasion, basically via the mandibular nerve which goes through the foramen ovale towards the skull base. It is also an important area for surgical access to the lateral skull base area and forms the basis of all the fish infratemporal approaches. Just medial to this is this area called pterygopalatine fossa, which is again anteriorly bound by the posterior wall of maxilla. Posteriorly, we have the pterygoid plates. Medially, we have the perpendicular plate of the palatine bone. Inferiorly, the pyramidal process of the palatine bone. Medially communicates with the nasal cavity and laterally with the ITF via the pterygomaxillary fissure. Again, it has extensive communications that provides pathway for disease spread. We have already discussed laterally and medially, and most important are these three posterior relations for skull base spread. That is the foramen rotundum, which communicates with the middle cranial fossa. Just medial to it is the pterygoid canal, which leads us to the foramen lacerum. And most medial is the pharyngeal canal via which it communicates with the nasopharynx. It also is the basis of endoscopic endonasal transpterygoid approaches. Endoscopically, after entering the nasal cavity, we can enter the maxilla. After removing the posterior wall of maxilla, we see this area, and drilling this area, we can get access to the deeper structures. It is also a surgical landmark for important structures like the Meckel's cave, petrous apex, and ICA. After reaching this fossa and mobilization of its content, we get access to the foramen rotundum and Vidian canal, and following these structures will provide us access to these important structures. Now, coming to important nerve, that is the trigeminal nerve, which provides basic sensation to most of the face. So it starts after coming from the brainstem. It starts with the trigeminal ganglion, which rests on the Meckel's cave, and then from here it gives its three major divisions: the ophthalmic, the maxillary, and the mandibular. And then it goes to supply the respective segments of the face. So clinically, this nerve is an important site for the trigeminal schwannomas and mostly occurs in the Meckel's cave. Also provides a pathway for perineural spread from the palatal and the cutaneous lesions. And very importantly, involvement of this nerve at any of the segments can produce facial numbness or neuralgias of the respective supplied segments. So it is important to remember that in some of the cases, facial pain might be the presenting symptom of some skull-based tumors involving the trigeminal nerve. Now coming to region 3, this is mainly located in the posterior cranial fossa and has structures like temporal bone, temporal bone, CP angle, petrous apex, and associated neurovascular structures. So temporal bone, this forms the core of the lateral skull base anatomy, and it has 4 major parts: squamous, mastoid, tympanic, and petrous. Just highlighting the important structures, we have the zygomatic process on the lateral surface, the temporal line which represents the attachment of temporalis fascia. Here we have the McEwen triangle. When we drill deep to it, by about 1.5 to 2 centimeters deeper, we encounter the mastoid antrum. This is the tympanic area housing the external auditory canal and meatus, and this is the mastoid area which houses the sigmoid sinus. On the medial surface, there are certain important structures basically found by the petrous part of the temporal bone. So this is the petrous apex. At the apex, we have the carotid canal from which the carotid exits and goes towards the foramen lacerum. Adjacent to it, we have the depression from Meckel's cave. Adjacent to that, we have the internal auditory canal roof, and then adjacent to that, we have this eminence, which is the arcuate eminence, and it is formed by the superior semicircular canal. During middle cranial fossa approaches, we utilize these landmarks, and it is said that by bisecting the angle formed by the arcuate eminence and the groove for greater superficial petrosal nerve, we get the roof of IAC, and that helps in identification of this area. Anteriorly, we have this carotid canal at the apex, and just medial to it, we have the eustachian tube isthmus. So this relation is important as this is separated by a thin osseous bone only. And in cases where it's dehiscent, it puts the carotid artery at high risk of injuries during tympanic cavity manipulations. In the inferior view also, we can see this important relation of carotid canal, and lateral to that, we have the jugular fossa, again separated by a thin jugulo-carotid spine. Coming to the middle ear cleft, so it is formed by the eustachian tube, tympanic cavity, and the mastoid system. And we have all read about this anatomy in detail. So just highlighting the major relations. Superiorly, it is related to the middle cranial fossa. Inferiorly, the jugular bulb. Anteriorly, to the eustachian tube and the internal carotid artery. On the medial wall, there are certain structures like oval window, processus cochleariformis, lateral semicircular canal, forming important landmarks for identification of the facial nerve. So this is a view, lateral view, where we can appreciate all the middle ear structures. Now coming to the star nerve of lateral skull base, that is the facial nerve. So we all know it has various segments. So after the intracranial course, it enters the internal auditory meatus. And after that, exiting that, we have the labyrinthine segment till the geniculate ganglion. This is the shortest and narrowest part of the facial nerve. At the geniculate ganglion, it will give the first branch, that is the greater petrosal, and then continue for the tympanic part, that is the horizontal part. And at the second genu, it will again turn and continue as the mastoid part in the posterior wall of the ear. And then at stylomastoid foramen, it will then exit and give all the extratemporal branches. So this nerve is both most important landmark and the most important structure at risk during lateral skull base surgeries. So it is a constant through the temporal bone, and again important landmark like geniculate ganglion is used in middle cranial fossa approaches to identify various structures, and it is also an important site of facial nerve schwannoma, greater petrosal nerve used for localization of petrous ischiae and apex. The understanding of the branches of facial nerves helps us in topographic localization of the site of injury. Again, stylomastoid foramen, we all know, is an important landmark in parotid and lateral skull base surgeries. Coming to this area called the internal acoustic canal, which provides communication between the inner ear and the posterior cranial fossa. This is about 1 centimeter. And this is the endoscopic view of inside of the IAC, where there are two important bony structures, the Bill's bar, which is the vertical bony structure separating the anterior from posterior, and the horizontal crest separates superior from inferior. So antero-superiorly we have the facial nerve, posterior-superiorly we have the superior vestibular nerve, antero-inferiorly we have the cochlear nerve, and posterior-inferiorly we have the inferior vestibular nerve and the cingular nerve, which supplies the posterior semicircular canal. Oncologically, again, the most common pathologies that we see here are the schwannomas, meningiomas, or there can be metastasis of diseases, potential pathway for intracranial extension of disease. Also serves as a surgical landmark in identification of various structures. Coming to jugular foramen, this is the second largest opening in the skull base following the foramen magnum. Usually right side is bigger than left. This is associated with the more common dominance of the right sigmoid system. And it has been divided into two parts. The lateral part is the pars venosa, containing the jugulo-sigmoid complex. And medially, we have the pars nervosa, where we have the 9th, 10th, 11th nerve, along with the inferior petrosal sinus. Clinically, most common pathology we see here is the paraganglioma, followed by schwannomas, meningiomas, and neurofibromas. So as discussed, it is separated by a thin jugular spine from carotid. This is the jugular bulb, this is the carotid. And in pathologies like glomus jugulaire, it is very common that there is erosion of this jugular spine, and this is seen as the Phelps sign on CT scan. Another important entity is the high-riding jugular bulb. That means it is at a higher level than the normal, that is higher than the middle ear floor. So if you're unaware about it, it can lead to unanticipated bleeding while doing the tympanic surgeries. It is also associated with certain named syndromes like the Wernicke, Collet-Sicard, and the Villaret syndrome. Coming to CP angle, this provides a conduit between brainstem and IAC. This is located between cerebellum and pons. So this is the CP angle. Medially by the brainstem. Laterally, we usually have the petrous temporal bone. Superiorly, we have the cerebellum, and inferiorly, it is associated with the lower cranial nerves. So it has a superior limb and an inferior limb. This is a zoomed view. So we can see the superior limb is associated with the fifth cranial nerve. The inferior limb is associated with the lower cranial nerves. And the main contents of the CP angle are the 7th and 8th nerve along with the anteroinferior cerebellar artery, and we also have the flocculus and the choroid plexus. So again, this is an endoscopic view of the same. We can see this is the brainstem, this is the temporal bone, and these are the main contents. That is the 7th and 8th nerve going to the IAC along with the anteroinferior cerebellar artery. These are the lower cranial nerves going to the jugular foramen, and up here is the trigeminal nerve probably going to the Meckel's cave. Clinically, again, important site of schwannoma, meningiomas, epidermoid and arachnoid cysts, and definitely site of intracranial extension from diseases from petrous apex and temporal bones. Petrous apex is an adjacent area which is associated to various critical structures, mainly the trigeminal nerve, the Meckel's cave, the 6th nerve, which goes through the Dorello's canal formed by the petrosphenoidal ligament of Gruber and the ICL. So this is an important site for benign diseases as well as malignancies of temporal bone, extension of nasopharyngeal carcinomas, involvement results in Gredenigo syndrome. It is an important landmark in skull-base surgeries, and it is basically critical due to its proximity to these critical structures. Discussing the vascular anatomy of this area. So this is, carotid is the major vascular structure that we are all concerned about during these surgeries. So we all know ICA has been divided into 7 segments by Boutelier, and the petrous part, that is the area of concern in lateral skull base, forms the 2nd segment. It enters via the carotid canal on the inferior surface of temporal bone, traverses through the temporal bone and exits at the petrous apex and goes towards the foramen lacerum. Here we can see this is the foramen lacerum going towards the cavernous. So very important are to know the landmarks of ICA in endoscopic skull base surgery. One very consistent landmark is the Vidian nerve. We can see here, this is the petrous ICA, and this is the Vidian nerve coming from the pterygopalatine foramen. And it is said usually if we keep following the Vidian nerve, it will lead us to petrous ICA. So the other one is the foramen lacerum. We can see here it traverses the foramen lacerum to go towards the cavernous sinus. Then another important landmark we discussed previously is the eustachian tube, which lies medial to it. So injury to the structure can lead to catastrophic hemorrhage, stroke or death. Oncologically, involvement and encasement of this structure is a major determinant of resectability of disease. Coming to venous sinuses, there are a lot of whole complex relation of venous and dural venous sinuses. All these sinuses form a confluence and then drain into the transverse sinus, followed by the sigmoid sinus, which continues as the IJV. So for us, these sinuses are important because they form major source of bleeding during mastoid and skull-base surgery. Particular importance we give to sigmoid sinus because it forms the posterior limit of safe mastoid drilling. Also, involvement of the dominant side of the sigmoid sinus might form the criteria of inoperability of the disease. Trotman's triangle, this is a significant landmark bounded by the sigmoid sinus, jugular bulb, and superior petrosal sinus. It provides us access to the posterior cranial fossa. Also, anatomy of this region is important as we are using the retrosigmoid approach for a lot of accessing tumors these days. So we need to know the anatomy. It forms the anterior boundaries formed by the sigmoid sinus and superiorly by the transverse sinus. So to summarize my presentation, lateral skull base is a complex interface between the brain, temporal bone, cranial nerves, and important neurovascular structures. It provides a critical neurovascular corridor and major pathway for tumor spread. It is centered around the temporal bone. Key structures include facial nerve, internal acoustic meatus, jugular foramen, CP angle, and petrous apex. And understanding these relationships and roots of disease is critical for safe surgical access, preservation of function, and adequate oncological clearance. So at the end, I would like to thank my head and neck DMG and all my mentors for their constant support and guidance. Thank you.
Thank you, Dr. Diksha Sharma, for nicely describing the surgical anatomy of the lateral skull base and temporal bone. So now the topic is open for discussion. If there is any questions, query or comment, somebody liked. So we'll move to the next topic. We have Dr. Pratap Kakoti, renowned radiologist from Arya Wellness Center, Guwahati. He will speak on radiologic evaluation of lateral skull-based tumors, what to look for. So I request Dr. Pratap Kakoti to deliberate his presentation.
Morning, everybody. So I'll be talking about the common pathologies in the lateral skull base. You know, you have a zone 1, 2, and 3. I'll stick on the zone 3 only, the temporal bone, including CP angle, petrous apex, and jugular foramen. And I will evaluate the common tumors associated with this. Okay. Basically, lateral skull base, you know, usually it corresponds to the temporal bone. It's a complex structure surrounded by various neurovascular structures. So it's very important to evaluate the nerves and vessels in relation to the particular tumors in particular zones. Thus, imaging plays, because it's not amenable to clinical examination, and imaging has a great role for evaluation of these tumors. So whenever you suspect a tumor or any lesion in the lateral skull base or any lesion in the, whether it is a central, posterior, or lateral skull base, the imaging of choice should be CT as well as the MRI, because MRI will give you the soft tissue detail of this particular tumor as well as the relationship of the tumor with the vessels. Whereas in CT, you will get all details of the body anatomical details of this particular bone. Thereby, you can narrow the differential diagnosis. In some cases, you can diagnose of this particular tumor. So we have in lateral skull base, the lesions are commonly localized into distinct lateral skull base compartment or the CP angle, petrous apex, jugular foramen, facial nerve, and petroclival fissures. Coming to the CP angle, the most common tumors in this CP angles are vestibular schwannoma. You know, most of the tumors are arising from the inferior vestibular nerve, almost 80% cases, followed by meningioma, followed by epidermoid or arachnoid cyst. Imaging has a great role. You can differentiate preoperatively whether you are going to dealing with the schwannoma or the meningioma or epidermoid cyst. So here is the example here. You can see The tumor, there is a heterogeneously enhancing tumor here, extending into the ISC, causing expansion of the internal auditory canal. This is the most common features of schwannoma, small schwannomas. Wherever they have a, how will you differentiate from meningioma? Because acute schwannoma, these schwannomas are more heterogeneous kind of enhancement. They have a cystic changes, they have more, not uniform, they are more heterogeneous, and they have a tendency to grow into the internal auditory canal leading to expansion. One sequence of MRI is the SWA sequence. Here, the last sequence you seen that you will get this dark linear and nodular things. This is very specific, typical of schwannomas. This is because of hemocysteine deposits due to microhemorrhages. So whenever we suspect a CPA tumor, we usually run a SWA sequence also to differentiate from meningioma. In schwannoma, we have a tumor in the CPA angle, which is acute angle in the petrous bone here. We have an acute angle in the petrous bone, extending into the ISC, heterogeneous enhancement. These are the features you can differentiate schwannoma from the meningioma. Sometimes schwannoma entirely cystic. You will get this kind of cystic kind of tumor. Still, you have, if you do a contrast study, you will have a significant enhancement surrounding cystic lesions and as well as the nodular component, which is not typical of epidermoid. Usually it's confused with epidermoid cyst. Epidermoid cyst usually doesn't enhance on post-contrast study. This is the diffusion weighted image. Is a very important sequence to differentiate from epidermoid, schwannoma, and meningioma. Epidermoid always bright on diffusion weighted images because of this cholesterol and viscous content of the cyst. Coming to the meningioma, meningioma is most common tumors. Again, it is similar to schwannoma, but it's a more homogeneous enhancement, broad-based to the petrous apex, usually not going, unless it is a very large, usually not going to the internal auditory canal. Okay, then you will get the bony changes in the meningioma in the form of lytic areas or hyperostosis. So any tumor in the CP angle, you will get this kind of hyperostosis, bony erosions, you think of meningioma rather than schwannoma. Here, the example here, you have a homogeneously enhancing broad-based tumor in this right CP angle. And this tumor has a dural trail and proximally and distally. This is specific of meningioma. So you have a homogeneous tumors with broad base with petrous apex. Hyperostosis of this bone is typical of meningiomas. The third most tumor is the epidermoid or cholesteatoma. It's most common in children, in young adults. Basically, in imaging, you can see that the cyst in this T1 image, T1 weighted images, you can see the cyst in the CP angle, which is bright on T2. This post-contrast doesn't show any enhancement. If you run the diffusion weighted images, you will get this kind of bright signal. It's a very typical of epidermoid cyst. So imaging has a rule to differentiate. Preoperatively, we can differentiate. We are dealing with epidermoid, schwannoma, or meningioma. Arachnoid cyst is similar kind of this one, epidermoid cyst, but this patient doesn't have this, no diffusion restriction on DWI sequence. In that way, we can differentiate. So in summary, if we have a mass in the CP angle, you usually try to differentiate whether it is solid or cystic. If it is solid, then whether it is a schwannoma or meningioma, on the basis of this imaging finding, you can differentiate it. If it is cystic, again, two only differential, only arachnoid and epidermoid. If it is diffusion restriction, epidermoid is not, it doesn't show any diffusion restriction, it is arachnoid cyst, very easy. So coming to the petrous apex, is a lot of pathologies arising from the petrous apex. Out of this, most common are the cholesterol granuloma, mucocele, epidermoid, again, cholesteatoma or epidermoid, petrous apicitis, petrous apex osteomyelitis, and metastasis. So in cholesterol granuloma, you know, it is the most common tumor in petrous apex, almost more than 90%, and it classically occurs in pneumatized petrous apex. This cystic filled viscous brown fluid granulation tissue of cholesterol crystals, that's where they give you the hyperintensity on both and T1 and T2. Very classical on imaging. In CT is non-specific, you can get very well-defined or irregular lighting lesions in the apex. It's very non-specific. You do a MRI, you will get T1, this is the T1 weighted image, this is the T2 weighted images because CSF is bright here. So you will get both T1 and T2. The hyperintense signal is a very classical of cholesterol granuloma. It is the most common lesion in the Petrus apex. The same lesion, Petrus apex mucocele can present like that. But in Petrus apex mucocele, you won't get T1 hyperintensity. Here you have a hyperintense lesion in the both Petrus apices, but if you do the diffusion weighted image, there's nothing. There is no restriction. Could it be restricted diffusion? It could be a cholesteatoma, but there is no diffusion restriction here. No T1 brightness here, so it is a mucocele, nothing but a this one. So you can differentiate cholesterol granuloma, mucocele, and epidermoid cyst. Another important thing is you can see the very ill-defined lytic lesions in the Petrus apex. In MRI, you will see the ill-defined homogeneously enhancing soft tissue lesion in the appendage. Very non-specific, we can't say whether we are dealing to Petrus apicitis. Although Petrus is clinically, you can differentiate because of classical third nerve palsy and other things. But these two, Petrus apex osteomyelitis and metastasis, is very impossible to differentiate. If you present a very ill-defined palmatic kind of lytic lesions in the Petrus apex, very non-specific. So in that case, you need SP evaluation. Coming to the jugular foramen, you know, it is a part of the temporal bone. It has a, this is divided by this jugular foramen into parts nervosa medially and vascularis laterally by jugular foramen. This spine is very important. In case any tumor, any small tumor in the jugular fossa, the earliest sign of this tumor is the loss of the jugular spine, because with a thin bone, it can erode easily. So what are the common tumors in the jugular foramen? Again, the paraganglioma is the most common, followed by schwannoma and meningioma. Metastasis rarely occur, usually from the central skull base or posterior skull base, not primarily in the jugular fossa. So coming to the paraganglioma, you know paraganglioma is a benign tumor of the chemoreceptor cells. Usually, by seeing CT and MRI, you can definitely diagnose paragangliomas on imaging. In bone, in a CT, it gives you a permeative, multiple kind of erosion in the jugular foramen or adjacent bones. In MRI, it is very classical. It is salt and pepper appearance, and it's avidly enhancing. And they have a superlateral tendency to invade the medullary cavity. So if you see these 4 images here this green arrow here, you have seen this very lytic, very permeative, very ill-defined, multiple appearance of the lytic lesions in the region of the jugular foramen. If you do MRI, you will get this is T1, this is the post-contrast image, this is the T2. So in T1, you will get very tiny heterogeneous kind of tumor signal with tiny bright hyperintense areas. These are represent microhemorrhages, and this is called hyperintense SALT. This is SALT, basically. SALT, what is SALT? SALT is basically T1 hyperintense foci due to hemorrhage in the paraganglioma. Pepper means you will get this kind of high flow, because these are the very highly vascular tumor. You will get this hypervascular, hypointense linear and nodular serpentine structures. This is high flow blood vessels. This is called pepper. Whenever you see multipariance of the very ill-defined lytic lesions in the jugular foramen, along with flavoid, salt and pepper events, very classical of paragangliomas. No differential will come usually. Second tumor is this schwannoma. Again, it's like CP angle tumor. This is a heterogeneous kind of enhancement. You will get cystic changes, and the way of growing of this schwannoma is like scientifically expanding jugular foramens rather than erode the bone. It expands, it's remodeling of the bones, basically. So how will you differentiate from this paraganglioma? Because the most important part is the lack of permeative erosion. Second is the lack of flavoids. So if we get Flovoid, permeative erosion, paraganglioma you don't get, then either it is a schwannoma or meningioma. This tumor have a tendency to grow along the tumor. The growth factor along the nerves, basically. Here you can see there is a smooth expansion of the jugular foramen. In T2 weighted images, you will get this hyperintense lesion here. Post-contrast is a homogeneously enhancing tumor in the jugular foramen. And if you do coronal reformate, you will get this kind of oblong or elliptical shape because of growing tendency towards along the nerve sheath. So in that way, you can differentiate from the meningioma. Meningiomas are more centrifugal in growing nature. The meningioma again is arising from the arachnoid capsules. Bone is again in meningioma will get this kind of little bit of erosion, hyperestosis of the adjacent jugular foramen bone. And again, the contrast enhancement, the similarity almost enhancement is similar to the schwannomas. So you will see, and lack of this one, flovoid. So you will see the, basically, where it is growing. You see here you can see this jugular foramen, the jugular foramen, this is normal one here. Here there is some sclerosis, hypersclerosis, irregulars in the jugular foramen. If you see this post-contrast images, there is a hyperintense lesion is growing centrifugally all around the jugular foramen. So this is a classical of meningioma. Another example here, this is the jugular foramen here, erosion, then enhancing mass, displacing the ICA and IJV here, then it is growing like all anterior posterior, all directions, it grows all direction of this jugular foramen. It's a classical meningioma. So secondary, again, I'm telling you, secondary mass in jugular foramen is rare, usually coming from the basically central skull base. Here you can see the lytic lesion in the clivus, going into the jugular foramen here, involving the jugular foramen. So it's not an uncommon thing. So in summarize, if you're dealing with a tumor in the jugular foramen, we usually deal with the, either you are deal with the paraganglioma, meningioma, or schwannoma. By combination of these changes, as well as the enhancement pattern, and the vector of the spread of this tumor, you can definitely differentiate all three on imagings. Lastly, the most medial part of the lateral breast tumor is this here. You have a clivus here, is a pectocepac. This is the petroclival fissure, and this is the petrosphenoidal fissures. Because these spaces are usually cartilage. So cartilaginous tumor are more common in these areas, arising from this particular syndesmosis areas and growing laterally or medially. Sometimes chordoma in clival chordoma can grow into the lateral skull base invade the pectocepac also. So whenever you see a large hyperintense mass in this region of this petroclival fissure or petrosphenoidal fissure, going into this pectocepac, along with the ring and arc-like calcification, is a classical of chondrosarcoma. It's sometimes difficult to differentiate from the chordoma. Chordoma usually more central. Bulk of the mass in the central, then grows laterally. So if you don't see the ring and arc-like calcification with a heterogeneous mass like this, is difficult to diagnose. So a lot of differential will come like chordoma, plasmacytoma, metastasis, and other things. So it is required. So in summary, whenever you suspect a mass in the lateral skull base, in the either it is CP angle, jugular foramen, or pectocepac, CT and MRI are the investigation of choice, because combination of CT findings and MRI soft tissue findings, you can definitely narrow the differential diagnosis, or you can definitely diagnose some of the tumors on imaging. With this, I will end my presentation here. Thank you very much.
Thank you, Dr. Pratap Kakoti, for excellent presentation. So, if there is any questions.
Very good presentation. I wanted to know do you routinely do or advise arterial angiography or venography sequences during your assessment of these tumors?
Yes, basically, whenever I do a routine scan, suppose the tumor is very close to the sigmoid sinus, we usually do in venogram. And sometimes ICA aneurysm and other things present like the mass in the recipient. Well, usually we do angiography and venogram along with the normal sequences.
Because we do find that at times you might have some dominant sinuses on one end. And most of these tumors, we usually address the pathway through these sinuses, the sigmoid or the jugular bulb.
Yes.
So at times you might not consider surgery if it is either a dominant sinus or an absent sinus on the other side.
Yes. We usually do angiography. I prefer CT angiography rather than MRI because it's very easy. Because tiny vessels are difficult on MRI angiography to evaluate.
Thank you.
Thank you.
Thank you, Dr. Pratap. So we'll move to the next topic. We have Dr. Lopamudra Kakoti, the Associate Professor, Department of Pathology, Borooah Cancer Institute. She will speak on the pathology of lateral skull-based tumors. What is the surgeons must know? So, Lopa, you can start.
Good morning, everyone. At the outset, I'd like to express my thanks to Dr. Kaveri and her team for giving me the opportunity to present in this platform. I've been told that not to include much of pathology because pathology is really vast and it's very vivid. So when we talk about the temporal bone, it's like opening a Pandora's box because we don't know what is going to come and it keeps surprising us. And as like the anatomy, even diagnosis is sometimes challenging. So when we talk about since temporal bone lesions, lateral temporal bone lesions comprises both non-neoplastic, neoplastic. Majority of the time we see from the non-neoplastic pathology, but I'll myself confine into it to the oncologic part only. So temporal bone malignancy comprises 0.2% of all head and neck malignancies. You can understand the rarity of its incidences. Temporal bone is the host for both primitive and metastatic neoplasm, and they may arise from practically all parts of the temporal bone, and whatever it is, because of their location, they are basically locally aggressive, and they're locally aggressive because the numerous pathways the tumor gets, which they use to spread from site of their origin. And in case of temporal bone pathology, the new advancement is that till now, actually, we never had any standard guidelines for reporting for temporal bone tumors because of its rarity and its vividity. And another thing is, so it's sometimes very difficult to, even including AJCC or UICC, they don't have any assigned staging system for this type of tumors also. But recently, ICCR, that is International Collaboration of Cancer Reporting, which is an international platform collaborated by many of the international bodies, which have recommended some staging reporting pattern and minimal data set reporting. And more on that, a few developments in the molecular era is that we are able to identify few new entities molecularly defined. And right now it is only in the rare case-based report, but maybe included in the coming WHO because of their possibility to a new targeted treatment options. So AJ pathologies, what scares us when dealing with especially skull-based tumors is, one is diagnostic difficulties, because one is inadequacy of the biopsies and lack of expertise in the interpretation, because we never get to see in our residency tenureships. And another thing is, and it is very, very difficult to handle a three-dimensional specimen when we receive for gross reporting. And for that, we really need the surgeons' cooperations, operating surgeons' cooperations to define and identify the structures. And next is, the last and foremost is to keep a pace with the newer entities that has been described in this new era, molecular era. So the differential considered according to the site of their origin, and majority of the time, radiology itself is good enough to come up to a diagnosis, but these sites sometimes do surprises us with different kind of pathologies. And according to, like last speaker, Dr. Pratap Kakoti sir has mentioned many of such tumors, and they are in the external ear, auditory canal, majority of the epithelial tumors, and middle ears, generally benign tumors, and inner ears, they have some few indigenous, but they are also sites of lot of metastasis. In case of temporal bone tumors in children, we need to keep in our mind about the rhabdomyosarcoma, Langerhans cell histiocytosis, and vestibular schwannoma. If we see bilaterally, should be thought of about syndromic. So basically, in malignancy in temporal bone, we divide into epithelial or non-epithelial. Epithelials, when we see squamous differentiations, when we see adeno differentiation, or when we see any salivary gland morphology, we divide according to their morphology pattern. And non-epithelial, when we don't see any of this, either polydifferentiated carcinoma or small round cell tumor, if it is spindle cells, or if it is a bony lesions, or if it is a melanoma or any hematopoietic lesions. And 5th edition of WHO head and neck tumors has defined certain kinds of indigenous entities in respective sites. In external auditory canal, most commonly is the squamous cells, as we know. And other than that, something called ceruminous adenoma and carcinomas. Middle ear meningioma, middle ear papilloma, middle ear neuroendocrine tumors, squamous cell carcinomas, and adenocarcinomas. And inner ear, their endogenous entity is something called endolymphatic sac tumor and vestibular schwannoma. So squamous cell carcinoma, it's a very straightforward diagnosis based on their maturation pattern and the pleomorphism. We divide into well-differentiated, moderately differentiated, and poorly differentiated. Any biopsy we see, if we see squamous pulse and pleomorphism, we straight away give it as squamous cell carcinoma. But in case of, when we see it is a temporal bone tumor, we need to be cautious because squamous cell carcinoma can arise from external ear, external auditory canal, even middle ear. But there are certain differences from their pathogenesis to the staging system because external ear, which is a pinna, is a cutaneous lesion. So the staging, the pathogenesis is different, which is UV related, and the staging is completely different because it includes different AJCC system for cutaneous SCC or basal cell carcinoma, or any other melanoma categories. Whatever diagnosis has been come, it has to follow the cutaneous SCC of AJCC. And the very fact is that AJCC of squamous cell carcinoma includes certain high-risk factors. And what are those high-risk factors? And these are essential for determining the management decision and also for your prognostication and risk stratification. In case of external auditory canal, there squamous cell carcinoma is the most common and when it is localized, they show a better outcome than purely middle ear tumors. Whereas in pure middle ear squamous cell carcinoma is less common, and it is most of the time it is the involvement from the other sites like sinonasal tumors. And their predisposing factors are completely different, like long-standing history of chronic otitis media or radiation treatment for intracranial lesions. And for squamous cell carcinoma, AJCC is applied, whereas for external auditory and middle ear mucosal tumors, there is a newly suggested staging system by ICCR, which has been based on modified Pittsburgh staging system. So in cutaneous SCC, it is basically depends on the size of the tumor, that is less than 2 to 4 and more than 4, along with the high-risk features. When it is category T3, you need to look for the high-risk features. What are the high-risk features? PNI, then deep invasions and bony invasions. PNI here, it is not like usual type of PNI because whenever we see tumor enwrapping the nerves, we directly call it as PNI. But in skin, PNI is determined by their size, which is supposed to be more than 1 millimeter, or any named facial nerve or any named nerve, or it should be beneath the dermis. Whereas in the external ear canal, the tumor stage, T stage, is based on the extent of soft tissue invasion, where it is less than 5 millimeter soft tissue invasion, more than 5 millimeter invasion, and T4 is your adjacent structures. End stage for this, both tumors share the same, although they share the same, but prognostically it is different because cutaneous tumor, when it is T1 and N1, that defines a different prognosis, which is very, very bad. And in contrast to the mucosal SCC, where it is T1 with N1 is a so-so prognosis. Squamous cell carcinoma, they have different temporal bone subsite, exhibit different patterns of spread, like conchal and cartilaginous EAC invade soft tissue early and behave like a cutaneous malignancy, whereas osseous EAC spread through bone due to thin overlying skin, and middle ear tumors extensively involve temporal bone while sparing the EAC. And this prognosis vary according to the direction of the tumor. Better outcome is seen with the anterior soft tissue compared to spread medially or posteriorly or inferiorly, and because basic of the critical structures involved. And when we report the diagnostic challenges, inadequate biopsies, many times we get a initial biopsy gets like polypoidal fibrovascular tissue lined by dysplastic epithelium. We are not able to say that stromal invasion is not there, but radiology-wise it may be. So we used to give as a atypical squamous proliferation or atypical squamous tumor without invasion. But at the same thing, when specimen was grossed And we see this cohesive nest of tumor cells in a foci which might be invading your underlying soft tissue or bone. Now, another is benign mimics. When we discuss the differentials, there's something called benign mimics, which would be, we are scared of. One is for external ear, something called seborrheic keratosis or chondrodermatitis nodularis chronica, where you will have a necrosis of the cartilage and you show a pseudoepitheliomatous hyperplasia of the squamous epithelium with sometimes reactive atypia. Similarly, with middle ear, it is the cholesteatoma, which is a keratinizing squamous cell epithelium with debris inflammation. And sometimes cholesteatoma, as sir has showed, that it might be locally destructive, mimicking radiologically as tumor, but, imaging itself will sometimes give the specific result. MRI with DWI marked diffusion restriction favor cholesteatoma. Then recent entities, normally in the middle ear, we don't get to see the non-keratinizing squamous epithelium. If you see a non-keratinizing squamous epithelium, it is generally arising from the sinonasal tumor, which has been involving your middle ear, or it is metastatic from some other sites in the head and neck. But some new case reports new entities coming is already we know in the sinonasal tumor, it is a DECF2 fusion gene. The mention of this is why it is important is it has a very good response to PD-L1 inhibitors immunotherapies. That's why they're particular about this when it is seen, especially in the non-keratinizing tumors. Ceruminous gland tumors, again middle ear tumors, ceruminous glands are nothing but modified apocrine glands, and they're located in the dermis of the cartilaginous portion of external ear auditory canal. And they can be benign when it is circumscribed and malignant when they are infiltrative and show pleomorphism of atypia. But different morphological subtype has been seen in the ceruminous gland, whether they are whether they can show the morphology of pleomorphic adenoma, syringocyst adenoma papilliform of the other side. When we don't see any other specific defined morphology, then we call it as NOS type. Similarly, in the malignant cases, they might show the morphological features of adenoid cystic or mucoepidermoid carcinoma. And if we don't get to see any other defined morphologic patterns, then we call it as NOS. So in this micro photograph, you can see that there are single line gland where you are seeing here the cribriforming. This is a NOS type. Whatever it is, when it is a salivary gland duct morphology, it is always better to rule out primary in the salivary gland, especially the parotid. And for adenoid cystic carcinoma, we know that we have a dermal. We have a different patterns like this is the tubular pattern, cribriform pattern, and the solid pattern. And independent prognostic factor for adenoid cystic carcinoma is margin status, high mitotic activity, and solid areas. Before, it was considered that more than 30% is the solid, but now they've seen that if it is any component of the solid tumor is good enough to say it is a high-risk high-risk category. And one terminology is adenoid cystic carcinoma with high-grade transformation, when we see a lot of pleomorphism with poorly differentiated or anaplastic morphology that is also carry a high-risk features. And adenoid cystic carcinoma has a specific gene rearrangement, MOIB, with MOIB rearrangement, and different immunohistochemistries are there, especially the c-KIT. And I have not mentioned the IACs here. 5-year survival rate is 30% in the higher stage, whereas 85% in the stage 1. Mucoepidermoid carcinoma, similarly, you have low grade, intermediate grade, and high grade based on the epidermoid component and mucocytes, where high grade you have the maximum epidermoid component. They don't have a specific IAC markers, but we have a MAML2 gene rearrangement, and the survival rates varies according to the grade. So this is one of our case, 64-year-old female with noticed a lesion in the left pinna involving external auditory canal, preauricular region. with history of decreased hearing, and CT scan showing non-enhancing lesion bony in the bony part of the EAC with TM involvement, and morphology-wise, it is a BCC with infiltrative subtypes. Here, I would like to draw an attention when it is you give a site. Suppose it is a pinna involving, then we'll think of cutaneous, and if you say it is an external auditory canal, then we have to again think for it can it be adenoid cystic carcinoma, because both carries the different prognosis and also different treatment management. Middle ear tumors, most common pathology is inflammatory. Most common tumors are benign, as mentioned earlier, paraganglioma and schwannoma. And commonest malignancy is keratinizing squamous cell carcinoma, and now few case report of non-keratinizing, which has already mentioned. And in the middle ear, something called papillary cystic tumors are there. I'll be mentioning here in a short, which may represent a spectrum of distinct type from middle ear adenoma to endolymphatic sac tumor to aggressive middle ear adenocarcinoma. Then coming to the paraganglioma, as we all know that paraganglioma is a tumor derived, non-epithelial tumor derived from the paraganglion cells of the autonomic nervous systems. In head and neck, majority of the time it is called parasympathetic with different names, globus tympanicus or different names. But now WHO suggests only one terminology is paraganglioma. In the middle ear, it arises jugulotympanic, or it may be a carotid body. They present with their pulsatile tinnitus, hearing abnormalities, or sensation of oral fullness. The important is paraganglion cells, they express neuroendocrine markers, synaptophysin, chromogranin. There are other IACs also. I feel this is out of the scope of this presentation. And synaptophysin and chromogranin. In paraganglioma, you have, this is a chromogranin positive, and this is a S100 positive, which highlights the sustentacular cells. The important important point in this that whenever bilaterality is there or multifocality is there in the paraganglioma, it might indicate a syndromic tumors, so which is mostly seen in the SDH deficient tumor. So we need to be careful. Then middle ear neuroendocrine tumor is also common. Here, this is also neuroendocrine tumor. Paraganglioma also show neuroendocrine marker positivity. The difference is that this is a epithelial, so cytokeratin will be positive, and paraganglioma cytokeratin has to be negative. And neuroendocrine tumors are based on the morphology. They are divided into well-differentiated tumor and poorly differentiated. Poorly differentiated are termed as neuroendocrine carcinoma, whereas tumors are graded based on the presence of mitotic activity or Ki-67 index, which is less than 2 to 20, and more than 20 in grade 3. And grade 3 correlates with really aggressive behavior, where grade 1 and grade 2 surgical management is good enough. And schwannoma. Next is acoustic neurolemoma or schwannoma, which is a benign nerve sheath tumor. They show cellular and hypocellular and hypercellular areas with Antony A, which is referred to as Antony A and Antony B areas. And they arises from the differentiated Schwann cells of nerve bundles. Whenever we see multiple schwannomas bilaterality, again, we should think about syndromic association like neurofibromatosis type 2 or schwannomatosis. They have got lot of variants, but one is important is like ancient variant of schwannoma, because they might show some kind of nuclear pleomorphism, which might be mistaken for malignant nerve sheath tumor. So it's always be careful, but mitosis is never increased. Coming to the meningiomas, they arise either as a primary ectopic or as a secondary involvement. And exposure to ionizing radiation is established as an environmental risk factor for meningioma. WHO has graded meningioma into 3 grades. Grade 1 is completely benign, and there are 15 variants, 9 are benign. Grade 2, they have got increased likelihood of recurrence, and certain variants like atypical, chordoid, and clear cells are grade 2. And grade 3 is suggests that malignance with high metastatic potential, and certain subtypes are directly grade 3 when we mention anaplastic meningioma, papillary meningioma, or rhabdoid meningioma. Then coming to that middle ear papillary cystic tumor, which can be middle ear or involving the inner ear. They are generally low grade, locally aggressive tumor. one is endolymphatic sac tumor, another is middle ear aggressive papillary adenocarcinoma. Endolymphatic sac tumor, they are located in the endolymphatic. The name itself is vestibular aqueduct, and their association is seen with VHL syndrome. That's why we need to be careful. And in aggressive middle ear adenocarcinoma, they are not associated with VHL, but new mutation has been identified like EGFR and BRAF fusions, because they might have a, coming days, we might have a targeted therapy available for these entities. But these papillary cystic tumors, they look always same. Both are same. And only thing, endolymphatic sac, which is associated with VHL, they express carbonic anhydrase 9 and PAX8 ISC marker, which is not shown by middle ear adenocarcinomas. And before diagnosing a primary rare variant, always better to rule out the metastatic from kidney or thyroid. Then coming to the rhabdomyosarcoma, they are mostly seen in the children, although not so uncommon in the adult. 3 types generally has been described: ERMS, embryonal, alveolar, and spindle cell sclerosing type. And these are based on these are basically to stratify the outcomes. And IR, as the International Rhabdomyosarcoma Group system, has given a risk stratification staging system based on surgicopathological staging and fusion positive. So whenever RMS is coming, irrespective of any types, before initially it was like embryonal tumors are good, alveolars are bad, but now it is not confined only to the morphology, it is based on the fusion positive or negative. We see a PAX3, PAX5, FOXO1 fusion. When fusion is positive, it carries a worse prognosis. And now here I would like to draw an attention. There is something called new entity TFCP2 RMS, or rhabdomyosarcoma, which is a new entity described in the especially craniofacial bone of head and neck, because they have a very bad prognosis. They are high-grade RMS, and they involve, and another loophole in the diagnosis is that they show a epithelioid variant with CK and Desmin positivity. So most of the time may be missed with only bone involving maybe metastatic carcinoma where origin cannot be found.
Lopa, please summarize.
Yes, sir, almost done. So sometimes I would like to share another experiences which was thought as a glomus tumor in a 56-year-old female. Turned out to be a plasmacytoma, where on follow-up workup, M spike was seen. In our year, as we have told, it is almost same as endolymphatic is the most common associated with VHL tumors. And case 3 is like 11-year-old male presented with periauricular swelling with otorrhea, where CT scan showed multiple punched out lytic lesion over skull, and diagnosis was given as Langhans histiocytosis. And when we use grossing, we use a inking method, especially after inking, we give the sagittal sectioning, and after inking, we do sagittal sectioning and look for the tumor invasion. And ICCR data set has given core and non-core elements, which I have already described. Operative procedures is important. Specimen submitted, tumor site, histological tumor type, because all are related to prognosis. Here, core elements means which is essential for a pathology report to include. Non-core is, it is for a good clinical practice, where core and non-core includes margin status and ancillary studies, because margin status may not be always available. Majority of the time we might get in the piecemeal state of the specimen. So basically when we deal with the temporal bone, we need information exchange both from surgeons and the pathologists. And key take-home message is that ear and temporal bone pathology remain challenging. ICCR minimum data set has now uniformized standard reporting and staging system. Molecular discovery is still on hunt. Close crosstalks should be there between pathologists, surgeons, and radiologists. And specialist review is recommended for difficult or recurrent lesions. So, thank you.
Thank you, Lomabudra, for excellent presentations. So, to diagnose a skull-based tumor, teamwork is required for the head and neck surgeons and radiologists and pathologists. They should work as a team to come to a diagnosis. For difficult cases, morphology, apart from morphology, histopathology, then IHC, and sometimes molecular tests are required. So if there are any questions, its time is running out. So we'll move to the next topic. Yes, one.
I think the pathology is very important for us during surgery also.
Yes,
So like you said, we normally will remove it in a piecemeal manner. So early on, we used to send a lot of tissues, and finally, there would be a lot of confusion as to what is to be taken as a margin positive and what is to be taken as a margin negative, because these are very complex areas. So when you receive a specimen, like you said, you are doing an ink, it would be relevant for the surgeon to actually do the ink and send to you.
Yes, sir.
Because then towards that end, we would want to know whether we have left behind any disease or not. So I think that discussion, like you said rightly, is very important. And just sending the entire specimen to the pathologist is of less value rather than orienting that specimen.
Yes, sir.
Like it has been often said that there should be an unofficial marriage between the surgeon and the pathologist, because unless you discuss each and every case between the surgeon and the pathologist, you're likely to land up with problems, and like you mentioned about margins and other problems which creep up. So thank you, Dr. Lapamudra. So coming to the next presentation by Dr. Upasana Borooah, she'll be talking on beyond consent, ethical dilemmas in surgical resection. Dr. Upasana is a professor, Department of Gynecological Oncology at BBCI. She's also member secretary of the Institutional Ethics Committee of BBCI. So, Dr. Upasana, please.
Good morning, everyone. So this is a non-scientific topic. Otherwise, I believe we don't get credit points. So as surgeons, I'll try to finish on time. As surgeons, we all surgeons know that somehow every day we try to do some innovations in a minimal or just for the sake of finishing the surgery early or for the benefit of the patient, but we do innovations every day. So such type of innovations or major surgical breakthroughs have led to the discipline of skull-based or any surgery what we are practicing today. But we must understand that whenever the surgical it progresses before any proof, it comes at a profound human cost. And the consequences are not only clinical, but also ethical. How do you change it? Okay. So what is a surgical clinical trial? It is a clinical, it means a systematic study involving human participants, where the intervention is in the form of a new surgical technique or the timing of surgery or in the form of devices or any care strategies. So what is difference? It is similar because it's intervention, you need to register under Clinical Trial Register of India or CTRI. CDSCO approval is not mandatory. However, if you are using any sort of new devices, it is required. So what makes surgical trial unique? So there are four major differences which makes a difference from any drug trial or clinical trial. First is therefore irreversibility of surgery, operator dependency, innovation with formal or without formal oversight, and the risk of placebo and the control arms. So irreversibility of surgery is not a complication. It is basically it's the fundamental nature, and why it matters is because the decisions are permanent. Once a surgery is done, you cannot, the tissues which are removed, it cannot be put back. Nowadays, of course, we are talking of transplant and other things, but mostly it is undone. And not only it always affects the functional ability of the patient. For example, talking of head and neck, when you're doing a laryngectomy, the voice is lost forever, and the patient needs to retrain himself or herself how to communicate. hysterectomy done, the patient, the woman cannot bear children, and if the ovaries are also removed, she loses her hormonal functions as well. So these are the things we need to understand why surgery is different. So it is, as I've already said, it is not a complication, but it's the fundamental nature. The second thing which we need to understand is that as it is the irreversibility is the major factor. It needs, whenever we are doing a study, we need to give higher ethical justification, and the consent forms needs to mention the details of what you are doing to the patient, and the PI or the investigator needs to explain carefully so that the patient understands why he or she is participating. And the dictum, good old dictum, also holds true for such trials, is that good surgeons know how to operate, better when to operate, and the best when not to operate. So this also holds true whenever you are doing any surgical trial. The second is operator dependency. Like it is not only true for two different surgeons. As a surgeon, when you are doing a surgery, same for the same method of surgery, same the parameter, the same stage of surgery, the outcomes are different. You are operating on two patients today, the outcome is totally different. One patient comes out of the surgery absolutely fine with a minor surgery. The same patient, same group of patient may have complications which you cannot anticipate. Likewise, a patient can tolerate a very aggressive surgeries and come out without complication and sit the next, absolutely sit on, do all his activities next day, whereas a minor surgery can cause a lot of problems, as I said. So this also depends on the skill of the surgeon as well. So this is a factor where medicine meets human factor. For example, in clinical trial, you are giving a dose 500 milligram of paracetamol to two group of patients. They will have similar side effects, but not for the surgery, because it also depends on the technique and the experience of the surgeon. So it is not optional. It is what defines the margin between the complication and control. Next is innovation without formal oversight. In clinical trials, whenever a drug is introduced in the market, it goes through phases, phase 1, 2, 3, then you are introducing the drug, and then it comes in the market and everyone is using that. But it is not in the case of surgery. It often emerges without any proof. For example, whenever we talk of robotic surgery, I'm sure the first patient who had given consent for the transcontinental or transatlantic robotic surgery didn't know what he was going through or she was going through. Likewise, everyone, laparoscopy has come in, robot has come in. Feasibility is done first in the patient rather than the survivability or the safety. Safety in a limited amount. So this is what is different. And the classical case example is the case of laparoscopic cholecystectomy, which was, when was introduced, everybody wanted lap cholecystectomy because it was thought to be, not proven at that time, but it was thought to have equal benefit, survival benefit, but why people, patient or doctors propagated this, because they thought the time of surgery would be less, the pain and for cosmesis. But everyone knows that when it was first introduced, the rate of biliary leak strictures were very high, and this led to a lot of mortality and morbidity. It was only after a decade that it was established as a gold standard, when everyone, most of the surgeons all around the country and the world, they started to gain this, the expertise. So it took almost 12 years, as I have shown. Then comes the fourth challenge is the control group challenges. In medicine or any drug trial or in medical other studies, you can design your two groups. As far as matching the two groups, as far as age, gender, the comorbidities, so that you can reduce the bias. For surgery, it is not possible. And this, not only the PI needs to understand the ethical, whenever the such study is being passed by the institute or the ethical committee, they also need to understand that you can never have perfect control. But there has been designs which other way around, where which are called the shams group or the placebo surgeries, where the perfect group is designed, where the control participants, they undergo similar surgery, type of surgery, whereas where the actual organ or the technique is not being delivered, but just the incision part and the anesthesia part. So these are called the sham surgical trials. And we do have such surgical trials which have proven benefit. The classical example is the knee surgery, where it was proven that basically the study was designed in two groups. One group they did the actual knee surgery, and other group they just did the washing or the debridement of the knee. But it was found that the control group didn't have any differences. So there are other studies also. In 1950, we had the internal mammary artery ligation. This was done. One patient was done. Actually, it was done. Another, it was not done. But they had to undergo the similar anesthesia and all. But it didn't prove, was not proved to be effective. It was mostly likely due to the patients were not told what actually the benefit might be. And Parkinson disease, this was again another study where burr holes were made. One group actually received stem cell, another group didn't, but the patient had to undergo the procedure. So this is the modern the way of designing a perfect control group for the surgery. But this type of sham group or placebo group, when you're designing surgery, it is only acceptable when there is a equipoise. You don't know whether the surgery is actually benefiting or not, but it has to be under strict control. And the patient needs to understand that there will be the control group will have anesthesia incision, and they may not have any direct benefit. So it is very difficult when surgery is involved. So just lastly, so surgery is such a discipline where surgeons, we intentionally wound our patients, but we do so in the patient's best medical interest. And this is the brutal or the foundation of surgical integrity. So when surgery meets research, the stakes double. And so every incision demands not only expertise, but ethical clarity. So the question is not, can we operate, or it should be, should we operate? And consent is not just paperwork. And it is the skill whenever, because it's surgery and the skill is very important. It is not just a variable, it is a constant. It's a constant, like the drug, it's a constant which will define the outcome. So ladies and gentlemen, we have often seen that it is not, studies have not failed because the patients have not given consent. Most of the studies have failed, or historically we have seen we have failed our participants or our patients because the researchers fail to the patients the amount of the belief the patient had put on the researchers, the same amount of protection was not delivered to them. So do no harm doesn't begin in the operating room. It begins with how the research is designed. Thank you, everyone.
Thank you, Dr. Upasana. I think this brings forward this timeless problem or the conundrum which we are always facing. Primum non nocere, yeah, that is very important. And yeah, these trials and the sham surgery or the placebo effect which procedures or medicines have on the psyche and the ultimate outcome of a treatment, whether it is surgical, non-surgical, or whatever. So, if there are any questions, thoughts on this presentation before we close this session?
You mentioned one about transatlantic, that robotic surgery. Actually, many questions asked by the patient. What is this? Is operating from Delhi, patient is in Guwahati. Actually, how the ethical consent is taken on these cases? People, they do not know. Even I also do not know, but I've seen that they're doing surgery, particularly in general surgeon, the robotic surgeon, they do. How the ethical consent is done on these cases, or how the counseling is done?
Ethical consent will come when we undertake as research. Actually, unfortunately, that comes in the last phase. like I said, first the technique is introduced into the general population, and then for surgical trials, what I'm saying, and then we design our study. Most of the time, it happens. It is also for laparoscopy. It is also for robotics. So surgery is such a discipline. It is actually like I've said, it is the fundamental nature. We cannot change it, and we need to understand the limitations. Of course, patient needs to be made to understand that doctor is operating for the first time. This is the first time of surgery. Before he had done only in AI models or in this thing. Still, the patient gives consent. I think the patient very well understands. And we should always give thanks to those participants or patients actually who has contributed to the science more than the doctor or the surgeon.
Yeah.
Another surgeon must have must. Any questions of the 4 topics? Otherwise, we'll conclude the session. Pratap Kakoti, what is it? Cone beam CT is utilized, it is lateral
Thank you.
skull base. CBCT, I have not told anything, but I've seen in all articles, CBCT is coming.
Yes, definitely some cases it has a role because it gives you a better detailed anatomy of the bone as well as the soft tissues. Now it's a new rule of CBT is coming, but it's not established right now. So it's now very difficult to tell the established rule of this CBCT.
So here we also have the same conundrum as Dr. Upasana mentioned. So we have to A1. Yeah.
Cone beam CTs are mostly done by dentists also
Yes.
for the evaluation, extraction. And all.
In very limited areas, because the cone beam will concentrate in a particular area only, from my understanding, because we don't do any cone beam. I don't know whether.
The whole of the bone can be seen also in very minutely. What is the erosion? What is the height of the bone? What are there will be any difficulty of the extraction of tooth? Because I have seen practically few cities of cone beam CT.
Uh-huh.
Yeah.
So, thank you for this fruitful session. We'd like to close this session. Thank you.
Thank you all to our distinguished speakers for their valuable remark. Now I will request all the speakers, Dr. Diksha Sharma ma'am, Dr. Pratap Kakoti sir, Dr. Lopamudra ma'am, Dr. Upasana ma'am to come on the stage for a group picture, and then we will proceed for tea for 10 minutes. The chairperson stand.
A very good morning to everyone present here. At the very outset, I would like to thank the institution where I have learnt everything, BBCI, for inviting me for this and giving me this opportunity. So, as we have seen in the previous whole session was that we are dealing with an area that has a critical and a complex anatomy. Radiology is challenging and the pathology is diverse. So at times it may be notoriously complex to adequately work up these malignancies. So, and also there is an overlap with the infective component as well. So over the next few minutes, let's try to cut down this diagnostic noise and develop a stepwise decision-making approach towards temporal bone malignancies. So as we have seen, these are rare group of tumors which are in close proximity to various critical structures. And not only the surgical resection has to be meticulously planned, but also what we needed to take into account is the functional aspects of these tumors, especially with the hearing and the vestibular system. So the aim of the workup is not only to reach a diagnosis, but also to make a plan which we can execute subsequently. So a thorough evaluation of these tumors, as I said, is of paramount importance. Many a times these patients may have been treated as a chronic suppurative otitis media because of the overlapping symptoms. So it's important that we pick these tumors up while they are early and treat them. Also, at times the histology may be very diverse and different histologies at times will require a completely different management. The surgical axis is very important because these are close to very critical structures. So our surgical planning our evaluation should also reflect the surgical planning. At the end, we should have enough of information from our workup so as to enable a multimodality treatment planning and assessment. So if we look at what would constitute a workup in these cases, first we begin with the clinical evaluation, which is the history taking and the examination, followed by investigations where we will have a radiological aspect, tissue diagnosis, and also the vascular studies and the functional studies. Then we would go about in staging these tumors, at the end reach a decision and then plan a final management which will be discussed in the upcoming lectures. So if we come to the symptomatology, these are tumors that may usually the SCC, the squamous cell carcinoma, will present at around 6 to 7 decades, most commonly in the males. Etiology may be related to a long-standing CSOM or a prior radiation exposure. So again, many of the, as I mentioned before, there might be an overlap with the infective etiologies as well, because the symptoms would still be otalgia, otorrhea, hearing loss, and so on. Sometimes a vascular lesions like a paraganglioma, like a glomus, may have pulsatile tinnitus, and advanced diseases will have symptoms like facial palsy, rotatory giddiness, nodal disease, and so on. Also, what we need to understand is literature has shown that many a times, because there is a diagnostic delay of an average of around 13 months. So at the end, the patient might come to us when the patient is not resectable. So coming back to the symptomatology, apart from these, there might be some symptomatologies that are peculiar to certain diseases. For example, if it's a glomus tumor, usually the head and neck paragangliomas are not secretory, but around 5 to 10% may have a secretory component, and that may be reflected in the form of diarrhea, palpitations, and so on. There may be severe otalgia if there is perineural invasion, especially in adenoid cystic carcinomas, and facial nerve tumors, if any, may have facial palsy as the initial complaint. So if we see the anatomical correlation here, so to understand the symptomatology and the examination, let's just go back into the anatomy. So what we can see is this: if the tumor is suppose an external auditory canal tumor, it might go medially so as to involve the middle ear, it may involve the inner ear and produce hearing complaints, it may produce giddiness, it may also involve the facial nerve there, it may go superiorly, and once it goes superiorly, it can cross the dura and have intracranial complaints. Then similarly, anteriorly, there are these fissures of Santorini, which it can cross and cause a parotid mass. And also there can be metastasis either to the cervical lymph nodes or to the distant sites as well. So on clinical examination, what do we see? A thorough ear, nose, and throat examination. So the ear examination, if it's a most common presenting symptoms in these patients, may be an external auditory canal mass. So we have to look at the morphology, pulsations, whether it bleeds on touch. If it's a non-bleeding mass, we can probe and see from which direction it is growing. We have to examine the pinna, the preauricular region, so as to get an idea of the temporomandibular joint. if there is parotid enlargement, post-auricular involvement, or neck nodal metastasis. So this is one of the videos of one of our patients this was a case of a glomus. So here we can see that there's a pulsatile mass just behind the external auditory canal. Sorry, behind the tympanic membrane. So again, continuing to the clinical examination, we also need to gather information regarding the hearing and the vestibular system. Cranial nerve examination is extremely important, particularly the facial nerve and the trigeminal nerves, and also the neck nodal examination. So as we can see here, the first image here is of a patient with a post-auricular tumor, which turned out to be an SCC. This is another patient who had a external auditory canal tumor, external auditory canal squamous cell carcinoma, which went on to involve the facial nerve. So now coming into the dilemma of inflammatory or malignancy. As I told that sometimes the symptoms are so overlapping that we may miss on malignancy that is there underneath. And there is often no clear-cut answer to what it is unless there is a biopsy. So one of the things that is followed here is if the patient is having some sort of granulation tissue or some exophytic component that is not responding over a large period of time, particularly in elderly patients, we may consider biopsy. And also if there are early or out of proportion signs like hearing loss and facial nerve deficit or a neck node or a trismus or a parotid swelling, we should keep the possibility of a malignancy with us. So now, after we have done a thorough history taking and examination, the next thing that we would come to is the array of our diagnostic investigation. So the diagnostic investigation will begin with the radiology, followed by tissue diagnosis. Depending on the tissue diagnosis, we need to look at what is the metastatic potential, and based on that, we will have a metastatic workup. We need to look at the functional deficit, and also, as we have discussed in the anatomy lecture, that the tumors may be in close proximity to various blood vessels, important blood vessels, so we need to have a vascular profiling for these patients. Certain histology-specific investigations may also exist, like for example, for a paraganglioma, we would want to rule out a secretory component. Also, not to forget, for all our patients who are undergoing surgery, we need to look at their fitness, we need to look at their performance status, nutrition, and comorbidities. So going further, before I go into the radiology and the pathology aspect, let's just have a brief overview on how the tumor can spread. So as we can see, a tumor from the external auditory canal here can spread medially, so as to involve the middle ear and then go into involving the otic capsule. Superiorly can go and involve the intracranial, the dura and the intracranial component. Anteroinferiorly can go through the fissures of Santorini and involve the parotid nerve, and can go laterally and involve the post-auricular region, the Simba concha, and so on. So radiological investigation, the first investigation of choice that this patient may have had, whether it's an infective or a malignancy, is an HRCT. But usually when we are looking at tumors, we would want the contrast here. We would want to cover the neck as well. We would want the thin cuts, to look at the soft tissue window as well as the bony window. We need to look at bone erosion, extent, and staging. Now the HRCT provides us an excellent delineation of bony landmarks, the status of the middle ear, the mastoid, and delineation of the jugular and the carotid. So as we can see here, this is a tumor that is in the external auditory canal, which is going into just falling short of the tympanic membrane. The ossicles are intact. So again, in this, we can see that there's a tumor in the external auditory canal that has gone into the middle ear. We can see the bony definitions very well. There is some amount of bone erosion here. The patient had a facial palsy. So now, what are the things that we need to look at? What is the check? Do we have a checklist? So even though we don't have a predefined checklist, these are all the things that you need to look into when we are considering a radiological evaluation for a temporal bone tumor. One would be the primary tumor characteristics, ranging from primary site, what is the dimensions, whether the EAC, the external auditory canal, is involved, what are the local extension of the disease, the middle ear and the mastoid component, the bony landmarks, the destruction, perineural spread, the status of the foraminas, inner ear, and the skull base involvement, and yes, definitely lymph nodes, and for certain histologies, we need to look at the metastatic potential. So HRCT may not be enough. Why? Because there are certain pitfalls. For example, we may not be able to distinguish between the middle ear fluid versus the tumor itself. The soft tissue delineation is better with MRI. The dural abutment and invasion is better differentiated with an MRI. Perineural invasion, again, is better done with an MRI. So HRCT at times may lead to underestimation and overestimation of the disease. So now coming to the role of the magnetic resonance imaging. So this is often complementary, especially in advanced cases where the middle ear is involved. So this will help us in distinguishing between the entrapped fluid and the malignancy depending on the behavior in the T2 sections. Also, it will give us a better idea about the soft tissue extent, the infratemporal fossa involvement, the perineural invasion, the dural and the brain involvement, and also the vascular involvement. So this is one of our patients, as I had shown the image before. This is of the same patient. We can see that there is a mass that is originating in the mastoid region and then going on to involve the bone and probably the middle ear. So this is how the image is looking on the MRI. We can see that the soft tissue delineation here is much better. We can see that the disease is extending to the middle ear. And on further cuts of the MRI, we can see that how the tumor is not extending intracranially. So again, this is how MRI and the CT may help complementing each other. And also based on the appearance of the disease in the particular sequences of the MRI, combined with the behavior on the CT, we may be able to reach a differential diagnosis in many of these cases. So now coming to vascular mapping, we have seen that these tumors may be in close proximity to very critical vascular systems, for example, the internal carotid artery or the sigmoid sinus. So in that, we may have to map the internal carotid artery to see if there is any encasement. Also, at times we may consider doing a MR venogram to see the status of a dominant sinus or an absent sinus on the other side. That may have some implications on the surgical planning as well. And also 4-vessel angiogram, and if indicated, a balloon occlusion test may be needed. So in 4 vessels angiogram, we need to look at the arterial face as well as the venous face. In arterial face, we would look at the internal carotid artery contour irregularity, the stenosis, and if a balloon occlusion is necessary. Similarly, for the venous face, we need to look at the collateral venous drainage, the sigmoid sinus, the status, the dominance or the absence. Now, depending on what the histology is, it may warrant a workup for the distant metastasis. Now, these are the guidelines from the UK which have just for an example, they have shown that if it is squamous cell carcinoma, we need to rule out any metastasis in the thorax. And also for melanoma and high-grade sarcomas, we may have to consider a PET CT to rule out distant metastasis. So now coming to the pathological aspect, the tissue diagnosis, as we have seen previously in the morning, that there are a wide arrays of histologies that may be present. And this may range from squamous cell carcinoma, adenocarcinoma, or some rarer tumors also. So when we are considering this, first, again, the image should guide us about the biopsy. If it's a completely vascular mass, we are having features of paraganglioma, very definite on MRI. We may not consider a biopsy in these patients because of the expected bleeding. And also we need to evaluate whether the procedure has to be done under the microscope or not, or whether we are going to do it at an outpatient department or an inpatient department. IHCs, as discussed in the morning, may have role particularly for when we are in a diagnostic dilemma. Now, talking about HPV, there have been case reports that have discussed, but we do not have any prognostic implication like oropharynx for temporal bone malignancies. The use of immunotherapy is coming up everywhere. So there have been some reports about using immunotherapy in temporal bone squamous cell carcinoma, but again, these are very small case series, so that is not come into practice. Again, coming back to the functional attributes of it, vestibular and auditory evaluation is very important. Patient has to be counseled. Sometimes the surgery itself may lead to a complete conductive hearing loss, so that has to be told to the patient. We need to have a baseline audiogram for medical legal purposes as well. If the patient is already having some baseline dysfunction, we need to see the status of the inner ear. It's extremely important. Probably it is an advanced case. Other histologies may require other specific investigations. For example, paragangliomas may require a workup for the secretory component. Neuroendocrine tumor, this is one of I'm showing the SSTR imaging of one of our neuroendocrine tumors, and it has shown that multiple neuroendocrine tumors were there. And PET CT may be needed in high-grade tumors as well. After this, we need to stage the patient. Now, that would depend on what histology it is. We have the FISH staging, we have the Jackson, the Jackson staging for the glomus. Similarly, for temporal bone carcinomas, we have the staging by the Pittsburgh group, which was further modified. Even though we do have so many systems in place, all these systems have some or the other pitfall. Now, for the modified Pittsburgh staging, the issues are that it is applicable more for external aortic canal cancers. And sometimes the involvement of anterior soft tissue involvement and the facial nerve, which is just stage 4, may not be prognostically as bad to consider it as stage 4. Now we also need to understand which are the tumors which are not resectable and not worthy of resecting after all our investigation. That would be the involvement of the, say, inner ear, gross brain involvement, dural nodularity, cavernous sinus involvement, metastatic disease, carotid artery complete encasement, paraspinal muscle involvement. So based on all this, we have now, after all this, we have the data of what is the histology, what is the extent, and then after taking into consideration the patient's health, the patient's fitness, we need to come to a stepwise decision making. So if we are planning for a curative intent, we need to again review all our investigations, see whether the patient is a fit candidate for surgery. If yes, then what is the surgery that we are going to do? And if it is a GC is poor, or patient is having has metastatic disease, patient may be considered for palliative treatment. So to sum it up, the stepwise decision making in terms of the treatment planning comes from evaluation itself. So we look at the performance status, we look at the fitness of our patients, the nutrition, then we want to see what is the extent of the disease, what is the possible histology that the patient might be harboring. If a metastatic workup is required, what is the extent of the workup? Then we decide whether the patient is having an unresectable disease or maybe a disease that is not worthy of resecting. If we are considering for surgery, now our investigation should aid us in planning what is the extent of surgery, and the decision may be influenced at multiple levels depending on various things like whether the parotid is involved, neck node, facial nerve, intracranial extension, what will be our mode of reconstruction, and so on. So with this, I would like to end the talk, and these are my acknowledgements. Thank you.
Thank you, Dr. Siddharth. I think we can take one or two questions. Yes.
Hi, I'm Dr. Govi. Nice talk, Dr. Siddharth. I have just two questions. So you said for PNI, MRI is better investigation of choice, and you will base your surgery decision based on that. So how can we be sure that the PNS, actually it's not PNI, in radial it's PNS, so is actually edema or disease, and what is the role of EMG or NMG in a case of temporal bone tumor?
So in this, I think most of the cases that we are dealing here with is the malignancy. Now, maybe we will not be able to always definitely say maybe the pathology is the better discriminator, but if we have a frank idea that there is extensive perineural spread, we might need to reconsider the decision, and this is where the MRI will help.
Will the clinical examination of patient of function be enough, or we need an EMG or NMG for the purpose of sacrificing or preserving the nerve? In case of any temporal bone tumor, will it depend upon the histology of the tumor itself? So how do we proceed if I have a HB2 with a perfect NMG? So how will we do? And if I have HB2 palsy with a weak NMG, how will we proceed in that patient? And one is adenocarcinoma, one is SSC. How do we do about that?
So in this, we need to see whether what is the grade of the malignancy. If it's a very high grade, if the malignancy is not radiosensitive, patient already has a preoperative palsy, we would consider resecting the nerve. Otherwise, the decision has to be made in taking into the patient into the account, patient's decision.
Okay. I think, thank you. Thank you, Dr. Siddharth. May I invite Dr. Brian to present his talk?
First of all, I'd like to thank the organizer for giving me this time. So the topic given to me is surgical approaches to temporal bone and lateral skull-based tumors. I think the topic is really very vast, and so I've divided into three sections. First is the surgical approaches to the temporal bone and ITF, that is infratemporal fossa. Second is surgical approaches to angiopharma with massive intracranial extension. And third is surgical approaches to CP angle area. temple bone resection. Basically, there are three types here: lateral temple bone resection and subtotal temple bone resection and total temple bone resection. But exactly what we are doing is in between the subtotal and total temple bone resection, actually what we do is near total temple bone resection, though this is not mentioned much in the textbook. Coming to the lateral temple bone resection, we perform this one when the tumor lies lateral to the tympanic membrane. See, what we do here is we do a cortical mastocytomy, then we go anteriorly or superior anteriorly delineating the middle cranial fossa, of course saving all the bone around the ear canal. Then we go to the capsule of the TM joint. And inferiorly, we go to we expose the styloid process, and then of course saving the facial nerve. And the specimen is, we get a specimen like this. So this is the Rossetti form specimen of the lateral temporal bone resection. Next is the near total temporal bone resection. This is performed when the tumor lies medial to the tympanic membrane. First thing we do here is we control the great vessel of the neck, and after the gross tumor resection, we go for the basically near total temporal bone resection is a kind of, see, M block is not possible, unlike the lateral temporal bone resection. M block is not possible. So basically more is of a piecemeal. Final stage is really a piecemeal here. So what we do here is frozen section become a mass here. This is a small video here. We delineate, once we do the gross tumor resection, we delineate of course we drill out the librans, and then we delineate the jugular bulb, and then internal carotid also. Sometimes we try to save the facial nerve. Sometimes we try to save facial nerve. Of course, we have to still drill the librans inner ear. These are all based on my R cases I'm just presenting because topic is really very vast. Now sometimes we get a cancer of the parotid going to the ear, especially external ear canal. There we go for en bloc resection. That is parotid temporal resection. We go for the radical parotid resection plus lateral temporal resection, including facial nerve, as in this case. We have removed this patient went en bloc resection, including the radical parotid, then lateral temporal resection, as well as the facial nerve have been sacrificed in this case. Now approaches to the ITF, that is infratemporal fossa for glomus tumor. See, and I would like to say Professor Sharma will do REC, then we have been exposed to this kind of surgery, but this kind of case now is coming very less to, in a year we operate 1 or 2 cases only, so not much experience in this regard. Now it's coming down. So these are our cases. So this approach to the infratemporal fossa approach for glomus tumor, first thing we do is we do cul-de-sac closure of the ear. Then after that, we can expose the neck for the great vessels. Then facial nerve is mobilized and translocate anteriorly. After that, we delineate the internal carotid artery and jugular bulb is exposed. This is fish type A. The infratemporal fossa approach, this is type A. Basically, the key to the surgery is the tympanic bone. We need to really go to the dissection hall. Then we need to really do a kind of cadaveric dissection, drilling the tympanic bone. When we are well versed with tympanic bone, surgery is not that difficult, but we really need to understand the anatomy of the tympanic bone. The tympanic bone is the key to the infratemporal ITF approaches, especially fish type A. And depending upon the tumor extent, there are type A, type B, and type C ITF approaches. So the type A basically glomus, and type B comes to petrous apex, and type C to the nasopharynx and to the paraclavial region. We do, as a ENT head and neck surgeon, we are basically restricted to type A only here. Now, another, this is angiofibrosis as a head and neck surgeon, time to time, and as a ENT surgeon also, time to time we are going to come across angiofibroma with, this is a case of angiofibroma with massive intracranial extension. So we can see at the scan, the tumor is going to the middle cranial fossa, pushing the temporal lobe far behind. So this is a massive intracranial extension. The patient underwent pre-auricular subtemporal approach. This is Alos's favorite approach, so pick up on him. So this here is a very good approach for angiopharma with massive intracranial extension. Endoscopy really, who are very good in endoscopy, they can do anything, but this kind of massive intracranial extension, I think we should not, endoscopy, I think is not possible. So, and this is straightforward. So we drilled the greater vein of sphenoid and the squamous part of temporal bone. When they have done there, we are into the temporal lobe and into the middle cranial fossa, right into the middle cranial fossa. So the key surgery to this is the greater vein of sphenoid. When the greater vein of sphenoid is drilled, we are right into the middle cranial fossa. It's not basically look very difficult, but once you remove the zygoma and the lateral wall of the orbit, it really is open booted. So this is our own case that we can see the sphenoid is the medial part, sphenoid is the left side, and we can see temporal lobe with all the tumor being aside from the middle cranial fossa. Now coming to the third section, that is, see my topic has been approached to lateral skull base, really it's very big. So now coming to the third part, that is CP angle area. This is really a very difficult area, and so some people say in no man's area. But these are difficult in a sense, all the critical structures are here, and we really need to plan very well for this kind of CP angles area, especially tumor involved in CP area. Otherwise, there can be a lot of complication. 5 ml in the CP angle area can lead to a lot of problems. It can lead to stroke of the patient also. So this is really a very critical area. So what are the approaches to CP angle area? See, there are many approaches, like one is retrosigmoid approach. This is a really a time-honored, very good neurosurgical approach. This is really a very fast, and this is really a time-honored approach. And the second is the translabyrinthine approach, and this is approach where we othologists are doing. And the middle cranial fossa approach is a fossa approach is basically for small tumor, and it is not well picked up in a sense. It is feasible only for a small tumor. And secondly, we have to bypass the fascia nerve to reach. And I think neurosurgeons, so they are not very, I think they prefer more retrosigmoid. And middle cranial fossa really for a very small tumor only head. So how do we choose when a CP angle tumor comes? Especially vestibular patient comes, because vestibular patient mostly they come to the ENT people first. In fact, the topic is mandatory. Even one class is dedicated to vestibular for MBBS class also. So then the first thing they come to us is to the ENT surgeon. We come across this patient. Most of the patient will come to ENT first. So how do we choose which approach? So there is all the approach are good. Retrosigmoid, translabyrinthine, I think both of them are equally good. The most important, I think, the surgeon-given approach. Surgeon expertise is, I think, the key. If someone is comfortable with retrosigmoid, I think he should stick up to that. And with someone, if the ENT or othologist or skull-based surgeon are doing good job in laboratory, you should continue to do. You should do. So, but of course, we need to remember the goal of the operation. So as I said, retrosigmoid is a hearing preservation. So if the patient comes with normal hearing, we should never do translabyrinth. That is, we as a ENT, we have to, our field is hearing, so we should really preserve the hearing. So that is in fact, our duty to preserve the hearing. So, but if the patient comes with loss of hearing, then of course we can go for translabyrinthine. The reason translabyrinthine is we don't have to retract the cerebellum. So there is one advantage we have got. Now we'll come to some cases. This is our own case, giant acoustic neuroma. So then, see, this is really a classical case for retrosigmoid. That is no doubt. And retrosigmoid is really very fast and very, very time-honored approach. What about translabyrinthine? This patient is our own patient. See, translabyrinthine approach also is a very good approach. And I should say, our neurosurgeons are sitting here. I'm really, I came across some of the best neurosurgeons in our previous institute, even here also in AIMS Guwahati also. I'm really indebted to them for earlier when we started. See, the backup for this approach is a neurosurgeon. We need a backup neurosurgeon. So really, I would like to thank my previous institute neurosurgeon, even here in AIMS on neurosurgeon. So if you do a good bony walk, if you can delineate the bone very well, bony walk is well done, then translabyrinthine can also give a very good approach to the equestrian neuroma. See, it can give a head-on approach. We can see here, it can remove the bone very well. It can give a head-on to the tumors. This is the patient who underwent translabyrinthine approach. And then we can see a total tumor totally removed and with normal facial nerve. Of course, translabyrinthine, one advantage in translabyrinthine approach, one big advantage is the facial nerve can be seen early in the surgery and facial nerve can be followed throughout the surgery. This is one advantage. So this is another case of large giant equestrian neuroma operated this week. So then this also underwent a translabyrinthine approach. We planned a translabyrinthine approach. And this was, see, the translabyrinthine approach, some of the, who are undertaking this surgery, one of the key message is, see, the skin incision had to be really liberal. Early in the career, our skin incision are very limited. So the flap come into the surgical field. So we really need to be very liberal in our skin incision. Then, the second point is we have to really delineate the jugular bulb very well. The jugular bulb has to be really delineated very well. Otherwise, the medial deep part of the tumor will never be able to assess it. And that is the most difficult tumor part. And thirdly, the sinusoidal area need to be well delineated. Otherwise, the posterior part of the tumor will be very difficult to assess it. So this is some of the key steps when you are exposing. This is a small video showing how we drill delineating the jugular bulb. And one of the good drill is Escalab is a very good drill here. Escalab is, I think, the drill of choice for this kind of surgery. We are using Escalab drill. We did this video we did it. The patient is fine now. So little bleeding there. And this is intratumor removal. Intratumor removal time taking here. Don't be in a hurry. Use bipolar with a silver coated. And take a lot of it. Don't be in a hurry. And one good thing is you can use a Merosil. Dissect the tumor and the brain, and then put a Merosil in between. Merosil will do the dissection work. Merosil, which we use for nasal packing. It will swell and it will dissect also, Merosil. So this is the post-operative picture. Total tumor being removed. We just did the CT scan 3 days ago. See, we did a very big bony wall. We can see a big bone has been drilled. Now coming to the petoclavial meningioma. This is basically a neurosurgery topic. If I just bring it out, this is a neuro. So we see here, see this kind of patients, petoclavial meningioma. Tumor is going too anteriorly and too medially. How will you go about? This patient underwent with a neurosurgeon. Basically, this is a neurosurgeon patient. Tata, we did together. Retrosigmoid translabyrinthine approach we did. But post-surgery, there's a very big, very significant tumor has been left behind. We can see here. So what will you do with this? What are the other options available to us? Let's see. See, otology combined approaches are there. Translabyrinthine, transotic approach is one there, and translabyrinthine, transcochlear approach, one also is there. Let's see how can they fit into this kind of tumor. See, translabyrinthine, transotic approach is a very good approach, especially for the equestrian neuroma with anterior apical extension. But we can see the problem here. The facial nerve is coming into the facial nerve is coming into the petrous apex. It will not allow us to drill the whole petrous apex. And secondly, we can see the intercarotid and facial nerve. There is a very narrow space to drill here. So then if you drill this area, we are invariably going to injure the facial nerve. So what is the next step? What are the other approach pathological available? See, the problem here is if you the labyrinthine transnasal approach, you see, we are not able to drill the anterior part of the bone or of the petrous apex. So then the tumor of the anterior medial part is going to be left behind. So what about if facial nerve is mobilized and translocate posteriorly? And that is translabyrinthine transcochlear approach. If the facial nerve is mobilized and translocate posteriorly, what will that approach is not a translabyrinthine transcochlear approach. So how will it give? See, we get a very good feel here. We can comfortably drill the cochlea. We can very comfortably drill the petrous apex. Once these two are drilled, see, we get head-on to the tumor of petroclavial meningioma also. So these are the few, my time is over, so these are the few slides here. Thank you for your patient listening. It's a very big topic here, so I don't know how to share. So based on our own case, I've shared.
It's okay, Dr. Brand. It was brilliant. Thank you for a very big practical talk. We can take some questions. I think Dr. Prathamesh would like to add something. Yes.
Ryan, that's a very fantastic, exposition of the entire lateral skull base that you have shown, and I must compliment you on the extent of the surgeries that you are performing. The access that you have shown is not something that most of us would do, and combined with neurosurgical aspect, I think your tumor clearances are very good.
Yes, sir.
What we have realized over time is that the posterior C-shaped incision, which accesses the temporal fossa, the mastoid, and the neck, gives us a very good access for the entire area that we would want.
Yes, sir.
And also gives you the ability to use the musculoperiosteal flaps for reconstruction. So rather than just take a C-shaped incision, if we can modify it to encompass the entire this entire area, it gives you access for the entire surgeries as we proceed. The facial nerve preservation is feasible, and I think you're shown how you are able to preserve the facial nerve even in a glomus surgery. I think that's commendable. Thank you.
Thank you. So you are the master of skull base. So actually, you mean to say the skin you had to take a bigger flap posteriorly? The skin incision had to be a bigger flap, you mean to say, sir? Or broader flap, okay. Also, this I think recommended by neurosurgeons. So in case they want to go for retrosigmoid, I think that feasibility we should, yes, sir. Thank you.
Thank you, Dr. Brand, and that was a very brilliant talk, and also very exhaustive on your part, probably. The next talk is probably online by Dr. Deepa Nair, Principles of Surgery in Temporal Bone Malignancy.
Good morning, everyone. Dr. Deepa is with us online. So after the presentation, should be available for questions. Thank you, ma'am. Can you hear us, ma'am?
Yes, I can hear you.
Yeah, ma'am. So any questions or comments from the audience? Madam is there to respond.
First of all, I would like to thank Kaveri, Dr. Shubhas, and the whole team at BBCI for inviting me. And I really apologize. I wanted to be here, but due to some personal issues, I could not make myself reach there. I think the video could not be heard by the online participants, but if there are any questions, I'm happy to take them.
Presented.
Can you hear Dr. Pai's comments?
No, I could not.
Very well presented. Can you hear?
Thank you. Yes, sir. Thank you, sir.
Yeah. So can you just clarify which are the cases you would consider for doing a modified resection? And is it always preferential to save the facial, or the facial is not part of that modified resection?
So, as I mentioned, I'm not sure whether it came out clearly, but most of the diseases, what we have seen in our experience, are diseases which are involved in the external aortic canal, and somehow they erode from the floor or the anterior wall and extend anteriorly to involve the parotid tissue in the infratemporal fossa, or involve the hypotympanon and go towards the stylomastoid foramen. Now, when you plan an oblong resection in these cases, this is the site where the osteotomy sort of converge, and you would still have residual disease in these areas. And that's also described by the Manzoni article. So in such cases where you have disease which is extending anteriorly to escape into the infratemporal fossa, minimal extension to the infratemporal fossa, or you have disease involving the hypotympanon, where there's no superior extension towards the tegmen. In such cases, these are cases which we would recommend to do a sequential resection by doing a lateral temporal bone resection initially, and then drilling out any involved areas. So this clearance of the eustachian tube becomes easier. And yes, you can preserve the facial nerve in all, not in all cases, in some cases, but if you have disease extension into the facial recess, or the middle ear mucosa or the promontory is positive for disease, in that case, it may be prudent to sacrifice the facial nerve because you do not want to leave behind disease in the facial recess, just because you want to save the facial nerve function. Remember that disease control is most important. And if you have disease in the facial recess around the stylomastoid foramen or on the middle ear mucosa or the promontory, in these cases, you may have to sacrifice the facial nerve. You can always consider doing rehabilitation, anastomosis of the facial nerve in bit of facial reanimation. But disease control by a proper surgical clearance is very paramount.
Thank you.
So any more comments or questions from the audience? I think so, ma'am, there is none. And thank you again.
Thank you
for the presentation.
So the next speaker is Dr. Song Joseph.
Good morning, all. First of all, may I compliment all the previous speakers who spoke brilliantly about the surgical techniques. I really liked your presentation, Professor Brian. And Dr. Deepa Nair very comprehensively she covered that topic. So I'm also, let me thank all the organizers for inviting me, especially Dr. Kaberi, who took a lot of pain in organizing our travel and hospitality. Thank you. It's a pleasure being here. It's an honor being here in one of the, it is indeed the oldest cancer institute in the whole of Northeast, and in the name of such a great and legendary physician. So my topic is reconstruction after temporal bone and lateral skull base resection. Okay. So who plays the most important role in bringing the patient back to his normal life? I've always felt it's not even the reconstruction surgeon, the resection surgeon, the person who first sees the patient. No? He should have a very good plan so that every treatment plan of the patient is sequentially performed and properly managed. And finally, patient returns in the way he wants to return back to the society. So every reconstructive decision has long-term consequences, and we should be wary of that. So I'll try to make it very simple. In fact, my presentation, the topic is quite simple compared to the previous topics. That's what I feel. I'll first go through the defect components following lateral skull base resections. What are the goals of reconstruction? The reconstruction options and how to choose various flaps for reconstruction. Then comes the functional rehabilitation outcomes. So I have a second talk after this, when I'll be covering that. So a surgical defect following a lateral skull base resection would show, I would primarily look at it as a soft tissue defect, a bony defect, and the neurovascular structures. The soft tissue would be the skin, auricle, parotid gland, infratemporal fossa contents, dura. And the bone defect, lateral temporal bone defect, mandibular, condyle would be going, the zygoma may be going, orbit may be involved, and the neurovascular. So these should be seen different. And what are our goals of reconstruction? The most important goal is separate and seal the CSF leak. Separate the intracranial and extracranial compartments and seal it. You have to protect the dura, the carotid, and the cranial nerves. And then obliteration of the dead space, with a view that majority of these cancer patients would be requiring adjuvant radiotherapy. So we should be using vascular tissue to facilitate adjuvant radiotherapy. And then comes what the patient really wants. Patient wants to be back to the society as he was before he got this disease. So restore the function. So for all the juniors here, we have three options. Local flaps we have the regional flaps, and we have the free flaps. So it's easy. When to use which flap is what we are going to decide. Mostly it is like that. So we have the temporalis flap as a local flap. The sternocleidomastoid, we should be aware of that. The submental flap would be the local flaps which we generally use in this area. Among the regional flaps, we would consider the supraclavicular, the PMMC, the trapezius, and the LD rarely. And the free flaps, the LT is the workhorse these days. So any resection surgeon should be well versed with at least the local and the regional flaps. That is for sure. Otherwise, it will be very difficult to go ahead in lateral skull base, advance in lateral skull base surgery. So we should be deciding which flap to use based on the defect. So let's try to divide these defects. One is small, well-contained defects. Like in this particular case, even if you have done a bony resection, but if the soft tissue loss is not much, the skin loss is not much, you have a small, well-contained defect. In that case, you can consider local muscle flap like a temporalis flap from above, or a sternocleidomastoid from below, or a combination. So most probably you will be able to solve this. If you have, in case you have a dural defect, it's important that you make sure that the dura is sealed in a watertight way. You may use a fascia lata graft for it, or sometimes even the temporalis graft, but make sure in all these cases you keep a vascular tissue to cover it. So these are local muscle flaps. When do we use it? When there is no skin defect, or if it is a primarily closable skin defect with a minimal dead space. So these are the different ways we can use the temporalis-based local flaps. So they are quite versatile. Many of these local flaps are very versatile if we try to use it. So once we understand the flap anatomy, we can use it based on the defect area involved. So one is this, the first one is a temporoparietal fascia flap. The second, that's a temporalis muscle flap. The vascularity, the pedicle supply is different for both. Then you can take it as a temporalis myocutaneous flap, in which case you have to actually track the perforator going to the flap. And the fourth, that's a temporalis myocutaneous with a calvarial bone flap. We cannot say how it is going to be. All these can be very useful in a particular patient. And in some of these patients, even your free flap skills may not help you, because sometimes only local flap can work in that way. And now the second is when a skin defect is present and the soft tissue loss is relatively less, you can use a local or regional fasciocutaneous flap. The skin, then for example, the submental flap or the supraclavicular flap, I would be using in a case where the skin defect is there, but the soft tissue loss is relatively less. You can cover a little bit of soft tissue with that. And the choice of patients would be like submental flap, as in any other case. Try to avoid in a, I would try to avoid it in a case where there is nodal disease in that area, prior neck dissections, prior RT, and all those things. You have to be very careful. Not that you cannot do it, but you have to be very careful while using. But it would be ideal for an elderly high-risk patient with a moderate defect. Another thing is, another flap is the supraclavicular flap. Here again, the skin defect is present, soft tissue loss is less. This was a basal cell carcinoma who underwent surgery and then underwent radiation and then came with a disease recurrent in that area. So the supraclavicular island flap is a very good flap for such patients. It is fast, thin, it has a good color match, and the morbidity is quite less. Now we are moving to the next level of defect. It's a moderate to large skin loss, and the soft tissue loss is there in a considerable way. This is the time when we can consider regional myocutaneous flaps, like a pectoralis major myocutaneous flap. The pectoralis major myocutaneous flap, you can take it like a regular pectoralis major, or it can be a real savior in situations where you cannot use a free flap also. Free flap has its advantages, but sometimes when the free flap is not possible in a patient, you should know how to raise a large pectoralis major flap, because it can reach, like in the patient on the right-hand side, it can reach quite high up posteriorly if you really plan it well. And when the skin loss is moderate to large and the soft tissue loss is considerable, another flap which you can consider is a trapezius myocutaneous flap. So this is also a very robust and reliable flap which you can use for the posterior or the lateral skull base defects. And then coming to the moderate to large skin and soft tissue defects, where you can use a free flap. So these are situations where you can use a free flap. And these days, the ALT is a preferred flap because the morbidity is less. You can actually harvest a large skin paddle with ALT. And the most important advantage of a free flap is like you don't need to think much about the planning is relatively less. You can just contour the flap very easily. So the free flap becomes a preferred option these days. And ALT compared to many other soft tissue flaps, free flaps like the rectus, has a long pedicle. It's the large skin paddle, and it can be used in a chimeric way as well. And the donor side morbidity is minimal, which is the very good plus. This is again a case, it's a recurrent chondrosarcoma involving the infratemporal fossa and the orbit, for which the ALT was taken and the muscle was used, the skin paddle was used in such a way that for the orbit also the skin, it was there, and we deepithelialized and covered the palate with the rest of the ALT, and the muscle also was used to cover the ITF. So, so free flap and regional flaps, they are, I mean, my thing is like it's about the patient and it's about the defect. So these are complementary options. Free flaps offer superior contouring, independent positioning. It can be used for complex defects. While regional flaps have advantages in faster reconstruction, it's technically simpler, reliable vascularity. So depending on your strength, you should choose your flap, and depending on your patient, obviously. But free flaps, you need the technical expertise to do it. The cost will be higher. Whereas in a regional flap, to a great extent, a lot of people are trained in it. So they are complementary reconstructive tools selected according to the patient and the defect factors. Maybe like whenever you're pushed poor free flap candidates, the patients with significant comorbidities, prior radiation or surgery with compromised recipient vessels, high anesthesia, surgical risk or technical limitations, it may be a better option to opt for regional flaps. So then again, for younger patients, good performance status, suitable vessels, complex 3D defect, favor free flap. Try to go for a free flap when it is possible. So free tissue transfer would remain the gold standard for most moderate to large lateral skull-based defect, but regional flaps remain invaluable in selected high-risk patients. So for example, for this patient, we had done a trapezius flap for an angiosarcoma, surgery done, then irradiated. After around 6 years, she developed a small recurrence and was operated elsewhere. There was a flap loss. A second surgery was performed. Then again, the loss again deepened. Then at that time, we were very concerned because we had to do a reliable flap, and the patient was drowning in cost also. So we took this trapezius flap from the opposite side. So it's like the soft tissue defect mainly decides. With the soft tissue defect, the larger the soft tissue defect, the larger the composite tissue loss, the flap increases, the size of the flap, and the choice of flap would go from the local to the free flap. So to conclude, defect analysis must include soft tissue, bone, and neurovascular loss. Reconstruction aims to separate intracranial spaces, obliterate dead space, protect vital structures, and restore form and function. Soft tissue requirements primarily drive flap selection. ALT flap is a workhorse for most moderate large size defects. Regional flaps are still invaluable in select patients. Acknowledging my team at Asta Medcity Kochi. Thank you for the patient listening.
Thank you so much, Dr. Joseph. In fact, my teacher used to say, if you don't know how to repair, don't cut. Then there was a discussion on in Tata, Dr. Pai was there, in fact, regarding flaps, what flap to put, how free flaps can be harvested, and maybe 15, 20 years back. I remember Dr. Jatin Shah saying one thing. He said that free flaps do not come for free in terms of time as well as money. Okay, anyway, you presented really well. I enjoyed listening to you. Okay, we'll take some 1 or 2 questions from the audience. Not exactly questions, someone can add also. There are a lot of people I see from BBCI.
I am Dr. Gopi from Hyderabad. So I have 2 questions. One is, both are about the temporalis. One is myocutaneous flap and one is osteomyocutaneous flap. Actually, 3 subunits with 3 different axial blood supplies. So I was able to ask how much of the bone you have taken of the calvarium, because it is usually supply both. It's a dual blood supply. Inner table has a separate blood supply, outer table has separate blood supply. So the temporalis muscle, which is based on DTA, is usually not supplying that part of the calvarium. So how much bone will be present in that part of osteomyocutaneous flap of yours, and is there any limit of how much to be taken? Or is it a free bone graft that is being used as a part of the tissue? Actually, I was unable to understand that part of the reconstruction. And the second part is the skin pattern over the temporalis, in the temporalis myocutaneous flap. How are you tracing the perforator from the temporalis muscle to the skin? Because the temporalis muscle is from DTA and skin is by STA. So how are we tracing the perforator that is going from DTA muscle to the skin? So 2 questions, sir.
Yeah. See, in all these cases, we have done a Doppler to actually map the vessel supplying the skin paddle as well as, and for the bone part, we have made sure that the bone is, the soft tissue, it's completely attached to the soft tissue. That is one thing. And these are all, this particular patient, we have taken for a small bone defect. It cannot be used for a large defect, for sure. It was for basically orbital floor reconstruction for a limited defect. So I suppose the size of the bone would be maybe around 3 into 3 centimeters, and the outer table only. That's how we took it.
I have one more question, sir. Do we trace the perforator till the origin of the perforator?
Yes, yes.
Okay, and one more thing, why don't we use iliac crest bone just to bridge the apex? Because there is study from Tata itself that free bone graft surrounded by a free flap is having better outcomes than to have a taken out calvarial bone.
No, that would require a separate donor site and a different surgery. No, this is just from the local site. So it all depends on the patient.
Okay. So, what is the maximum amount of bone that you have taken? It's only 3 centimeters.
I think I have to interrupt. He is here only. You can interact one-on-one. Okay, don't mind. Anyone?
Yes, sir. Like, yes, sir. We use it. We use it, especially when we suspect a dura breach. Even after the facial ladder, we would be using free bone graft. Fat graft. But not as much as we used in TMH during our training period. Maybe I think such cases are relatively less in Kerala. That's what I understand. No, never. Whenever we have considered a large regional flap or a free flap, I haven't really thought about using a fat graft.
Okay. Thank you, Dr. Son, once again.
Thank you so much.
May we invite the next speaker, Dr. Orindam Kakoti. He will be speaking on CP angle tumors.
Respected chairpersons, honorable members in the audience, a very good afternoon. A very big thank you to the organizing committee for giving me the opportunity. Dr. Brian has already spoken about CP angle tumors from the ENT perspective, so let me put it forward from the neurosurgeon's perspective. Okay. So what is the cerebellopontine angle? I hope we all know. Basically, it's a very small space between the pons on one side, medially, and the petrous bone and the cerebellum. Importance of this structure is that a lot of important cranial nerves, facial nerves, all the from 5th till 11th cranial nerve are present here. vascular structures like the ICA is present here. Of course, surrounded by important balancing organ like the cerebellum and the pons carrying the pyramidal tract. So that is why lesions in this area are important in terms of how we approach them without causing too much problem to the patients. So cadaveric dissection, this is from Roton's cadaveric dissection, where they have die-cast the vessels, shows the extent of the nerves, the 7th-8th complex going into the internal acoustic meatus, the lower cranial nerves going into the jugular foramen, and the vascular structures present here. Relationship of the various 7th-8th complex nerves, the superior and inferior vestibular nerves, with the cochlear and the facial nerve being anterior to the chin. So this is the diagram of showing what we see during surgery when we go from the retromastoid region. So spectrum of tumors occurring here, good thing is that most of the tumors are benign. Temporal bone tumors, they can be malignant, but most of the tumors in the CP angle are benign. And commonest of them being the acoustic schwannomas or vestibular schwannomas, comprising around 80 to 94%, followed by meningiomas, epidermoids. These are the gist of the tumors present. However, other rarer ones are the other cranial nerve schwannomas are there, paragangliomas, chordomas, metastases, chondrosarcomas, and of course, cholesteatomas. So I will keep my talk to these primary 3 tumors. So acoustic schwannomas, for classification's sake, are divided into various T1, T2, T1 being in the intrameatal, primarily intrameatal, T2 being intra and extrameatal, the second image, T3 being it's reaching into the cistern, CP angle cistern, T3B is reaching the brainstem, and subsequently, as the brainstem compression goes on, the tumors gets bigger, higher stages. The second thing is the meningiomas. Basically, CP angle meningiomas are the posterior petrous meningiomas. So some people classify them as premeatal, postmeatal, and meatal, and the petrous apex. This is postmeatal, premeatal, and this is the meatal. So meningioma characteristic is that they are broad-based. The acoustic schwannomas, they tend to be what we call as the ice cream cone appearance. They tend to come out from the IAM. So that is a differentiating point in imaging. Sorry. Regarding epidermoids, which is the third common tumor here, epidermoids usually are not solid tumors. They tend to occupy the cisternal space. So you will not get them as rounded lesions. And the most important thing is that if you get diffusion images, in the diffusion images, anything which is white, outside the brain parenchyma, because in the brain parenchyma it's an infarct, outside the brain parenchyma, it's most likely an epidermoid tumor in the cistern. So what is the aim of surgery? Previously, if you see a tumor in the scan, you want to take it out. But as things have progressed, primarily now the first question we have to ask is, how are we going to preserve or improve the function of the patient? Second comes the surgery. Then you plan about the surgery. So my talk is on this line. So approaches to the CP angle. Now skull-base approaches, lateral skull-base approaches for us is, if you want to go anterior, there is the orbitozygomatic approach. There is a subtemporal approach. Posterior fossa, we can go through the petrosal approach, and lower down near the foramen magnum, we can go through the far lateral approach. So in this CP angle region, there are basically 3 approaches that are used. This favorite for neurosurgeon is this one, the retrosigmoid approach, where we approach through behind the sigmoid sinus. However, in certain cases, especially when the tumor is going above the tentorium, because our vision doesn't go above the tentorium in the retrosigmoid approach, or it is going in front of the brainstem, touching the basilar artery there. In those cases, we might need to go through the pre-sigmoid approach with various stages of petrous bone excision, retrolabyrinthine, partial labyrinthectomy, or total labyrinthectomy. And there's of course one more approach, the middle fossa approach, which we seldom use and only useful for very medially placed tumors and which are very small, less than 2 centimeters in size. So how to select approaches? So translabyrinthine approaches, advantages, there's lower CSF leak if you do it properly. There's minimal brain retraction, can be used in all sizes of tumor. However, it can sacrifice hearing. However, if you do retrolabyrinthine approaches, hearing can be preserved. And any size tumor without serviceable hearing, it can be done. Middle fossa approaches is basically for small sized tumors, as I told you, and more medially placed tumors. Also, one advantage of middle fossa approach is that the access to the entire internal acoustic canal, especially the lateral ones, because from the retrosigmoid, it's difficult to go more than 2/3 of the internal acoustic meatus. Retrosigmoid, of course, it is the workhorse. 99%, I would say, of the CPO angles operated by neurosurgeons will be done through this because it is very fast. You reach the tumor within 1 to 2 hours, and you can focus on what needs to be done. Closure is also easier. However, in the translabyrinthine approaches, you need to do a lot of bone work, and it takes a lot of time. By the time you reach the tumor, you're already fatigued. So this is the thing. However, in function preservation, I feel that CP angle tumor should not be done without any neuromonitoring because it's paramount importance, especially monitoring of the facial nerve. Cochlear nerve can also be managed, but it is cumbersome. It requires specialized neurophysiologist, but facial nerve can be monitored by anybody, and it needs to be done before doing it, for doing any CP angle tumor. A special mention about NF2 patients. So the decision making in NF2 patients is a little bit dicey because these are very aggressive tumors. They are not like normal CP angle tumors. So they progress very fast. So observation also, you have to do 6 monthly MRIs because they sometimes can increase in size suddenly. So if the tumor size is similar, the side with a better brainstem auditory evoke responses is treated first. If they go on both sides, the side with larger tumor is treated first. If both tumors are large tumors in compressing the brainstem, treatment is first on the side of the more significant brain compression. And if patient has unilateral hearing loss or complete deafness, aim is to decompress the brainstem aiming to preserve function. So this is a typical CP angle tumor. You can see it is extraaxial tumor. There is a CSF cleft around it. Important to see if there is any edema in the brainstem, because if edema is there, then it has infiltrated into the brainstem. So this is the retrosigmoid approach. After releasing the CSF, we retract the cerebellum, and the tumor is exposed. Acoustic schwannomas have 2 layers of arachnoids. So meningiomas will have 1 layer of arachnoid. So it is important to remove the arachnoid because that gives you a plane around the tumor. So here we are trying to remove the arachnoid around it. And it's also important to know that usually the acoustic schwannoma, this is a neuromonitoring we're using to see sometimes the facial nerve can be posterior also, but mostly it is anterior superior in the front of the tumor. You'll get them last. And to preserve the facial nerve, it is important to identify the nerve near the brainstem or at the internal acoustic meatus. So once you have, then you go around decompressing tumor, leaving the capsule. We are using a accuser to decompress the tumor. So as the tumor gets decompressed, the capsule you can pull and dissect. So once you pull it, you can see the facial nerve is coming to view near the brainstem. So with a cotton pledget, you separate the facial nerve and you go dissecting the tumor. Decompress, take out the capsule, see what is behind. Slowly, you can go on doing it. So in the end, this is the facial nerve going into the internal acoustic meatus. Better to use the bipolar stimulator because monopolar stimulator will sometimes cause dissipation of current, and in nearby, if any nerves are there, you may get an erroneous response. So it's better to stimulate, and the best outcome you will get if you use 2 milliamperes of current near the brainstem and you're getting a good signal. That means the patient will have preserved facial nerve function. So this is the post-op scan and the patient. Now, sometimes what happened, you got multi-compartment tumors, as some of our previous speakers have said. This is a trigeminal schwannoma. He had middle fossa involvement, posterior fossa involvement, pre-brainstem tumor was there. So single approach will be quite an extensive approach and took too long. So we did it in 2 approaches. As I told you, skull-based approaches are many. So the anterior part of the tumor, we did first the FTOZ craniotomy, frontotemporal orbitozygomatic, and remove this part of the tumor which was superior to the tent. Following that, we did the retrosigmoid approach. Through the retrosigmoid approach, when we do the retrosigmoid approach, it is important to delineate the border of the sigmoid sinus. This is the sigmoid sinus. There is the transverse sinus. Placing of the burr hole is important. It should be near the transverse and sigmoid sinus junction. This is the cerebellum coming into view. How do you speed up the video? So we release the CSF to give more space. Similarly, the tumor is exposed. Again, the arachnoid is peeled so that we get the plane. Again, we check for the facial nerve. Here, since the tumor is anterior to the, arising from the trigeminal nerve, facial nerve is pushed posteriorly. You can see the facial nerve there. So we dissect the plane, then decompress the tumor. Again, using CUSA. Without CUSA, treating these schwannomas is quite difficult because the decompression becomes very tedious. So here the facial nerve has get the 7th-8 complex has got delineated. Then we are going anterior to it, decompressing. So final part of the capsule can be removed, and its brainstem is coming into view now. Running out of time, so I'll go to the next patient. So this was the post-op scan of the patient. Both the middle cranial fossa and the posterior fossa component of the tumor was taken out. So regarding petroclival meningiomas, so these are relatively difficult because they're too deep inside. Reaching them is difficult, and they may involve important structures like the ICA, the basilar artery. So in this patient, if you can see, it is the medial petrous based on the tent also is involved, and the clivus is also involved. It's touching the basilar artery, but it's not infiltrating. ICA is preserved. So in this patient, we did this is the audiogram of the patient. We decided to go pre-sigmoid. So the incision is a C-shaped incision. I'm sorry, the video quality is not good because in that surgery, the recording was not very well. So basically, we exposed the temporal bone, the petrous bone area, and the retrosigmoid area. You can do either the temporal craniotomy and the retrosigmoid craniotomy first, then do the mastodectomy, or you can do the mastodectomy first. So we did the mastodectomy first. I prefer that because the sigmoid sinus is delineated in that region, and I can be sure. However, if you have navigation, you can use that to delineate mark on the bone where the sigmoid sinus is. So this is the basic bone excision that has been done, exposing the infratemporal fossa, the retrosigmoid region, as well as the. Following that, these are the cuts that are made. Presigmoid cut is made, and subtemporal cut is made, and we have to cut the superior petrosal sinus. So superior petrosal sinus is coming here. We coagulate the superior petrosal sinus and cut it. After that, the tentorium will come. We have to cut the tentorium around 1 or 2 centimeters behind the cavernous sinus and preserve the superior cerebellar artery and the abducens nerve. This is the tentorial cutting. So the tumor comes into view now around the petrous bone. So same principle, separate it from the brain, slowly decompress. CUSA is best because working space is very small. Monitoring of nerves. Here the facial nerve is coming. So decompressing with the CUSA. Now the brainstem is coming into view as we keep on decompressing. This is the fifth nerve that is coming now. This is the fifth nerve. Dissecting from the fifth nerve. Now meningiomas are attached to the meninges, meaning the dura. So the attachment has to be burnt. So this is the detachment of the medial part from the clivus. And the final part of the tumor is getting removed. So we could achieve a total excision in this scan. The MRI is showing total excision in this case. However, so this is the patient post-operatively, 3rd day post-op. Eighth nerve function is seventh nerve function is preserved, as well as fifth nerve function is also preserved. However, you do not land up with every time with preservation of the nerves. This patient with SCP angle tumor, we could not preserve the facial nerve. This is 3 months after surgery. She has a facial in high facial on the right side. We had to do a tarsorrhaphy. So in the end, these are all findings, but what does the evidence say? What are evidence regarding treatment of CP angle tumors surgically? So the Congress of Neurological Surgeons Systematic Review have given these guidelines for in 2025. They have studied all the good quality studies till 2022, and they've come up with these recommendations regarding surgery. So they have some questions and answers. In patients with sporadic vestibular schwannoma and serviceable hearing, is retrosigmoid craniotomy as effective as middle fossa craniotomy for facial nerve preservation with GTR? They're saying there is insufficient evidence to prove this. Second question is, in patients with sporadic vestibular schwannomas without serviceable hearing, is retrosigmoid craniotomy as effective as the translabyrinthine approach for facial nerve preservation and GTR? There again, there is insufficient evidence. And third question, in patients with sporadic vestibular schwannomas, is there an optimal surgical approach in all 3 approaches available for tumors more than 2 centimeter in greatest dimension compared to tumors less than 2 centimeter in greatest dimension for maintenance of facial nerve function? There also there is insufficient evidence. So till now, whatever the surgeon feels is the best outcome he can give is the best approach. So there is another few things they have mentioned is that there is insufficient evidence to support subtotal resection. Nowadays, subtotal resection is coming because gamma knife is coming up. So you do partial resection and give gamma knife for facial nerve preservation. What they have said is that there is insufficient evidence to support STR followed by SRS, provided comparable or favorable hearing and facial nerve preservation compared to patients who undergo complete surgical resection. So there is no difference. You can go for total excision. And there is level 3 evidence that if microsurgical resection is necessary, because 10% of patients after gamma knife will have progression of tumors. So if those patients are going to operate, you have to be very careful because there's a lot of addition between the facial nerve. So facial nerve preservation rates are quite low, and tumor excision rate is also low because brainstem addition is there. So on that note, I'll end. Thank you so much.
Thank you, Dr. Orindam. We'll take one or two questions only. We are running late. Yes.
Arindam, you gave the chart where you showed about the trans lab and the middle fossa and then the retrosigmoid. And which amongst you is the better approach for facial nerve preservation when the facial nerve is not involved, but of course you have now a CP angle tumor, and it's of course involving the meatus and the hearing is gone. So what would your approach would be a better access?
Regarding only if my concern is facial nerve preservation, I would prefer retromastoid, because the time when I need my best concentration, it is preserved. Because other approaches, till the time I get there, it's already fatigue has set in. That is one thing. Other thing that I decide on is regarding extent of the tumor. As I showed, if it is going too anterior or too superior, so in those cases, of course, we have to think about other approaches like pre-sigmoid approaches.
But would you combine the two approaches, or would you then start off with a retrosigmoid and then do an extended?
It's possible to combine, but I haven't required to combine as of now, because in pre-sigmoid also, to relax the cerebellum, we have to open post-sigmoid. Retrosigmoid. Small opening has to be made to relax the cerebellomedullary cistern to release the CSF so that the cerebellum goes back. So that is done. That can be extended to go retrosigmoid also if required. That of course it is important because retrosigmoid gives a more anterior view. Because petrous is like this, we are looking like this. So retrosigmoid we are looking like this. So the more anterior view you get, but problem is you reach the basilar artery in the end. So there you require a little bit of, so that is one of the things.
Hi, sir. Facial nerve most superiorly, and the most soft tissue landmark is superior vestibular nerve. Basically, brain that gives the because it's we don't go for the bone way, we don't follow the Bill's bar. We take the superior vestibular, then to get directly to the seventh nerve. So the seventh nerves come first, then the rest of the nerve in ISA. And so that's why I think transclavian is most functional preservation than the retrosigmoid. What is your take on, sir? I want to sir's opinions also.
You're saying trans or retro?
Transclavian.
In non-serviceable hearing?
Not so serving. I'm the facial preservation, I'm telling. Sir's question was facial preservation.
So, Biswajit, I agree that the retrosigmoid might be a better option because of the time duration and for the access. Because all your tumor is inferior and posterior when you are doing a retrosigmoid. Like you said, if the tumor is more anterior or superior, then maybe you might combine it, or maybe start off with a trans lab or a middle cranial fossa. I haven't seen many middle cranial fossa approaches, but primarily as if the ENT surgeon operates, I see that people go for a trans lab. But when you're looking at a multidisciplinary approach, and your discussion is there in the tumor board as to how you're going to access it, I think the right way would be, where is the tumor extension? Is it gone beyond the meatus into the CP angle? And then how far is it stretching the facial nerve? If the facial nerve is stretched, you will find it that the tumor is, when you're going at trans lab, the facial nerve is anterior and medial, and your dissection will be more posterior. So your access as you go beyond the sigmoid will be posterior. So your access actually is going posterior to access the entire tumor. So when you have a larger tumor, in my opinion, a retrosigmoid would be a better approach. Right.
The both approach are equally good. In fact, I have to credit my translate what I'm doing today to Dr. Arinda. When I started to call it. See, the problem is questions are coming to ENT quite frequent, and we will be in a center when neurosurgeons are not well versed also. For him to know where he is there, we don't need to go for translate, but sometimes we come across where neurosurgeons are doing retrosigmoid. They have a lot of facial nerve palsy. See, my concern is facial nerve palsy. For you in your hands, in the best neurosurgeon hand who are very well versed in retrosigmoid, there is no need for translate. But in a center where we need to do facial nerve preservation, and we are seeing retrosigmoid causing a lot of facial nerve palsy, there translate. Because translate, one of the advantages is head on to the tumor. And secondly, the nerve is identified from the beginning of the surgery. And then as you use nerve monitor, see, the nerve is usually under the control, something like that. So, but as I said again, board retrosigmoid is a well-versed, time-honored, and in a good neurosurgeon hand, is still the best approach, I can say. Well, my question now coming to you, see, petrocleval meningioma. Will the trans-Levantine transcochlear give a better approach than what you do in your last case? Will they, because if I drill the cochlear, if I drill the cochlear and the apex, see, you are head on to the petrocleval meningioma. I've seen the neurosurgeons struggling with See, acoustic neuroma is not a problem. No, it's not a big deal. No. Good neurosurgeon will do the best job. ENT, Mario Sana type, or say, they will still translate the best job. So this depend upon the surgeon who is doing regularly. But petrocleval meningioma, see, I've really particularly seen neurosurgeon really struggling. And I don't know, will the transcochlear give a better approach? I want
You're
to
saying total petrosectomy.
See, if you shift the facial nerve posteriorly, we can remove the whole cochlea. We can drill the whole petrosepace, and we'll not remove the tumor, but we'll give you a head onto the basilar artery. My last slide.
You're very correct, sir. In fact, 3 days back with Dr. Biswajit Gogoi, we had done.
So this is the approach by the ego face, actually.
The patient had little bit of hearing, so I was reluctant for the.
Hearing is, if there's no hearing.
I know. He was very, like, I will.
But if there's no hearing, we should never go, yes.
So we didn't go, and later on the CT is showing that we should have gone because the angle the bulge, of the middle ear was causing the vision problem. So we should have gone on second thoughts. But yes, petrocleval meningiomas, a lot of things depends on the extent of the tumor also very important because subtemporal, we cannot see too much high. So that is why if it is going too much above the tentorium, it is better to go from a FTOZ approach or some approach in 2-stage surgeries. And also depends on whether vascular encasement is there or not. If vascular encasement is there, you never know when you are doing the tumor decompression, you may injure some important structure. So in those cases, since these are benign tumors, it's better to leave behind some tumor.
I feel is, not many people do the middle fossa approach. The Hisselberger approach was designed primarily to also address the same situation where the facial nerve is at risk and you have a larger tumor going towards the petrous apex. And I feel that might be a middle path towards even hearing preservation to some extent and facial nerve identification. So in the cases where you have too far anterior disease or too far inferior and posterior disease, both the approaches have their limitations. So I think that might be a superior approach where you're seeing both the middle and the posterior fossa might be a better access.
Yes, as a surgeon, you always want to see the normal structure first so that you can trace where the abnormal things are.
Yes, I'd like to interrupt here.
No, actually, we all neurosurgeons learn doing sapiengal tumor from retromastoid. over last 4 or 5 years, we have started the trans lab. So I am experienced in both approaches. Of course, middle cranial fossa approaches very rarely we do for CP tumor. Actually, we need to see detailed study about the tumor size, most important size, hearing, and facial nerve. Facial nerve is a tumor-friendly nerve, not a surgeon-friendly nerve. Many a times you monitor everything, but while doing dissection, putting some cottonoids, most of the patient, they develop facial nerve palsy. Even though you have preserved electrophysiologically, surgically, but transiently we do get facial nerve palsy. But that again, surgeons hand and team work is very essential for that. Now, idea of doing the CP tumor, what is your aim? You want to preserve hearing, you want to preserve facial nerve, you want to preserve the life. Because first and foremost thing, the starting point, you need to be very gentle. Because nowadays, the pattern of tumor in CP has been changed. When we were resident, that time, CP tumor was used to be so huge. Now, over the period, the facial nerve, people usually comes early now, tumor size is less. So you could able to preserve the facial nerve as well as the loss of hearing preservation is coming up now.
Okay, thank you, Rumjyoti. We can discuss it during lunchtime also. Anyway, so my take on all these discussions is that CP tumors were primitively, rather historically, were treated by ENT surgeons. Neurosurgery is a later specialty than ENT. So there were some rudimentary reports of some surgeons, I don't know which specialty they belong to, but typically ENT surgeons did CP tumors historically, anciently, okay? So then the neurosurgery developed. So it's in tandem, see, we have to respect each other's approaches. And as Dr. Brian said, the whichever is beneficial to the patient and whichever you are comfortable with, we should adopt it. Anyway, thank you.
Thank you.
You generated a lot of debate. Thank you. Our next speaker, Dr. Biswajit, come over.
A very good afternoon. I respected Chairperson, sir, and thanks to the organizing team of BBCI for the second skull-based, inviting me for the second skull-based course. I think I'm standing as a benign surgeon here, and lucky to I have my own mentors, Dr. Gautam Khan, who has given me the 3 subjects to try. One is the airway, one is the cochlear implant, one is the skull base. I think the skull base is, I'm a little bit of poor student. And I think both of my 2 neurosurgeons is in this hall, Rumjyoti and Arindam. And the first topic of mine is the vestibular schwannoma observation and radio surgery. So as we all know, the vestibular surgery is previously known as acoustic neuroma. Now it's a vestibular schwannoma. Why? Because it's a Schwann cell origin. And its affinity to grow at the transitional zone. The transitional, that's why the CP angle. This is located, where is the transitional zone? It is a zone where the Schwann cell migrate to the ISC. They get the glial cell, and this is the cell. This is a specific name, I forget the name now. And it was first observed in autopsy in 1770, so long. I don't know how, without a microscope, without most probably with that time, I think, don't know MRI, no CT scan, only X-ray was there. Sir Charles Wells published the first clinical case report of vestibular schwannoma in 1833. So my talk was to the, I'm not the authority, but going to all the references, I'm today. So if the patient come to my OPD, that he is asking my very plain question, docs, how will you treat my T1? So this basically, this is class, my treatment protocol is to go with the 3. Either you can go for observation, I can go for microsurgery and stereotactic radiation. So, but if you see this is my basket of the offer, what I can offer to him. But in our very less cohort, we have only the microsurgery MRI follow-up cases. I don't know how many of we have get the cases of you can wait and observe. How many of we get the cases of wait and scan? But definitely nowadays, more MRI screening, more sudden sensory nearing loss, the cases of observe and MRI follow-ups comes. But here again stands where, how do you follow up the MRI? What interval? It's a 6 months, it's a 1 year. That's again comes to like Orindanta has the sporadic characteristic tumors are different follow-up protocol, and the other tumor has a little bit of non-sporadic follow-up protocol. Basically, we prefer to go with a 1 year MRI things. And that's why. So I try to make it a very simple, what are the 4 denominator will give the judgment to my patients. So this depends upon how they present with us. What is the radiological mapping? We have a very good presentation today. It's a thorough radiological mapping. It is not the CT scan, it is not the MRI only. We have to know as a surgeon what are the sequences of an MRI and also the audiological evaluation. If I see the Orindam presentation, most probably there's a word, keyword is here is a serviceable hearing. So I'll try to stand here for serviceable hearing. Since I am a otology, I'm a student of cochlear implant, try to take the word, the serviceable hearing from today's my talk and the resources available. So they mostly present with the vestibular symptoms, but they forget the first vestibular symptoms because they compensate. So I mean, because it's a very slow growing tumor, they lost the history of when they gets dizzy. But if they present with a vestibular symptom, presently it's not the vestibular, so it may be dizzy patient, maybe has a large tumor that affects the cerebellum. So take a note on mine. Cochlea, how they present, since they're slow growing, they have no as such a complaint of hearing loss. So either they may present with a progressive hearing loss or they present with a sudden sensory hearing loss, unilateral. So any unilateral sensory hearing loss, the investigation of choice is always a MRI. Trigeminal lump symptoms, yes, they present with a trigeminal lump symptoms, like sensation, all these parts of the face, and very rarely they present with a facial nerve palsy. Why? We have that's why the treatment is, why is such large tumor, they don't present with a facial nerve palsy. I think in ISC, facial nerve is the most accommodative nerve to grow of the tumor. It's in a Sambu textbook, it is written as it becomes like a gossamer. I have searched the Google, what is the word called gossamer? It's a thin worm-like. It's so thin out. I have a very, but I can't hyperlink the video. Let's try once. Anupam, mostly you have not that fixer. Sambo is a very beautiful fixer. How it's a thin out. That's why you have a facial palsy. Whatever you do, whatever gel form, whatever micro dissection, ultimately it's so thin out. But if it presents with a facial palsy, it's not the vestibular schwannoma. It is a primary 7 nerve. It's a primary facial nerve schwannoma. That's the tip. If it's present with any lesion from ISE, if it presents with a facial nerve palsy, then it is not from the vestibular nerve. It is from the 7 nerve, facial nerve. Large tumor always present with lower cranial nerve palsy with all this mass effect. Not going. Okay. What happened on one? So yes. So second denominator, the size. The clinical presence, I have finished most of the clinical. So next denominator is just size. How will you know the size? We can't know the size of looking at the patients. It's the MRI with him. So these are the sequence of MRI. T2 day becomes hypointense, T1 become hypointense, both the hypointense. What is the gold standard investigation of choice for schwannoma? It's the T1 contrast. So there we'll get the hyperintense. What are the other differential diagnoses where you get the T1 gadolinium contrast? It's the meningioma. So what will get in a meningioma? The dural trail. So we have only 2 pathology will get the uptick. All other, cholesterol granuloma, all other will not get any uptick in contrast. That's all. So tumors, that's why we have to map. We always go to the DICOM software. I use the DICOM software, measure because it's the only measurement we can do, the measurement of the tumor, and that's how you can choose the treatment option. If you go less than 2 centimeter tumor, that's mostly observed, and 1.5 to 3, we have 2 modality of treatment. Either you can go with a stereotactic radiation, and according to the age of the patient, symptomatology, and generally in a young patient, poor hearing, we definitely prefer for surgery, and definitely upfront surgery for more than 3 centimeter. So that's how. If you see, this is a group or Mayurshana group. If you see, I'm not telling about what the approach, but more than 1.5 centimeter, they are taking mostly for the surgery. And if you see the Mayo group also, from 2.4 centimeter, they have a more green, that they are taking more surgical intervention for all these tumors. So size is an important denominator of all these lesions. Now, the third denominator, we talks on the hearing preservation. If you see, if you go to the YouTube last 2 weeks, I have seen hearing preservation surgery for vestibular schwannoma, hearing preservation surgery for, but do you generally measure our hearing? Number 1, vestibular schwannoma present with a normal hearing. Vestibular schwannoma may present with a sudden sensory hearing loss. They may present with a progressive hearing loss because they are basically vestibular schwannoma origin. So why there is a sudden hearing loss? Because of tumor enlargement, maybe there is a hemorrhage, and maybe cochlear nerve involvement. So the investigation audiology is here, the speech score. But it is not only speech score, it is the marks, M-A-S-K-E, the marks speech score. So what's next? So what is the speech score? Next is the marks speech score. Third is the insert masking. So when you refer for the audiologist, you ask 3 questions. When there is the internal disturbance difference of 10 dB, you will always ask for masking. What the masking they have, you always ask for, do you have an insert masking facility? Third, they have to measure the serviceable hearing. So what is the serviceable? The law of 50 by 50. 50 dB hearing loss in pure tone and less than 50 in the speech distribution score. That is unserviceable. That groups come from C and D. So that's why if you don't do all this, I most probably in my next talk, I'll try to, you see, these are 2 different audiogram. Have you seen the left side audiogram? If you go through file of many CP angle surgery, you will get this audiometer, this audiogram. What is not there? It is species not there. If species not there, then how will you know this patient has a hearing? All guidelines is saying the 2 words. It's not the hearing. This is serviceable hearing, sir. So it's a combination of both pure tone and my speech. So this right hand, you have all this speech score. You can appreciate. He has in the left ear, pure tone threshold is 91, and you see speech score is a 42. So if you go to this, there's a less than 50. So it's a class D. The non-serviceable hearing. So you can do translab from the approach also. You can have a hearing presumption surgery. So, and again, can MRI give a serviceable hearing or non-serviceable hearing? Can you please the left side of the cochlea? What is this image? It's a T2. In T2, CSF is bright, cochlear fluid should be bright. But why there is a whiteout? It's black. You will see when you perform a T1 contrast, cochlea is also taking up the contrast. That means some elements is also there. There's a cochlear loss. You have a hearing, normal hearing or moderate hearing loss, but your T1 contrast is showing there is a contrast uptake in the cochlea also. then you can't preserve that patient hearing. You're not going to do hearing preservation surgery. Yes, this is how the radio surgery has taken up, and you can show how the tumor regress with the radio surgery. Radio surgery claims hearing preservation, but sometimes literature says this, mild immediate hearing loss, maybe there's a edema because of the radiation, and but many studies have showed that because what is the difference, the deficiency of the radio service, they don't go the tumor away, get rid of the tinnitus, preserve hearing, and get rid of vertigo. But this is important. We see the long-term hearing with the radio surgery also, there is a decreasing trend. The last denominator is the resources available. What as all have says, because because we are not do the middle cranial fossa force. Similarly, we need all the armamentarium, the team, the knowledge of the whole team, including the all neuromonitor, all this available. That gives what the best option I can offer to my patient. And in conclusion, this factors influence in the choice of treatment into tumor size. Number one, hearing status, course of the tumor growth, as longevity of the associated health status. Radiotherapy is the treatment modality for small canalicular tumor without any nerve palsy, tumor more than 2 centimeters within CPS surgery is the modality. So surgery is a complete tumor removal with preservation of function. Thank you. Thank you so much.
Thank you, Dr. Vishya. You have completed before time.
Because I have another talk, so I bonus.
So I think we can take a single or a couple of questions, but we already had a debate on this subject earlier. I think all the questions are exhausted, and that was a lovely session. The talks were very good, and it arose debate. The paradox is that as the day progresses, people become sleepy, but here we have seen that the people become more active during the end of the session. So thank you once again. I thank all the speakers for presenting very beautiful talk, and also the organizer for giving us the opportunity. Thank you.
Thank you. That concludes session 2. Now I will request the chairperson and all the speakers to come on the stage for the group photograph. Then we will be taking a lunch break and we will be starting at 2:15 sharp. So Dr. Siddharth sir, Arindam sir, Sean sir, and Gogoi sir, please come on the dash for group photograph. Brian sir, please come on to.
Can you hear me? Hello? Can you check on the Zoom whether it can be heard by other participants? Yeah, I'm speaking. Can you hear me? Yeah? And see as well?
Kindly join for lunch at Tumor Boardroom.
Why is that? You can see the presentation? You can see this also. No? Yeah. No, because you had done this. I can. When you do this, na, comes here. Me alag dito. Yeah.
Hello, check.
Hello. 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 ठीक है सर
Processes, perineural invasion, positive margins, recurrent tumors, and bone invasion would warrant adjuvant radiotherapy. And this has been important because it has shown to have improved survival outcomes with adjuvant radiotherapy when compared to surgery alone, especially for T1. and T2 cancers. We all know the modified Pittsburgh staging system, and you must have heard of it already. But just to recapitulate, early lesions are the T1, T2 diseases. In T1 diseases, which are limited to the external auditory canal without bone erosion or evidence of soft tissue extension. T2 diseases, anything which is limited with limited external canal auditory canal erosion or soft tissue less than 0.5 centimeters. Whenever the soft tissue is more than 0.5 centimeters, it becomes a T4 disease. Whenever there's full thickness involvement of the bone or involvement of the middle and mastoid, then it is a T3 disease. And any nodal disease is upstaged automatically to T4 disease. Now, why it's important to know the disease extension and staging? Because when these patients present to us, because of the natural foramen or the natural propensity of the tumor to spread through different parts of the external auditory canal into the adjacent structures, what we find that in a substantial amount of patients, around up to 63% of the patients in the study by Gidley et al., there was extension of disease from the anterior EAC wall into the surrounding soft tissue. The jugular foramen was involved in 23% of the cases, carotid artery in 11% of the cases, infratemporal fossa in 11%, and the TM joint in 4%. Now, what is very important to understand is most of the times tumors arising from the external auditory canal will be limited to the external canal and spread through the various foramen or eroding the bone either posteriorly or anteriorly. Generally, the middle ear is quite resistant to involvement by disease, and this is due to the presence of the tympanic membrane, which was previously described as the Ongren's line for temporal bone cancers. So generally, to have a tumor transgress the tympanic membrane and involve the middle ear is not very common. When these tumors involve the middle ear, it has very poor outcomes with lower locoregional control, disease-specific survival, and overall survival. Anytime you have patients who have de novo cancer involving the middle ear, this 5-year survival is really poor in these cases, irrespective of the type of surgery which you do offer for these cases. Now, before we think of operating patients, we should know what is unresectable in these patients. And definitely the areas like involvement of the carotid canal, involvement of the petrous apex, the middle fossa dura, the otic capsule, the involvement of sigmoid sinus, jugular bulb involvement, and frank intracranial brain involvement, again make this technically unresectable because these areas are difficult to get a good clearance. It's not just enough to get a gross total resection. You need to be able to be confident that you have taken out every microscopic bit of the disease. But also, especially when you are talking about repairing of the dura, you should be able to successfully repair it, which is a challenge when you are resecting middle fossa dura, especially in the petrous apex area. So any of these extensions would sort of technically make them unresectable and would send these patients for non-surgical management. The surgical treatment algorithm is very clear, and I think you've already heard about the different types of surgeries. And for us, whenever we look at the patient, we always look at where the tumor is primarily situated, whether it's in the external auditory canal, middle ear, and the hypotympanum or the infratemporal fossa. So if it is in the external auditory canal and just limited to the cartilaginous external auditory canal, that is a true T1 lesion, you can offer a sleeve resection in these cases. Anything which extends beyond the cartilage into the bone, even if there's no bone involvement, would warrant a lateral temporal bone resection at the minimum. If there's disease involving the middle ear and extending into the middle ear, but the petrous apex is free, that is, it's a true T3 disease, you would offer subtotal temporal bone resection. But if the petrous apex is involved, what requires to be done is a total temporal bone resection, a surgery we do not advocate nowadays because of the high morbidity of the surgery, where you need to sacrifice the carotid. And in spite of that, the disease is very likely to come back soon, and your disease controls do not match the morbidity what you're offering in this surgery. If there's extension into the hypotympanum or the infratemporal fossa, what we offer is something called a sequential resection or a modified subtotal temporal bone resection. Now, you have heard about en bloc versus sequential resection. And this paper by Elisabetta Zanoletti and Mazzoni is a very good paper published in 2016, where they talked in depth about the different techniques and principles of surgery. They defined an en bloc LTBR as removal of the cartilaginous and bony external auditory canal with the eardrum, periauricular soft tissues, parotid with or without the facial nerve, and lymph nodes. And they prescribe these in patients who have T1, T2 diseases or anterior T3, T4 diseases. They prescribe an en bloc subtotal temporal bone resection when you resect the whole temporal bone except for the petrous apex lying anterior to the IAC in non-anterior T3, T4 cancers. Now, this is very important that they are talking about non-anterior T3, T4 cancers, and we'll just come to that shortly. So if you see a classical or an en bloc subtotal temporal bone resection has very well-defined steps, where you do a temporal craniotomy, you elevate the dura of the petrous bone, the superior osteotomy is along the floor of the middle cranial fossa, there's an inferior osteotomy, the sigmoid sinus is ligated, the temporomandibular joint is resected, and this cones down into a triangle, and the facial nerve is generally sacrificed. So this case, as you see here, where there's disease in the middle ear, which is reaching the tegmen, not really intracranially, but just elevating the dura off and limited to the external auditory canal, is the ideal candidate for a classical en bloc STBR. However, what we have realized through our experience is that 30% of patients would have a prior history of chronic suppurative otitis media. And however good we have imaging like CT scan or MRIs, the sensitivity and specificity of predicting middle ear disease is poor compared to what we would want in these, because there is an overestimation of middle ear and mastoid involvement in patients who have underlying CSOM. This is primarily because of either the retracted drum, which plasters over the promontory, appearing that their middle ear is completely involved, or due to presence of granulations in the middle ear, which is just reactive to the long-standing infection and the blockage of the gestation tube by the tumors. Also, 30 to 40% of patients who have been diagnosed as temporal bone cancers would have undergone some prior mastoidectomy, because they would have been misdiagnosed as chronic otitis media, and then the granulations which are sent during surgery are diagnosed as malignancy, and then they are referred on for further treatment. So what happens in such case, like in this case, that there is erosion of the posterior wall, there's extension along the eustachian tube, and more importantly, there's also a lot of inferior extension down along and inferiorly. Now, when you have such sort of extensions which are going anteriorly and inferiorly, remember the osteotomies of the en bloc subtotal temporal bone resection cone down towards this area, and more often than not, this is the area when you're doing your osteotomies and you have disease in this hypotympanem or anteriorly in the infratemporal fossa, you're going to leave behind disease out here. And then you have to clear this separately in spite of doing an oblong. So what we have moved on is to do a lateral temporal bone resection in these cases. And this is primarily because we know we need to achieve good disease clearance, but when patients do not have disease involving the tegmen, we want to avoid unnecessary craniotomies in them. We want to avoid unnecessary damage to the inferior petrosal sinus or the sigmoid sinus when they have completely anterior and inferior disease. And in such cases, also try and preserve the facial nerve function. The Prasad and also described this very well, that when all tissues lateral to the cervical petrous carotid are removed, recurrences can occur. And in such cases, when you have disease on the medial jugular wall, sometimes you may have to remove them piecemeal. And it does not make sense in such cases then to have disease left behind on the medial jugular wall, remove that piecemeal, but try and remove the whole temporal bone, risking the carotid by an oblong resection. And so what they have prescribed is that when you have patients who have non-anterior disease, in such cases you can offer a classical oblong subtotal temporal bone resection. But when you have a T4 disease or disease involving the infratemporal fossa, in such cases you have to do a piecemeal resection. So we have modified it to call it a sequential resection or a modified STPR. These are in cases which involve the infratemporal fossa and the hypotympanem, where we know that we won't get a complete clearance anteriorly and inferiorly, and our major limitations are the internal carotid artery and the jugular bulb. In such cases, we would do a conventional lateral temporal bone resection, assess the middle ear mucosa through an extended facial recess approach, send granulation tissue, send middle ear mucosa for frozen section. Most of the times we find that there's no evidence of any disease in there. If there is disease on frozen section, then we would first complete the LTBR as a monoblock as classically described, and then subsequently drill out all the involved areas of the promontory, of the cochlea, leaving only the petrous apex behind, but trying to preserve the vestibular apparatus, trying to preserve the facial nerve, and getting the same negative margins as a subtotal temporal bone resection. Now, again, the paper which I referred to previously, Mazzoni's paper, have talked about both techniques and have talked about the advantages and disadvantages of both. But again, the radicality depends on the tumor site and extent. And generally, if you feel that the tumor is in the anterior and inferior compartments, it may be more, or the patient has undergone a prior mastoidectomy, where again, taking an oblong specimen may not be possible. In such cases, it may be prudent to be guided by the tumor and resect appropriately. Our aim is to achieve a negative margin resection. Now, this can be done in a sequential resection. It can be done in oblong form. The aim is to get a gross total resection. The aim is to be able to have a clearance where we are sure that we've not left behind any disease. And it's not the technique which predicts survival. It is the clearance which ultimately predicts survival in these patients. We looked at our hospital. This is data between 2007 and 2016. And we found that irrespective of the technique, it is the extent of the disease which really determines the outcomes of these patients. And if you can see that even with in advanced T3, T4 disease, where there is either an oblong resection or a sequential resection, the overall survival and the disease-free survival are almost similar, with good local control in both the subgroups. What are the other issues when you're talking about surgery in temporal bone resections? Again, one of the factors is should we be preserving the facial nerve or not? Simple factor is that if the facial nerve is normal and you do not have, you can offer a lateral temporal bone resection, then the patient's facial nerve should be preserved. If you have to do a subtotal temporal bone resection due to disease in the middle ear, disease in the facial recess, you need to sacrifice a facial nerve because, again, clearance of the facial nerve is of most importance. What about involvement of the neck nodes and the incidence of neck node metastasis? So again, in most cancers of the temporal bone, unless they are involving the skin of the pinna, the rate of occult lymph node metastasis is much lower. It's in the tune of around 14%. And if you actually look at it by the T staging, the highest T stages, that is T3 and T4, have a higher incidence of occult nodal metastasis. So generally, comprehensive neck dissection is not offered in early tumors, that is T1, T2, because of the chance of low risk of occult nodal metastasis. If you do want to do a neck dissection, you should plan it in advanced cases, that is either in middle ear involvement, in the presence of either facial palsy, obvious node positive disease, intraparotid nodal disease, skin involvement. These cases are the ones which you can offer elective neck dissection. One of the policies what we do in Tata Memorial Hospital is to do a level 2 sampling and send that level 2 nodes for frozen section. If those nodes are positive, then we would definitely complete the rest of the neck and do a comprehensive neck dissection. For a higher grade tumor, if you're planning to do it electively, you can clear levels 1, 2, 3, and 4. If that's node positive, you definitely have to clear 1B to 5 in these cases. What about parotidectomies? Well, the incidence of direct parotid involvement in early cases is very low. Generally, the involvement of the parotid by direct extension is only seen when there's soft tissue involvement or erosion of the anterior wall of the disease by the cancer, and then you would have extension of the parotid. More likely, you may have intraparotid nodal disease, which will make a parotidectomy mandatory in those cases. So the recommendations are that when you have disease which is eroding the anterior wall of the extraorbital canal, or you have intraparotid nodes, in such cases, you may want to do a total parotidectomy. In these cases, facial nerve can be preserved as far as possible, unless there is disease along the facial nerve or in the stylomastoid foramen. But most of the times, the parotidectomy would be a total conservative parotidectomy, and this is for achieving a good safety margin on soft tissue anteriorly, as well as to clear the nodal disease in the parotids. When you deal with advanced cancers, that is, cancers which are involving the infratemporal fossa or extensive soft tissue involvement or a large neck node which may be borderline resectable, you need to upfront decide what your intent is, whether this patient is a curative intent treatment or a palliative intent treatment. Is there a role for debulking surgery? Not really. If you feel that the patient, you're not going to be able to achieve good margins upfront, then this does not make sense to remove part of the disease, leave some disease behind, expecting radiotherapy to take care of it. In such cases, you may think of giving neoadjuvant chemotherapy in patients who are not clearly resectable upfront. Again, which are the patients whom you may predict that you would want to use this approach is the patients who have extensive soft tissue disease, extratemporal disease, and extensive involvement of the parotid, involvement of the infratemporal fossa, or large neck nodes which are borderline resectable. Again, the risk of recurrence in these cases is very high, and so these patients who have T3, T4 disease would always need adjuvant treatment. Now, we have used in our series neoadjuvant chemotherapy in locally advanced cancers. This is data of 16 patients who received NECT for locally advanced unresectable cancers. There was a decent response rate of around 44%, and 42% of these patients managed to undergo surgical resection. Again, you need to think about non-surgical treatment like chemoradiation in patients who are very advanced and in whom clear margins may not be feasible. We have treated these patients. Of course, the outcomes of these patients are poorer than when you are able to offer surgery and adjuvant radiation or chemoradiation to patients. But still, there is a fairly good control with upfront chemoradiation in locally advanced disease. Rehabilitation after treatment is very important, and there are lots of issues like how do we balance between loss of hearing versus disease control, especially with respect to dealing with conductive hearing loss, which happens when we do a temporal bone resection in these patients. Is there a role of osseointegrated hearing aids? And some of the subsequent lectures today are going to cover all of these. So I'd like to end by saying that in surgery, the principles are very clear. If it is possible, you should resect it because temporal bone cancers are a surgical disease, but you need to assess your imaging well. You need to plan in advance. You need to make your intent, whether it's curative or palliative, right up front. Start as a monoblock lateral temporal bone resection in all cases. Be prepared to do a sequential resection under frozen section guidance, especially for those cases where you feel the middle ear is involved under the on preoperative imaging. Always aim for a gross total resection, and remember that survival outcomes are similar whether you do a gross resection or a sequential envelope resection or a sequential resection if the disease clear is optimal. Thank you.
Enjoying the movie, man. Then lectures, you are enjoying the movie. Enjoying the Arepo. Total change of personality. Really? Used to recently you are making very big. That's the same point, sir. You also you'll be you always be reading the source of inspiration. And sir, you are here only. That's why I'm here. Meeting. Suddenly I just came out. I saw you where. Saw you were sitting with that. Saw you, sir. I thought you came this. No, I had a mistake. Just I thought meeting or attending some Balu sir lecture. He's taking lectures, sir, Balu sir. Sometimes he takes classes. Really? Take not regularly. Not regularly. And he, like Choma, he's telling update. Not like a during academics days. During academics. Topic. Being planned. That's it. Being planned. They usually sometimes takes a topic. It's a discussion. Banana on it. It's a discussion. Choose sir. I don't have any good start. September 24th. Mine is different, man. Mine is Sage. Then when is the exam? Mine is different, totally different. I don't know. Now the banana network. So don't know what to put, what not to put. The mail he put everybody MS family putting to us also. My HOD is literally torturing me. He don't know how to put all these things. That new things produced by university, na? It's torturing me. That e logbook. I never opened the logbook at all. Huh? And, initially it's not there. The university is not well planned in this thing, and the university is releasing just exam 3 months before, 4 months before they release what they will do. It's just a summa for putting some they're doing their own blah blah blah. Same specialty also in other countries like they don't know my parallel batch here. Tamil Nadu only they have logbook. No other places. It's a problem.
Colleges, usually remember you said 2 colleges, right? CMC and
Only say Tamil Nadu CMC only. No other colleges they have that. Only here only. No other places in Tamil Nadu is not there.
specialty. What they are doing.
They also don't know anything about it.
Strokes. That would be happening very easily.
Guwahati, Tata.
What of CMC, what to learn from Tata,
List means we have to see the list. Sometimes next week OT case. Nobody is there. That is a problem here. No one will. The anesthesia team is not available. They'll block the thing. So. Yeah, that will be there, but anesthesia will see up to 4 o'clock, I think so. They have to PHs, na? Because Monday OTs are there. Sunday is holiday. They cannot see on Monday. See Sunday. At least IP, they tell that IP on Saturday. Sunday they have a time. Otherwise, maybe duty team is here only. Someone will go and see and don't know. Just plan.
Big college, cases to keep on running. They can have a separate team
for PACs. Otherwise, patient will not wait till Monday or Saturday, Sunday, and we are not getting appointment for PAC. That is not a thing. You should provide because you are charging. You are not giving free of that's what I'm telling you. You are charging, and if you are doing like this, that side okay, but some educated fellow he will complete his show on CMC and take money from the CMC. They have their own problem, but anyway, whatever the thing is, they should provide
service.
Because the amount, the pay, if we go to Apollo, he will operate by within 1 day. Here it is not possible like that. Okay, I'll accept comorbidities and all the thing. Okay, whatever thing, even they will do it within 4 to 5 days. Mostly with 4 to 5 days, they will complete. They're telling they have less load, 8 pounds. We are also charging same like them. We are also doing same like them. We are doing everything. Why there is not possible here? Because of
separate team.
Yeah, they have separate team for everything. So it's not mixing with others. OT's team is totally different. Anesthesia team is totally here also different, but I don't know whether the people are sufficient or not.
People can handle this. Why should people see? They should have separate
people. Yeah.
Actually, to do it with usually you're doing something asking insights of answers questions.
People will not wait because people are paying money. Insurance also giving money.
A refreshing lunch break. We once again welcome you all to the second BBCI Skull-based CME. We will start our next session, Master Video Session. I would like to invite Dr. Raj Lakshmi ma'am and Dr. Shamim sir to chair this session.
Good afternoon, everyone. After a nice, sumptuous lunch, we would welcome you to the video session. First video session would be on lateral temporal bone resection for temporal bone malignancy by Dr. Deepa Nair, Professor, Department of Head and Neck Oncology, TMH. I think this is the recorded one here.
Good afternoon. I'm going to talk about actually how we do the temporal bone resection.
You can start.
And this is going to be a brief overview of the steps and a small video about the various steps in temporal bone resection. So temporal bone cancers, as we all have heard throughout the day, are very rare and less than, even in a busy center like Tata Memorial Hospital, we operate less than 10 to 15 cases every year. We've already seen the different types of resection. The most common resections which are carried out are the sleeve resection and the lateral temporal bone resections. Subtotal temporal bone resections, now the conventional oblong resections are less frequently done. More often than not, we do a sequential resection after a lateral temporal bone resection for tumors which involve the middle ear. The most important thing when we start with for surgery is incision planning. And generally, if the skin is free, you can plan it as a C-shaped incision. This incision is placed around 4 centimeters behind the pinna, extending superiorly so that you get good access to the temporalis muscle. If you need to do a craniotomy, you can get good access there. And lower down, this incision is carried along to the neck so that you can get good access to the parotid, level 2, as well as a neck dissection if you need so. However, a significant number of these patients will have skin resection involvement either due to previous surgeries, presence of scars, or just disease coming through the postoral regions. Then you have to modify your skin incisions to involve these previous operative scars or encompass the disease which is present and accordingly modify the superior and inferior extents so that you can have less amount of pinna necrosis and good exposure at the same time. The other thing is to circumscribe disease in the external aortic canal, and this is done typically keeping a margin on the disease in the external aortic canal, and that is done using an incision on the tragus. We basically take an incision in the canal skin and suture the canal skin so that we don't have any spillage of disease. Once that is done, then you erase the flap, expose the whole area which is going to be resected, and as well as the parotid. Now, this lateral margin in the EAC, which I have talked about, is done so that you can, one, raise the flap anteriorly properly. It helps you contain spillage of the disease and gets the good lateral margin. So this is something what we do. Once we've taken a canal margin all around, we suture the edge of the tumor so that the canal, so that the tumor remains contained, and when we are drilling, there's no spillage of the tumor and contamination of the field. We try and preserve the lateral end of tragus wherever possible, as long as it's oncologically safe. And this is how the flap would look after elevation. Here you can see this is the cut end of the external aortic canal and tragus, which is remaining. Here, this is the tumor circumscribed, and the external aortic skin and tragus is sutured to contain spillage of the tumor. After complete this, we proceed to complete a superficial parotidectomy if indicated either by the presence of nodal disease or anterior wall involvement or soft tissue disease in the anterior canal wall. In such cases, we would do a superficial or a total parotidectomy as warranted. The next step is to elevate the temporalis flap, and I will show you a bit about how we elevate this flap in the subsequent video. This is done to keep it used as a part of reconstruction at the end of the surgery and to fill the cavity. Now, this is a small video clip which is speeded up, trying to show you the basic steps of the surgery. So after this exposure is done, and like conventional cortical mastoidectomy, this is performed. Now you have to keep the cavity wide, but unlike a conventional cortical mastoidectomy or a modified radical mastoidectomy, we are trying to keep the canal wall intact. Especially if you have disease which is coming posteriorly towards the mastoid, this might be a bit of a challenge. You need to expose and open the whole posterior canal wall, and what we are trying to do here is circumscribe the disease so that we can get a full circular segment of the external aortic canal completely. So you drill above into the tegmen area, as you can see out here, and all the tegmen air cells are drilled out completely. Inferiorly drill out to the digastric tip. Once you've done that, you identify the incus, and then by an extended facial recess approach, as you can see we are doing here, we're thinning out the posterior canal wall. And here you can see the fossa incudis and the extended facial recess approach which is happening. Now, this extended facial recess approach is done because this is where we are going to work around disconnecting the external aortic canal above the facial nerve to keep the facial nerve intact and remove the specimen, which is a margin, along with the tympanic membrane. And once the posterior disconnection is done, anterior osteotomies are taken along the anterior tympanic ring. Then the only thing which is remaining is going to be some soft tissue, which will be at the parotid as well as the tympanic membrane and the ossicles. Remember, you've already taken off the fossa incudis. Now, this is once the specimen has been removed and delivered. You can see the residual fallopian canal. You can see it going along the stylomastoid and the exit of the facial nerve. What we do is smooth out any rough edges, drill out any soft tissue disease, any granulation in this area, and be sure that we are leaving behind no disease. We also then inspect the middle ear. Typically, we would strip off all the mucosa of the middle ear because we plan a cul-de-sac closure, and we would send this middle ear mucosa for evaluation in the frozen section, just to be sure that there is no microscopic disease remaining behind in the promontory or in the facial recess. Once that is done, we achieve hemostasis. Here you can see some gel foam being put. And I was talking about raising the temporalis muscle flap. This is what we do. We raise the muscle flap as high as possible to get the complete bulk of the temporalis muscle. It is an anterior and inferiorly based flap. So we are basically dividing the muscle posteriorly and from the superior temporal lines so that we can elevate and rotate this along the attachment to the coronoid process of the mandible. So here you can see the temporalis muscle as well as the temporalis fascia is being elevated. Sometimes if you need some more soft tissue, You can extend the incision and take some part of the pericranium as well. This flap is then sutured to the residual soft tissue, to the digastric muscle, to the parotid, and we use fat to obliterate the cavity. Next, the external auditory canal remnant external auditory canal is closed in layers to complete the cul-de-sac closure. These are just talking about the middle ear involvement. Again, even in cases which look like this, where there seems to be significant middle ear involvement, it's always good practice to dislocate the incus, do an extended facial recess approach, inspect the middle ear, because the middle ear involvement is always overestimated by CT scans and MRIs, especially when the patients have chronic suppurative otitis media or a retracted drum. As mentioned, once your osteotomy is done along the anterior tympanic rim, the specimen is delivered, and this is how an ideal lateral temporal bone cavity should look like. When you are performing a subtotal temporal bone resection, generally the en bloc resection means you're resecting the petrous bone, the mastoid, the bony and cartilaginous canal, parotid gland with the facial nerve, all as one specimen. And you need to separate the tympanic bone from the dura, the carotid, the sigmoid sinus. And so you need to place particular osteotomies, the temporal osteotomy, the occipital craniotomy, across the anterior, medial, and posterior aspects of the petrous bone. This is just a small clip, a very old clip of a conventional en bloc subtotal temporal bone resection, which is happening. This is the dura, which is retracted, and we are working along the tegmen and the middle cranial fossa. We are performing an osteotomy along the floor of the middle cranial fossa, which forms the superior margin. Here you can see the osteotomy being placed. This is the soft tissue in the external auditory canal, which is circumscribed, and the superior osteotomy, which is being placed to give you the superior margin. Now, the posterior fossa dura is retracted, and the posterior osteotomy just above the sigmoid sinus, the posterior part of the petrous, is performed. Once these two osteotomies are done, and this is just a schematic representation of the same, you generally have to sacrifice the facial nerve, and this inferior osteotomy is always made along the floor, which towards the stylomastoid foramen, which leads to sacrifice of the facial nerve. Now again, going back to the same video, you connect the superior and inferior osteotomies at the stylomastoid foramen. You can see the inferior osteotomy being placed just above the styloid process. You have to be careful here that you do not have the trajectory passing through or the fracture line passing through the internal carotid artery. Once this is done, the specimen is gently mobilized from all sides. You can see the elevation occurring and release of any soft tissue which is holding it back, typically the facial nerve, and then the specimen is delivered out. You free the zygoma from the masseter, the mandibular condyle is always taken in the specimen, and then the specimen is delivered. As you can see here, this is the last bit of the osteotomy, where we are releasing all the soft tissue from the zygoma, the anterior parotid, the temporomandibular joint, and resecting the specimen completely along with it. So though this is an en bloc resection, generally because of the various orientation of the bone and the way the osteotomies are placed, the specimen may still not be completely intact, and the pieces of bone may separate out just because of the orientation and anatomy. Here you can see the specimen being delivered out along with the condyle, and this is the remnant bed which will contain the posterior fossa dura, the middle cranial fossa dura, the posterior fossa dura, and the internal auditory meatus. There may be CSF leak from the internal auditory meatus, which needs to be plugged properly. As I mentioned in my previous lecture, we have moved away from doing a classical subtotal temporal bone resection, especially in cases where there's soft tissue involvement of the hypotympanium, stylomastoid foramen, and the infratemporal fossa, because as you saw, the osteotomies which are placed and coned down would leave behind residual disease in these areas. So what we do in these cases is do a conventional lateral temporal bone resection, then denate the facial nerve completely, and then drill out all these affected areas. The end result should be the clearance will be similar to a oblong subtotal temporal bone resection, but with preserving the facial nerve and causing less damage in terms of no craniotomies wherever necessary. Reconstruction, as I mentioned before, a layer of fat is placed and then the temporalis muscle is rotated around it. Sometimes if skin has been resected due to involvement, or in such cases, we would use a spiral PMMC to reconstruct the defect. This surgery is not without its complications, the most common complication being facial paresis, but also sometimes in cases of modified or even classical subtotal resections, the chances of CSF leak, sigmoid sinus bleed are significant. Skin necrosis is a problem if incisions are not planned properly, or the patient has had prior mastoidectomy, or you're doing it as a salvage surgery. Wound infection and meningitis, fortunately, are not very common, but they are not rare either. The most important thing about the complications in the surgery are CSF leak and sigmoid sinus bleed, and we have to be prepared to manage these complications if and when they occur. Use of lumbar drain is not advocated generally in these cases, but if you feel that there's a high pressure leak, you may place a lumbar drain, but we must remember that placing a lumbar drain may again increase the chance of meningitis in the postoperative period. Facial nerve management is very important because a lot of patients would require some amount of sacrifice of the facial nerve due to the presence of disease, and the management of the facial nerve and hearing rehabilitation is going to be taken in subsequent lectures in this CME. Thank you for your patient listening.
Thank you so much, madam. Would like to have a short interaction if anyone needs.
Hello, ma'am. Can you hear us?
Yes, I can hear you.
Yeah, ma'am. Thank you, ma'am, for the presentation. Any questions, comments? There is no questions, ma'am. Thank you.
Thank you very much.
Thank you. Hello, ma'am. Yeah, Pfizer wants to tell something.
Deepa, what would you advise as far as the incision is concerned? People are taking pre-auricular, post-auricular. A word of advice on the incision planning?
So the standard, I think you've discussed this in the morning as well, that the post-auricular incisions or C-shaped incisions are, especially when you place them at a distance from the pinna, is a good incision because it gives you good access even to the tegmen in case you need to do a craniotomy. It gives you good access to the temporalis, and inferiorly gives you good access to the neck. However, if the patient has been operated previously, like a mastoidectomy or a cortical has been done, or a post-oral incision for just a year exploration has been done, then taking a separate incision is not advisable. You would have to, in that case, incorporate the planned incision with the previous scar. This is simply because the moment a post-auricular incision has been done previously, then the vascularity of the pinna will have reduced, and placing a separate incision would cause devascularization of the area and skin necrosis. Very rarely, sometimes we have encountered endoral incisions being taken by the ENT surgeons when they do the ear exploration. And in that case, you would have to plan your incision encompassing that endoral incision. Sometimes you have tumor which is involving the tragus and eroding the anterior wall coming out into the skin of the parotid. Then you would circumscribe that and then raise the pinna posteriorly in this case, again trying to preserve the vascularity. But remember, every time you raise the flap posteriorly, the chances of pinna necrosis increases because the vascularity from anterior facial branches is gone, and the greater auricular occipital artery branch also gets devascularized as the course of the mastectomy. So whenever you raise the pinna posteriorly, the chance of necrosis of the skin is higher. So as far as possible, when you are doing it, circumscribe the incision in such way that the pinna can be transposed anteriorly. The blood supply from the anterior part is much more robust.
Just to add to what Deepa said, the blood supply comes from the superficial temporal artery to the pinna. And that's the part where we need to take care as you're elevating the flap. Do not cauterize that blood supply. And lastly, once you're reposited it, please do not use a heavy mastoid dressing like we are used to. That compression on the pinna causes a lot of dermal necrosis. And we have had loss of pinna, not because the incision was not placed properly, but because there was too much of compression because of the bandage. So when we place a vacuum drain, you do not really need that kind of a compression. So these are a few pointers towards a better outcome.
Thank you, ma'am. Thank you once again.
Thank you.
Next, I would like to invite the next speaker, Dr. Biswajit Gogoi, to present the video on translabyrinthine approach for CP angle tumors. So there was a lot of debate on this topic in the pre-lunch session. So hopefully we'll get a better idea of it through the video.
Good afternoon. So this is my second talk. It's actually a video presentation, but I'm not a master, so it's not a master's presentation. I'm just a student of audiology. So anyway, this topic is on vestibular schwannoma translabyrinthine approach step by step. I am making this video particularly for my junior colleague. I am from the school of nowadays, there's not only hearing preservation, the preservation of all residual hearing also. Not only the hearing preservation, the preservation of residual hearing also. So if you go to the history of vestibular surgery, it's very interesting. I don't know how without that modern era of microscope and CT, MRI, they have started as a Charles balance. But it was a Harvey Cushing and Dendy who actually was all these microsurgical approach, the two neurosurgeons who generally, but still they have a 40% of mortality. But I think this William House is the first neurotologist who team with neurosurgeons. It is the era of 1960. So they club with the neurosurgeons. So neurotologists and neurosurgeons first approach the CP angle, the vestibular schwannoma. And they have found that what Dandy and Cushing has done, the most of the previous surgeons and ligate the anterior inferior cerebellar artery. So they have first done the stop, ligating the anterior cerebral artery. Then comes as we have discussed transortic approach by William Igofis. The Mariusana group has this extended translab approach. Maybe I miss many grades like neurosurgeon Roton here and Lalegam, but I'll quote many during the course of my treatment. Actually, FS Quicks has this translamplar approach in 1946. But the neuro people has abandoned that technique. Then the William House again proponent this technique. And what the extended translamplar approach is by Mariusana group. So this is the translamplar, the left side picture. You can see, as Brian sir has said, it's a direct approach to the cochlea, and you have the other approach where you need a bend detection. No doubt. If you see this is a group autological chart, then more than 1.5 centimeter, whatever hearing, you can approach with a translab approach. Same with as we have going to this same slide by Orindam also. This is from the textbook of Laligam, the Atlas of Neurosurgical Technique. If you see the indication, the right side, the last tumor, more than 2.5 with serviceable hearing also, it's the choice of approach. So what's the basic difference between classic translab and enlarged translab? The classic translab is basically we have a island of bone. Generally, we don't retake it. But the extended translab, ultimately the whole approach, except the anterior, all other walls are soft tissue wall. Superiorly doer, posteriorly sigmoid plate. So we can retake the whole software. This is a concept of, and this is a line I have directly quoted here from Laligam Brook. And this is how the extended translab has proponent. I'm not going, already these things are discussed. So a little bit of anesthesia, it should be the balanced anesthesia where immobility and minimal muscle relaxation. So that this nerve monitoring is a key here in this part of the surgery. And also the safe anesthesia for the timely emergence. And hypotension, because of the position is the key. Previously, all the surgery in a sitting position, all the neurosurgeons, today has the dreaded complications due to hypertension. So this is the OR environment. This is how it is not the preservation of function, also preservation of hair. We did let the betadine dry, and also the modern gadgets like without the CUSA and all this thing, you can operate this kind of tumor. These are all microdrill instruments, and this pneumatic drill gives an extra because this is a very high top generated, so it's very good for the little bone dissection. So now mandatory. This is basically the OR setup. A little bit of just now the anatomy. What is the basic ISC anatomy? So I have borrowed this picture from one Wava, is a CI surgeon from Egypt. So he has described the ISC anatomy at the porous part. In Europe, the soft drinks are served outside the veranda, and hard drinks always served inside. So what are the soft drinks? The 7 is up, 7 up. Coca-Cola is these are two soft drinks. And hard disks are inside. So when they come with a hard disk, come out to the veranda, they have a vestibular gate. So superior vestibular and inferior vestibular are the posterior and a part of the ISC. So basically, ultimately the preservation of all this structure. Second anatomy, we have to give respect of veins because all the veins, because that may be the only dominant vein. Few days back, what I am putting this picture of, the suctions are very important when you walk on all this vein, it expose and a vein. I don't know what this 2 liter of showing here. Actually, is the flow rate to that suction if you close properly. Now this the video. So this is how we make the incision before draping. And as Paisa has made this kind of incision that gives maximum exposure and so that we can go for the reconstruction. Like CI surgery, I don't prefer diathermy most part of this surgery because that I don't know. This is a concept I have created from CI surgery. So if you optimize your diathermy use, particularly monopolar, if you can use a bipolar whenever it's required, then it's always good. And you can see the flap elevation also. We prefer to go with a knife. Then you can use optimal, these are the cliff views for the skin flap blade. Then this is how this is why it's available. This is new for me actually. It's not coming. Touch skin is little different on the bone. Okay. It's not forwarding. Yeah, no, it's come. Can you have a mouse? Do you have a mouse? I can use a mouse. Oh yeah. I'll put, This is the muscular pastel layer. Yeah.
Till they set up the laptop, if you have any interactions, you can continue from the August gathering. Any queries I'll put to Biswa or Pfizer for that matter.
Yeah. I think appendectomy has started with a large conical bar. We prefer to go with a large conical bar. I prefer use to conical bar because it gives a more surface area of cutting and also safe in the initial part of the. So you can do a more carpeting of your bone drilling. That's how. Then this is the entrance we are following, and we look for the vertical portion of the facial nerve. So all the cells from the maxilla are exenterated, and as Brenda says, you have to delineate the jugular bulb, posteriorly sigmoid sinus, and initially we keep a thin layer of bone over the sigmoid, thin layer of bone over the dura, and you have to do all this, delineate the sinusoidal angle. You can appreciate how this conical bar is doing a very fine work and give the proper angulation, and you can modify your this thing. So that's how. Next, you have to go all this cell like this kind of a retrofacial cell, extension, and the delineation of the labyrinthine block. So this is the, I think, the next level. I think most of the otology surgeon, otology work will perform up to this limit. Now we have going to start the labyrinthectomy. The smoothing of the wall, and this is the dilemma. Then next come the delineation of the labyrinth proper. Then all the cells, the superior labyrinthine delineate out. We have to change according to the side of the diameter according to the side. And the first semicircular canals we delineating here, the lateral semicircular canal. You can appreciate the ampullary of the lateral semicircular canal here. Then whole semicircular canal is going to. And this is how we next the superior semicircular canal. And this is the superior semicircular canal. So this is the ampullary of the lateral semicircular canal, ampullary of the superior semicircular canal, semicircular canals. Then this is posterior end of the non-ampullary end of the superior semicircular that will club with, join with posterior semicircular canal. So that's how the all cells, semicircular canals are delineated. And here's an important structure. We're going to see the endolymphatic duct. Most probably I'll go later on there. We get the endolymphatic duct. Endolymphatic duct is actually, if you draw a line along the lateral semicircular canal, that will bisect perpendicularly posterior semicircular canal, and you will get the endolymphatic duct. So you can appreciate when you place fluid, then it comes out other. Then you can very beautifully, with a proper magnification, you can appreciate the neuroepithelium of the vestibule. So vestibule is the next level. So vestibule basically it is the lateralmost part of the ISC. So if you go beyond that, then you will going to get the ISC. So this is the neuroepithelium inside the vestibules. Then you started the expura of the vestibule. So every dissection now is medial to facial nerve. Now the next plane of the facial nerve. So facial nerves are more superiorly or lateral, and it's always, you can magnify, you can optimize the how much bone you have to drill medially. So that's a, but try to not to try to remove all the bones from the sigmoid sinus in the initial part of the surgery, because the sigmoid sinus come into your operative field. That way, when you go for more medial drilling, the shaft may cause your sigmoid sinus injury. Look, this is the sigmoid sinus is pop up. There's every chances of injury, because still you have a lots of bone. Still you have a lots of bone to drill in the medial of the your distinct sigmoid. And if it is pop up, then you can do just bipolar cauterize. It will come down, and that's how we can know how much bone you need to drill. So we should be very careful during the removal of this cell of bone, because any sharp edges may cause either any injury to the either sigmoid sinus or maybe some like superficial veins. So this mass of bone. This is because one of the hardest part of the bone, so you need a lots of drilling, and that's how we get the ISC. So how in the initial days I lost who is the ISC. So it's a simple. Then I got a who. It's the same alignment to the how our external auditory canal is there. How the patient external auditory canal is the same axis. How our external auditory canal is there. And this is the most important step of skeletonization of the ISC. You have to skeletonize 260 degree of the ISC. So that's how we have do the superior del. As I have seen, when you go anteriorly, you have to very careful because there I get the soft tissue landmark. This is a superior vestibular vein. So be very careful because that's a landmark for facial nerve. So this is the superior shaft, and you have to go here the inferior shaft. So in big tumor, it's sometimes very difficult to get the inferior shaft. So that's why you have to drill out all the jugular up to jugular fossa. You have to delineate the jugular. That's how you can get or either you can start centipetally. So in between, sometimes for the big tumor, we start at the centripetal removal of the bone. This is how because it's a jugular, because my jugular is coming here. So I start centripetal removal of your bone and to expose the ISC, and this whole ISC is drilled out. Now, this actually, honestly speaking, from this part, I always invite my neurosurgeon colleague, because now I have reached the whatever. I don't know, this is my feeling, because it's a combined approach with the neurosurgeons, and they take part of the most of the part. Or sometimes Rupjotita has said, this is I did actually Rupjotita. So Rupjotita is saying maybe so you continue the lateral most part, then I start the lateral most parts of the removal. And this is the sonopet ultrasonic aspirator. And then we start aspirating the central core of the tumor, and we try to it like axial dissection at the peripheral down the tumor to the central, and after central debulking, we can aspirate the whole tumor. They claim that there were some settings. According to them, sometimes they don't cut the nerve, they don't injure the nerve. Believe them, but better not to believe sometimes. So that's how you can delineate the whole way. But it can, because the fear of injury, the superior distance, I have not still drilling. Mostly this in video, editing video still. But if you have to drill this amount of bone from the superior aspect, then you can see the nerve superiorly there. 7 is still hiding there, still not. But if you see in this part of the video, that part is not here. So that's how we can remove all this tumor. Now we see the 7 nerve will appear. So with the help of good dissector, very gently, here the key is if you get the arachnoid plane, try to go down slow, because arachnoid giving the maximum safety of all neural elements to preserve the arachnoid layer. Should have a very good control of your suction. Don't block fully the whole suction. The whole neuro anatomy is about to visualize now. So very gently pulling, and you can remove the tumor. And sometimes you go with the assisted vision with the endoscope. If you have any doubt, and after that, when you are sure that you are about to reach all the neural structure, then very gently we go for a tumor removal from the nerve sheath. That's how whole tumor was removed. We have to give time, give patience, good suction control, and whole tumor we can remove. The last bit of tumor, and final tumor removal. So this is again the final view with the endoscope. So you can appreciate the whole anatomy. And can you appreciate how the vessels are there over the nerve? That should be maintained. That's the arachne decision is most important from the neurosurgical microscopic point of view. And it is not anatomically preserved nerve. I think it's going to be a functional preserved nerve. You can preserve if these vasculars are over the nerve. So you can see all these nerves here, and now the reconstruction. So what is the most dreaded complication of transclavian approach is CSF leak. How the CSF will come? There's two things is important. That's why the study of CT scan is very important. What is the extension of our petrous apex cellular structure? If you keep all these cells, then you have to follow the cell, take some time also. And also they have to block the editors with a pedestrian. If you don't block the editors, then the CSF will come through this route. So this editors is blocked, and with a fat, bone wax, fossa harvested before, and we have repaired the layer. And sometimes we repair without fat also, the muscles also, and the skin is closed with layers. And this is the immediate post-op. You can have a intake facial nerve and very beautifully appreciate. So I think that's just it. And this is the post-op MRI of the patient. These are my reference textbook, and thanks Kabe to again go through all this book. It's not nowadays it's so easy. And thank you all. Thank you. Thank you so much.
Thank you, Bishwa, for the beautiful presentation. The pictures were really clear. I don't know which microscope you're using, but we're getting lovely pictures from that microscope. Keep using that microscope. Don't change. And of course, the armamentarium of instruments is very important. And since this is a combined approach with a neurosurgeon, so you should know where you have to stop and let the neurosurgeon come in.
Yes.
So that's another important point. And if there are any questions from the house, we are ready to take them. Yeah.
Not as a malignancy, yes, sir.
But I thought I saw a tail, you had given a tail below that C incision, or was it just the ink running down?
This is running down, sir. It's if you see, understand it. This is this is, yeah, this is the incision.
Okay, there's no tail, no?
There is no tail. You don't come to the neck, sir. It's not like a malignancy.
What is the size of the tumor, this one?
It's more than 3.5 like that, 3.5.
You address the fundus, no? First, after the vestibule, you get the fundus.
Yes, sir.
Porous is the medial side.
Yes, sir.
Then the whole tumor covering the canal.
Yes, sir.
Therefore it becomes. But the isolation of the nerve, then you can go for it.
Yes, sir.
If you are dealing with a very sclerotic mastoid and you want to do a transloc, what will be your takes, advice to the audience?
Very sclerotic mastoid, sir. I'll follow the same, but I'll prefer pneumatic drill rather than the electronic drill, because pneumatic drill has an excellent torque. It's quite like a butter. But same time, we have to be very careful. And the issue is the pneumatic drill, they have a long handle. I don't know how bias you have. You put it like a collar. Okay, that's I found sometimes is pain.
And very sclerotic mastoid means you're going to get your The margins will be, the boundaries will be narrow.
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 But
So
anyway,
you-
sir, extended, you see the extended thread lab concept, that's the concept of extended translab. Because ultimately you need a soft tissue wall. So you have a liver, you drain the CSF, and you have a, this detector is called, detector name ki asile? With the detector, please. Lila, we have a very beautiful Lila detector with a pad over it. We can detect the dura, you can detect the sigmoids, and optimize the whole field. So it doesn't mean that you can very good soft tissue window ultimately.
Vishwadit, now we are getting the same Medas Rex with the electrical.
Yeah.
So
Medas is by Strauss, no, sir?
Metron.
Metronic, okay.
Metronic bought over Medas Rex. So we are
Ah.
getting the same 7,000 RPM.
Yes, sir.
With the IPC controller which we are using for our debrider.
Okay. We have a new set of the Escolab. Escolab has a very good deal as Brian.
So now with the same kind of the same electrical device gives the same kind of torque. But I think the difference is your conical burrs.
Yes,
Conical
sir.
burrs
But
might make.
our ENT deal has a great advantage of one is a conical burr. I always, I prefer two drill set. One, our own ENT drill set, because I put diamond bar always kept ready. Suppose in the initial part of it has a bleeding, I don't want to sense because it, so put up a diamond bar sister area or diamond bar sister. That's one is this conical bar, diamond handset ready. Third is, I don't know, sir, over the facial nerve. Yesterday. Over the sigmoid, last bit of sigmoid sinus, last bit of bone cell, I prefer ENT bar because it's lighter.
Yeah.
It has a very good control. It has a good irrigation. I have a video. If you just 1 minute, I can just this video.
The conical burr, I noticed that you had two types of conical burr.
Yes.
One with the cone distal,
yes,
at the distal end, and the other with the cone towards the shaft.
So it's not coming here. Oh, it's not coming.
So how do you use these two types of conical burrs? At what
One
time?
is, sir, one is, I am not getting it. One is
the cone
is
goes away like this,
more conical.
and the other
One is the rounded.
is
Yes, sir. So the more conical one, I used to mostly the more carpeting of drilling. And this rounded, what you have till a rounded, it's like you imagine, the proximal portion is like a ball kind of bar. So you can do like this, you have a round ball. That way I use. And you have the distal end is like a small round bar, kind of. So you see, I'm using the pneumatic drill and suddenly I have the sigmoid sinus injury. Sigmoid sinus injury. This is, so I'm just happy to, I can share the complication part also. And this is the injury. But after that, I don't know. I have a confidence on my own drill set of autology because now I'm going to delineate the whole sigmoid and also we suture it also. This portion, because already this vein is injured. Then over it, I get a more control of my this autology bar, conventional autology bar. So we can appreciate this coming out and we get the vein and we can repair it.
Regarding sir drill bit, I am using Matronics actually. I have 3 sets of Matronics drill. The drill, there are various, the Matronics they call acron bar. What you call as a conical, that is an acron bar. Actually, it will open very small. Then you go for the round bar. Again, diamond has got 2 types of diamond in Matronics.
Coarse diamond, one is coarse diamond
and one is soft. In this case, you should use soft diamond, and mind it, the drill speed should be very slow. Because normally the Matronics drill is around 75,000 RPM. So you bring down to around 10,000 RPM. What we do in pituitary and all, I think you have seen there. Over the carotid, we used to drill it with very slow speed.
Yes. Yes.
That is how you can reduce the vascular injuries.
Yes.
Suppose.
Yes. Yes.
Cautery of bipolar, like to shin anything.
Exactly, sir.
And then so to the sigmoid sinus, 2 centimeter to 3 centimeter, you can remove the bone. See, we should be trans-lemon, the secret of trans-lemon, you should be very liberal in bone removal. Actually, initial of our career, we are very miser in removing the bone.
Yes.
The more you
That's why that's a classic translab data. This is concept is coming from Myasana group. If you see the Laligam group they have quoted these things, Myasana group. I have it of pages yesterday. And this is what you are saying now. No bone there. Dura, no bone, sigmoid sinus, no bone.
And then see, delineating the facial nerve, digastric ridge, you are not exposed. Exposed up to digastric ridge, and then delineate the facial till there. So that you'll get a good control over the jugular bulb. See, jugular bulb, this part is not being well exposed, but you can go up to the digastric ridge here. You can drill the areas. And medial cranial fossa, you have to really, 3 centimeter, you can expose it. Be very liberal, posterior, superior, inferior. Then translate really very good. Provided very liberal enough bone removal.
No bone. No bone.
Okay.
Concept is a no bone.
I'd like to interrupt here because I got a message that we are running out of time, but I would like to have the discussion continuing even after the session is over. So I think with this, we have come to the end of this master video session. And I think we'll move on to the next session. We'll have a photo. Okay, right. I think Dr. Rajalakshmi had to go because she had a flight to catch. And somehow her flight was at 8 o'clock. She told me it was preponed to 5 o'clock. So she had to rush back. Thank you.
Excuse me, sir. Stay back for a minute. Can you please stay back for a minute for a photo? Thank you, sir and ma'am, for such an amazing session. With such intricate details about the anatomy and the surgery, we'll now move on to the next session, integrating non-surgical modalities for better patient care beyond the scalpel. I would like to invite Dr. B.N. Sharma, sir, Dr. K.K. Borooah, sir, and Dr. Anandita, ma'am, to chair this session.
Good afternoon to all. First of all, I'd like to thank Dr. Kaveri, Justin Baido, and the whole team for inviting us and for chair this session. So far, we are dealing with the critical anatomies, pathologies, different surgical resections. But in this session, we'll be going what is there beyond the scalpel. So what other treatment modalities like radiotherapy, SRS, what will be the various systemic modalities, targeted therapies, immunotherapies, how we are going to do organ preservation, like hearing preservation, facial nerve preservation, other lower cranial nerve preservations, and what are the newer trends, the new innovations, and what is the future of the newer modalities of treatment. So I'd like to hand the mic to other chairpersons.
Thank you. Thank you very much for inviting us to chair this session. The first session will be the role of radiotherapy, radiosurgery in lateral skull-based tumors. Speaker is Dr. Jyotiman Nath, Associate Professor, Department of Radiation Oncology, BBCI. I'd like to welcome
Dr. Jyotiman Nath.
Thank you, respected chairpersons, all the faculties, participants. We have heard a lot about the precision surgeries techniques, various spectrum of diseases of these lateral skull-based tumors. Now let us move and search where this radiation fits in the entire spectrum of disease, in which are the scenarios where radiation comes into play to improve the local control, address the quality of life of these patients. So why this skull base is challenging? From the morning we are listening that it is challenging to the surgeons mainly because of the critical structures. The same reason it's challenging for the radiation oncologists also, because it is surrounded by such structures which are very radiosensitive, and they have a strict radiation dose constraints, because of which it's very difficult to deliver a very high dose of radiation and keeping these organs within the normal range. Another reason why the tumor spectrum is challenging because of its heterogeneous biology and histology, as these tumors arises from various tissue origins in these regions like bone, parotid tissue, nerves, vasculatures, and they have a different natural history. They have different radiosensitivity. Some tumors respond to high doses of radiation, some tumor responds to conventional doses of radiation. Therefore, the treatment spectrum of the entire diseases are different in this group. So now this is just a snapshot of the different tumors. In the left, these are the benign tumors, already described a lot. And on the right side, the malignant tumors. And in skull base, more than malignant tumors, the benign tumors are more common. And again, among the malignant tumors, squamous carcinoma of the temporal bone external auditory canal, these are the common subsites. Moreover, chondrosarcomas, osteosarcomas, RMS are found very rarely. So where does radiation fits? So there is no controversy, there is no dilemma that surgery remains central to the management of this disease whenever there is a safe and oncologically appropriate. This is very important. It should be safe and oncologically appropriate. Radiation fits into different settings. In a definitive settings, mainly some selected benign tumors or patients who are medically unfit, those are unresectable disease. It fits in adjuvant settings, mainly in the malignant setting. Those have high-risk structures. It also fits in salvage settings, recurrence after surgery or progression after surgery, and it definitely fits in palliative setting to relieve some symptoms for its patient. Therefore, it's important to know that the radiation should be a part of the planned MDT strategy. So let us start the vestibular schwannoma. So we are seeing from the morning various surgical techniques, precision surgeries regarding vestibular schwannoma. So basically all the treatment modalities are accepted based on different tumor factors, out of which the tumor size and the Coos grading are the most important to decide the treatment. Presenting symptoms, the serviceable hearing, as Dr. Biswajit was telling, the serviceable hearing is the one of the important factor to decide. And based on these factors, whether to observe or operate or irradiate, decision has to be taken. So this is a Coos grading used commonly. As you can see in the grade 1, it is the intracanalicular tumor. In the grade 2, it is the tumor just reaching the CP angle. In the grade 3, it has occupied the CP angle but has not infiltrated to compression to the brainstem. In the grade 4, it compresses the brainstem. And as we move from left to right, from grade 1 to grade 2, the role of observation to radiation to surgery changes accordingly. So these are the guidelines from the EANO. These are very practical guidelines. It says that for small asymptomatic Coos grade 1 and 2 tumor, observation can be a good option, whereas radiation therapy can also be offered to the patients. For small tumors who has an impaired hearing, not a complete hearing loss, radiation therapy is offered because RT offers a better rate of hearing preservation and a lower risk of facial palsies. In small tumors with a complete hearing loss, surgery should be an offered treatment, whether radiation can also be offered. But for the larger tumors or hearing loss, surgery remains the cornerstone of management. And the planned subtotal resection followed by radiation can also be one approach for this group of patients. Before going into treatment proper, let us quickly say about the radiation fractions, because entire time I'll be talking about SRS, SRT. So since we have some non-radiation oncology students here, just something about what is SRS actually. It's something, maybe a misnomer, because it's not a surgery. Stereotactic radiation surgery is a radiation treatment, not a surgery. So whenever we deliver radiation, usually we deliver radiation in a conventionally fractionated regimen. Whenever we deliver radiation, in a dose of 1.8 to 2 gray per fraction. It is called a conventionally fractionated radiation, and it is usually given for the patients who have a large tumor, like other head and neck cancer, like oral cavity, like a larynx, where we have to treat a large area. This is a conventional fraction of radiation. But on the contrary, when we treat a very small, precisely targeted tumor, it can be a single fraction of radiation on a very high dose. And this is called a stereotactic radiation because we localize the tumor in the 3D space with the help of some coordinates. And sometimes this stereotactic radiotherapy is also delivered with some fractions, like 3 fractions or 5 fractions, then it is called a fractionated SRT. Just to make you understand what is radiosurgery is, here a tumor, mainly intracranial or tumor is identified in the space with the help of many coordinates. You can just imagine we are putting a lot of beams, many number of beams from the various angles. Low energy beams are going inside the tumor, and the point where all the beams are meeting, giving the highest dose. So the normal brain is getting the low dose, but at the area where all the beams are meeting, giving the very high dose, keeping the normal tissue within the tolerance, having a highest tumor. Because these are the benign tumors who need a very high radiation dose for the tumoricidal effects. So again, coming back, now what are the techniques of delivering radiation therapy? SRS, one is the gamma knife, as Sir was saying. These are some frame-based gamma knife system where the radiation is delivered with the help of a cobalt machine, and other systems are like linear-based SRS. We can deliver SRS with the help of common linear accelerator machines, as we have in many centers. And one of the important machines to deliver SRS is a cyber knife, which has a robotic arm attached with gantry so that the radiation can be delivered from various angles to target the disease. Coming back to vestibular schwannoma, what is the standard radiation dose? It's 11 to 14 gray in a single fraction, and it can be reduced dose like 11 to 12 gray when hearing preservation is the critical, when we cannot achieve the dose to the critical structures. With this approach, tumor control and 5-year tumor control reaches as high as 90 to 99%. Facial nerve preservation reaches up to 100% in some cases. Trigeminal nerve preservation is around 79 to 99%, and hearing preservation is variable. One important point patients undergoing SRS is the pseudo-progression. Sometimes we see a pseudo-progression of the tumor in 3 months up to 3 years following SRS radiotherapy. Therefore, it is very important to identify this, and it should not be labeled as a tumor failure. This is the evidence. This is the evidence of more than 4,000 of patients. It's a meta-analysis where sporadic vestibular schwannoma less than 3 centimeters were treated with primary SRS with a tumor control of more than 92%. These are prospective studies, but obviously without randomization because of the rarity of the disease. It has revealed that the SRS is superior to microsurgery for patients, important, less than 3 centimeter size, not the large tumors, in terms of preserving the facial nerve and hearing function. Now, next tumor where the radiation therapy fits is the paraganglioma, which is also called the glomus tumor. These are usually benign tumor, hypervascular tumors, and based on location, it can be glomus jugulare in the jugular bulb, it can be tympanicum, glomus vagale, or the carotid body tumor. Principle of management remains same based on various factors. The options can be observe, operate, or irradiate. So this is a British skull-based treatment guideline for paramenian paragangliomas, which says that for the tympanic paragangliomas, early surgical treatment is the treatment of choice. But for the jugular, carotid body, and vagal paragangliomas, it can be observed if it is asymptomatic. But surgery and radiotherapy provides equal long-term outcome. The mainstay of treatment for growing tumors is radiation therapy, as the morbidity of treatment is usually significantly less than surgery, because in paraganglioma, unlike vestibular schwannoma, you are more concerned about the lower cranial nerve morbidities. These are some evidences of series of patients which says that local control rate after radiation therapy is as high as 90% in head, neck, and other skull-based paragangliomas with stereotactic radiotherapy. Regarding paraganglioma, dose is almost similar. For SRS, we go up to 15 to 18 gray. For fractionated, we go up to 25 to 35 gray for tumors more than 3 centimeters. And for larger tumors, a conventionally fractionated radiation of 45 to 50.4 gray in 25 to 30 fractions are generally preferred. Skull-based meningioma is another subsite. This is one of the common intracranial tumors, but it can also occur in, as shown previously, in the petroclival region, CP angle, jugular foramen, and petra skull base. Again, surgery is the preferred with maximum safe resection whenever feasible. Small tumors can safely be treated with radiation therapy alone. And in skull-based site, complete resection sometimes become very difficult, and there the radiation comes into play. So these are some evidences for meningioma who are less than 3 centimeters. Both surgery and radiation can offer a local control up to 96%. For meningiomas 3 to 4 centimeter, either surgery, or if not considered for surgery, we can go for fractionated radiation. But tumor more than 4 centimeter, we definitely has to go for surgery plus radiation. And those who has a WHO grade 3 and anaplastic meningioma, adjuvant radiotherapy is mandatory. This is a phase 2 RTOG prospective trial, which is using risk stratified management for meningioma. It has low, intermediate, and high risk. For the low risk patients, they use for undergoing ZTR or STR, undergo observation. For the intermediate group of patients, undergo 54 gray and 30 fraction of adjuvant RT. But for a high grade and high risk group and STR patient, it goes up to 60 gray, which IMRT. So it supports observation for low risk meningiomas and adjuvant RT for intermediate or high risk disease, though outcomes remain very suboptimal in high risk patients. And now, after benign tumors, let's go to the skull-based cancers. These things already been covered. Rare tumor, squamous is the most common. So again, challenges are almost similar. Histologies are too heterogeneous. We have a lot of different histologies in this region. And another challenge is the rare disease. So randomized trials are not available to say what is best. So management is mainly driven by multi-institutional retrospective analysis and the expert opinions, as we have seen today. One of the common staging classification that is used for temporal bone SCCs, there is a modified Pittsburgh. As we move from T1 to T4, the complexity of surgery increases. So again, surgery remains the cornerstone of management, with radiation mostly indicated in the adjuvant setting for this group of patients. These are a list of indications of adjuvant radiation, those which have positive or close margin, T3 or T4 disease, perineural invasion, facial nerve involvement, nodal disease, or with an extranodal extension, patients with parotid, TMJ, or soft tissue extension, and obviously in recurrent diseases. These are some evidences of using adjuvant radiation in advanced T3, T4 temporal bone disease. With surgery and adjuvant radiation, the 5-year overall survival ranges up to 50%, more than 50%. So radiation is not a optional adjunctive therapy. Actually, it should be a core component of locally advanced temporal bone malignancies. But what about the T1 diseases? For T3 and T4, there is no controversy. But for T1 diseases, there are some literature says for T1 diseases, we can safely omit radiation therapy whenever we have a safe resection without any high-risk features. So this study says that when PURT was not used in T1 diseases, there was no significant difference between the survival of patients who underwent PURT in T1 diseases also. However, this is the UK lateral skull-based multidisciplinary guideline. It says this, most of the patients ranging from T2 to T4 should receive postoperative radiation, and that is our practice also to consider all patients of T2 to T4 for adjuvant radiation therapy. So the aim should be R0 resection. That is the most important prognostic factor. Across studies, it has been shown, as I shown in these two pictures, across studies, it is shown that those patients comes with a margin positive, performs very poorly. So definitely, RT can reduce the recurrences, but RT cannot fully compensate for a grossly inadequate oncology resection. So that the primary aim should be to get an R0 resection, and obviously adjuvant radiation adds into it. So the optimum approach for this group of patients for resectable with R0 possibility, it is surgery plus PURT. Patients with a high-risk pathology, surgery plus PURT, with or without concurrent chemotherapy based on the patient selection. When there is an unfit or patient who is not fit for surgery, we can see the patient for definitive chemoradiotherapy, and for borderline diseases, neoadjuvant chemotherapy that that my next speaker will talk in detail on that. Now, radiation therapy as a primary modality. Is there any scope for radiation therapy as a primary modality? Because we know a lot of patients comes in unresectable. As Madam Deepa has also said, these are some unresectable criteria. Can we offer definitive radiation for this group of patients who are not operable, who are medically unfit, or patient who doesn't want surgery? So controversies comes out when somebody reads this meta-analysis. This meta-analysis of more than 1,200 patients says that this is obviously a meta-analysis of retrospective patients. All temporal bone SCCs were taken into consideration. T3 and T4 tumors were treated. Those patients, but the interesting fact is that those patients who underwent definitive CRT had a more 5-year overall survival, those who had a surgery plus postoperative radiation. So this brings against controversy and debate. But based on this, should definitive RT be offered in a first line to the resectable temporal bone SCC? The answer is a clear no. Why? Because this meta-analysis does not automatically give a high level of evidence, because these are all retrospective series, and these series contain as low as 6 patients in the series. There's obviously selection bias, and there is heterogeneous treatment modalities, different radiation doses, different chemotherapy regimens. Most importantly, different surgical extent were used on this in this series. So surgical techniques has improved, as we have seen in the previous lectures. And most importantly, overall survival was taken as a primary endpoint in this study, because OS alone is not an adequate surrogate, because local failure is the most common failure in this group of patients, and therefore surgery should be preferred whenever patient is resectable. Therefore, the optimum approach, if the patient is surgically operable, it should undergo surgery with RGO resection, then followed by adjuvant radiation. If not, we should offer the patient for definitive radiation, because we have seen in that meta-analysis that overall survival is as high as 50%. On the other hand, if the patient is not operable, we should not label the patient as a palliative patient or a patient for a base supportive care. We should always send the patient to a radiation oncologist to assess for whether definitive radiation can be offered or not. So therefore, there is no question about surgery versus radiation. There is always question about surgery plus radiation. So this is also supported by Indian data. This is from Tata group only. Pfizer was also a part of this study sitting here. Here they have treated 65 patients who underwent surgery followed by RT. 24 patients underwent definitive CTRT, and clearly there is an improved event-free survival and overall survival in the patients who underwent surgery plus adjuvant radiation. Regarding the doses, this is almost similar to other head and neck cancers. Like in postoperative patients with clear margin, we deliver 60 gray to the tumor bed and high-risk postoperative bed. For those with a positive margin, we escalate the dose to like 66 gray, and in a curative setting, we deliver as high as 70 gray, respecting all the normal tissue. Regarding technique, IMRT should be the preferred technique, because IMRT helps us to give maximum normal tissue sparing. As you can see in this picture, all the normal tissue can be spared well from the high dose region. Optimal dose can be preferred, because this area have various high tissue air inhomogeneity, and dose escalation can be offered with IMRT in required cases. So these are some other rare cases. I'm not going in detail, like skull-based chondrosarcoma, rhabdomyosarcoma. Radiation therapy has some role in the entire course of management. In parotid gland malignancy, although it's not considered as a lateral skull-based tumors, whenever it involves the temporal bone, sometimes it's considered as a lateral skull-based tumor. All those have a high-risk features like T3, T4 disease, high-grade. These tumors are also taken for adjuvant radiation therapy. But radiation also comes with toxicities, as it is similar to other head and neck cancers. In acute cases, we see dermatitis, mucositis, xerostomia. In chronic, in long term, we see hyposalivation, because these are the areas who contain the parotid gland also, trismus, dysphagia, dental caries. These all are the long-term toxicities. So the aim should be to reduce this toxicity. And the technique, therefore the technique should be IMRT, because the same paper from the Tata group has also shown that those patients actually who underwent IMRT, there was almost no grade 3 toxicities in any of the patients. And the long-term subcutaneous fibrosis was as high as 38% in the group who did not undergo IMRT, and as low as 8% who had IMRT. So therefore, IMRT should be the preferred, because it gives us the liberty to use CT-MR fusion for the better target delineation. It helps us to respect the normal tissue, and we can take a daily image guidance to deliver the precise treatment. This is a picture showing how precisely we can deliver IMRT with respecting the normal tissues like brainstem. So now coming to the conclusion, lateral skull-based tumors are challenging because of the complex anatomy, critical OS, and the heterogeneous biology. In benign tumors, RT, that is the SRS, provides durable control. In external auditory canal or temporal bone SCC, surgery plus R0, intent plus risk-adapted RTCT or RT is the standard. Definitive RT or CRT is reserved for unresectable, medically inoperable, and very high patients who had a very high morbidity following surgery. IMRT or VMAT with CT-MR fusion with careful OR sparing should be the preferred technique. So my message is very clear, simple. In lateral skull-based disease, radiation therapy is not an afterthought. It should be planned as early as a part of MDT strategy to preserve function in benign tumors, to intensify local treatment in malignancies, and to reduce morbidity throughout using the modern techniques. Thank you for your patience hearing.
Thank you, Dr. Nath. Do we have any questions?
This query is very nice talk, first of all.
Thank you, sir.
This query is actually directed towards the surgeons, Dr. Pai, and could you just give me an insight, because many a times in glomus jugulare, we find that the person has undergone a surgery and ends up with a lower cranial palsy, or we have the flip side, where patient has undergone a radiotherapy, and then patient comes back with a recurrence or a residual disease. Now the surgeon says there's too much of fibrosis, I can't go in now. So what is the thumb rule, or what do we actually should do as people who like me who'd like to refer a case of glomus jugulare?
You mean post-radiation fibrosis?
No, if we have a patient of glomus jugulare, what is the thumb rule to decide whether this patient goes for radiation, this goes for, say, surgery first?
So I think that talk was very well, put up as to which cases you're going to select out. So I'll bring some points up during our panel discussion. But suffice to say that as it goes superior and it goes intracranial, less likely that you will be able to do the surgery safely. So long as it is subcranial and not involving the carotid to a greater extent, those should be operated. The ones that are involving petrous carotid and going intracranial, beware.
Thank you. Any more questions? Thank you, Dr. Nath.
Thank you.
That was quite a lucid talk. Thank you so much. I'd now like to invite Dr. Ankur Bhattacharya to deliver his talk on role of systemic therapies in lateral skull-based tumors, current evidence.
Thank you, respected chairpersons and my esteemed delegates. So today my presentation will be on role of systemic therapies, what are the current evidences. From the morning lectures, it is evident that the importance of the lateral skull base is because of the complex anatomical structures. But when we consider the systemic therapy, the only thing that matters the most is the histology, not the anatomical structures. Although the direct evidences were scarce, but pooled analysis showing that benefit of systemic therapy in variety of systemic causes and variety of diseases, variety of the staging and the histopathological diagnosis, which we'll discuss in our presentations. Yes, the surgery and radiotherapy is the backbone and it is a gold standard till today, and no systemic therapy can replace that. But systemic therapy is the solution for those tumors which are not amenable for surgery, not feasible for radiotherapy. And we have so many options like in the form of chemotherapy, immunotherapy, targetable therapy available nowadays to treat those advanced diseases. So the only important structure, the only important thing that matters most for a medical oncologist is the histology and the biomarker availability. So suppose we have a disease of temporal bone squamous cell carcinoma, mucosal or cutaneous. So we can estimate different pathological diagnosis here, like mucosal squamous cell carcinoma, cutaneous squamous cell carcinoma, salivary ductal CA, melanoma, leptomeosarcoma. Each and every histology has a different approach. Mucosal cutaneous, obviously we have the opportunity to give the neoadjuvant approach followed by surgery and adjuvant approach. Salivary ductal, there is no question of any chemotherapy, immunotherapy. The surgery is just straight away. Melanoma, yes, immunotherapy, there is a very good response, and RMS, only the chemotherapy is the backbone. So although these are the different malignant tumors, but I will be highlighting mostly on the squamous cell carcinoma, which we get more in case of our day-to-day practices. So why systemic therapy is required? Because the presentation, the patient came with those symptoms who always mimics the different benign pathologies, and it causes the delayed diagnosis. So some resectable diseases become locally advanced and some locally advanced diseases become unresectable. So in locally advanced setting, yes, we have options of neoadjuvant chemotherapy. Neoadjuvant immunotherapy is the new guidelines. And we can tackle the higher disease to downstage the T disease, and also we can address the micrometastasis. But when the disease is advanced and we don't have other options, then we have to search for one important aspect, that is the biomarker. So biomarker-directed therapy is the new norm, and we have to find out what are the biomarkers which we can go and we can target, like PD-L1, HER2, androgen receptor, NTRK, BRAF, KIT, which are relevant to the different histologies. So if we go in depth, So we can see the temporal bone mucosal SCC, the most important biomarker for us is the PD-L1 and EGFR expression. Because if we get a PD-L1 expression more than 20%, if we get PD-L1 expression more than 10%, we can formulate the neoadjuvant approach, we can formulate the systemic approach. And these are the very important predictor for as well as prognostic predictor for immunotherapies. Simultaneously, EGFR overexpression is also important for us. And if we go by the salivary duct carcinoma, it is very important for us because we cannot offer immunotherapy or chemotherapy in those patients. And here the HER2 amplifications, not the overproduction, it is the amplifications. And androgen receptor positivity guide us to formulate the different treatment options in the form of trastuzumab, pertuzumab, TDXD, or androgen deprivation therapy. In other diseases like mucosal melanoma, we have so many targetable mutations like BRAF, KIT, and we can offer our systemic treatment to all those diseases. And in secretory carcinoma, there is newer mutation available, that is the NTRK, against which we can have the TKI therapies. But the important biomarker which is now of importance, that is the circulating tumor DNA. In GI malignancies, we have always incorporated it to the formulate whether the patient need adjuvant therapy or not. And it is the upcoming thing in head and neck cases also. Based on the circular tDNA, we can formulate the adjuvant therapy requirement, whether it is required or not in all the cases of head and neck malignancies. So the biomarkers, that is the driving the entire pharma industry as well as the disease and newer trial modules. And if you go by the 2007, when that was the era of chemotherapy, now it is changed to the entirely immunotherapy. In 2008, we have the EXTREME trial, which is one of the popular trial and important in our day-to-day aspects, where we first introduced the targetable EGFR, that is the cetuximab. And in 2025, the entire landscape is changed with the help of the newer molecule, it is the pembrolizumab in neoadjuvant setting. And now in 2025 December, we have another publications that is on adjuvant nivolumab, that is a newer, totally newer concept in head and neck cases. So what is our current approach? Yes, resectable, go with the resections. Artificiable, go with the artificiable. With pinch of salt with when we have to use the concurrent chemotherapies with like positive margin and extranodal extension also. But the role of systemic therapy lies truly in case of when we consider neoadjuvant therapy, adjuvant therapy, recurrent setting, and obviously it is as part of precision oncology directed. So neoadjuvant therapy, it is not routinely recommended, it is not routinely adopted, but on those cases which are difficult for R0 resection, where we need the organ preservations like facial nerve, T3 high, T4 disease, dural intratemporal involvement, in these cases we have to go for neoadjuvant chemotherapy. So in various trials like TEX 323, 324, we have established the TPF, the chemotherapy, main chemotherapy arm as the main state for which the further treatment has been postulated, whether to go for the curative resection or not, or adjuvant RT or not. In cases of RMS also, the IRS 1 to 4 trials showed that the chemotherapy is the backbone. And in soft tissue sarcoma also, the STS 1001 and Ewing sarcoma, it is INT 0091. They established that induction chemotherapy is the main predictor for OS, not only the resection. So coming to the immunotherapy, this is the new hot topic, and temporal bone or external auditory canal SCC is showing results to the keynote 6 and 9. And the cutaneous SCC to the semiplemip and the melanoma with the nivolumab and nivolumab plus ipilimumab combination therapy. So when disease returns, we have already exhausted our chemotherapy options. So what is our only option? It is the immunotherapy. And in various trials like Keynote 048, 040, Checkmate 141, they showed that even if we have exhausted all sort of chemotherapy, we still have the immunotherapy backbone and we can get a better response in the form of OS in those patients. Simultaneously, in cases of melanoma and salivary gland also, we have a few trials like Keynote 06 and Keynote 028 who is showing the promising results. Now going to the part specific, in temporal bone, whether it is mucosal SCC or cutaneous SCC, what should be our ideal approach? Should we consider the T2, T3 disease, neoadjuvant chemotherapy, neoadjuvant immunotherapy? The answer is strictly no. If possible, we always push for surgery. If possible, we always push for radiation. It is not a standard, but in case of unresectable, difficult resection with difficult R0 positivity, feasibility, then only we should consider the chemotherapy or immunotherapy options. That as far as the most commonly and most importantly adopted chemotherapy regimen is the TPF. In fit patients and on those patients which are not fit, then taxane and platinum is the backbone. What is the then role of immunotherapy? Yes, in neoadjuvant approach, we have the Keynote 689, and in adjuvant approach, we have the nivolumab, that is nivolumab. We will discuss a little bit in that. So Keynote 689, this is a new paradigm shift in the management of neoadjuvant approach. So it is purely planning to do chemo-free. So in neoadjuvant approach, if the CPS score is more than 10, then pembrolizumab 2 cycle followed by surgery, followed by radiation with concurrent with pembrolizumab, followed by maintenance pembrolizumab. They try to do the chemo-free regimen, and it is showed that 11% benefit in case of 3-year event-free survival, and the event-free survival and hazard ratios far better in cases of CPS more than 10 compared to the CPS more than 1. So any patient before going for before counseling for neoadjuvant chemotherapy, as per the NCCN guideline, we always have to look for the PDL1 scoring, and if the PDL score is more than 10, then only we can offer the chemo-free approach to those patients. Similarly, in the adjuvant approach, it is a beyond newer concept. The patient undergone surgical resection with adjuvant CTRT. Those, if we offer the nivolumab for 6 months, we can see the 11% absolute DFS gain, which is very important considering the disease and rarity of the disease occurrence also, and modality of treatment availability. So in recurrent metastatic setting, it is already established that Keynote 048, they showed when the patient is having CPS score more than 20, we have a better response compared to the CPS score more than 1, where we have to add the chemotherapy along with the immunotherapy. And Checkmate 141 revolutionized the paradigm where we consider the platinum was the only responding chemotherapy options. Here it showed the nivolumab after platinum failure also, we can provide the better cure to the patient. So it go by the survival analysis. NATS are already showed that it is a more than 50 to 59%. And the issue is that the favorable OS benefit is seen in case of T1, T2 disease. So if any patient presented with T3, T4 disease, and with the help of neoadjuvant, we can downstage the disease, definitely we can expect the better OS benefit. Coming to the cutaneous squamous cell carcinomas, then we have one wonder drug that is a semiplamib, which is currently, although not available in India, but it is showing in all 3 settings, neoadjuvant, adjuvant, and palliative settings. And surprisingly, in neoadjuvant setting, although it is a phase 2 data, it is showing that half of the cases respond to the therapy and go for completely disease-free. Now, the nightmare begins when it comes to the salivary type malignancies. If it's not responding, then it is very less chance of getting response from chemotherapy also, immunotherapy also, and gives a nightmare to the medical oncologist. Here we have to go by absolutely by biomarker-driven approach. We have to go for NGS. We have to check the IHC to look for HER2 amplifications, NTRK, RAP, MET infusions also, and androgen receptor also. If we find an HER2 amplification, yes, we have so many drugs like trastuzumab, pertuzumab, TDM1, and new wonder drug that is a trastuzumab deruxtecan, with showing the promising result of at least 68% ORR in MITROS trial. In secretory carcinomas, we have different biomarkers-driven approach targeting the NTRK, that is the larotrectinib and trictinib. Yes, it is although expensive, but we have very good data on secretory carcinoma. But adenoid cystic carcinoma, yes, barely we get any targetable mutation. We have to go ahead with the VGF targeted, that is lenvatinib, axitinib in those cases. And RMS, yes, it is excellently responding to the chemotherapy. So chemotherapy is the mainstay in the RMS. And in melanoma also, we have all modalities, that is the neoadjuvant, adjuvant, and palliative setting. We have a very good result on neoadjuvant chemotherapy, neoadjuvant immunotherapy approaches. Coming to other pathologies like giant cell tumors, we have a very good robust data on denosumab. It not only reduces the tumor size, it also do the ossification and do the surgery more easy. And in lymphoma, if we get a lymphoma in the lateral skull base, we have to treat it like a systemic disease, and we have to offer the systemic chemotherapy options only. No surgery, no RT to be given. And the last point, it is the metastasis from other sites. Here also, we have to deal with the primary, not the local disease. If we control the primary, then we can expect the better results with the secondary diseases. So a practical design pathway, how to formulate it. The main issue is that when the disease is resectable or radiation-wise it is curable, we have to push for that. Once it is not curable, or if we consider the locally advanced, then certainly first we have to confirm the histology, then second step will be our biomarker testing, whether it's biomarker availability or not. In cases of squamous cell carcinoma, PD-L1 of course helps us in formulating neoadjuvant therapies. After biomarker deriving, then we can formulate whether we can go for the salvageable approach or not. If it's unresectable disease, then automatically it becomes palliative. Only thing we can offer is the prolonged life with a better quality. And if it's a borderline resectable, yes, we can proceed with the neoadjuvant approach. So what is our future direction? From different studies, it is clear that our future is going towards the chemo-free regimen. So perioperative immunotherapy will be the new norm in upcoming few years. And the circular tumor DNA will always guide to formulate whether we can go ahead with the adjuvant approach or not. And lastly, the antibody drug conjugates are doing in the rare tumors, and the cellular therapy in the form of CAR T cell therapy is up in the upcoming days, which are showing better results of solid tumors like lung and melanoma. So my take-home message is, although it is anatomical structure, complex structures, but it is very important when we formulate the systemic therapy. The approach should be always histology-driven. The squamous cell carcinoma of a site and rhabdomyosarcoma both will work differently, and we have to plan the therapy differently. So future is histology-driven, biomarker-guided, and always we have to be MDT-based. So this is the third pillar of skull-based care that we are offering from medical oncology. The surgery, the radiation, and the systemic therapy and the medical oncology approach should be go hand in hand for a better tripod care. So the previous dictum, Petrus bone, if it is involved, then it is not resectable. It is not feasible for the chemotherapy. That days are over. And Petrus bone is no longer a barrier for drug penetrance. We always look for the molecular targets before the second intervention in the form of radiation or surgery. And now days are coming that we have to go for the molecular-driven approach in the day of the diagnosis. With this, I would like to conclude my lecture. Thank you.
Thank you, Dr. Ankur. That was quite an illuminating talk. Any questions? Can somebody hand him the mic?
First of all, a wonderful presentation.
Thank you.
I'm not asking anything, I'm just adding to what was already been put up. So sometimes we come across issues with very advanced paragangliomas or metastatic paragangliomas where we run out of options. Surgically not resectable, sometimes radiation is difficult. So for that also we have a agent now, belzutifan, which is a HIF2 inhibitors. So recently that has been FDA approved. It's a LightSpark 015 trial. So that also is one of the things that we are considering in various temporal bone paragangliomas and other paragangliomas of the body. Yeah. So thank you. Yeah.
Thank you. Any more questions?
Thank you, Dr. Ankur, for the excellent presentation. Really very illuminating. Just one query. Do you have first-hand experience of using monoclonal antibodies in your practice?
Monoclonal antibodies, sir, pertaining to which site, sir?
This one, maybe RMS also.
RMS, no, sir. It is purely chemosensitive, so we always go ahead with the chemotherapy regimen as per the ILS-4 protocol. We go for the induction therapy, followed by surgery, followed by maintenance therapy. But issue is that in salivary type of cancers on metastatic disease, here we are using trastuzumab-based targeted therapy. Yes, we are using, but the response is not that good. But thing is that the newer advent like trastuzumab deruxtecan, that pool that are showing the better benefit, and because of the cost and thing, we are not currently using in our centers because of the cost only. But in a pool that is showing very promising results.
Thank you. Thank you very much. Thank you, Dr. Ankur. Our next topic is functional impact following lateral skull-base surgery, facial nerve, hearing, postoperative functional outcome. Speaker is Dr. Sean Joseph, consultant head and neck oncosurgeon, Star Medicity.
After Dr. Ankur's talk, I really feel we had some option for
functional rehabilitation as well, because these are very difficult cases we deal in our following lateral skull base surgery. So I'll cover this topic, functional impact following lateral skull base surgery. So any cancer treatment, what should be the goal of a cancer treatment? Should it be tumor removal, or, I mean, we have so many specialties playing a role here. Already we saw the radiation oncologist, the neurosurgeon, the ENT surgeon, the radiation oncologist, medical oncologist. What should be the ultimate goal of treatment of cancer, and are we getting drifted away from the understanding of what should be the goal? It should be restoring the social identity of the patient back as he was before surgery. So lateral skull base surgery, or in fact any complex skull base surgery, these were certain things which we have to look into, that history, histopathology, radiation, the vessels, the venous sinuses, the nerves. And I've always felt it can be used as a mnemonic, like hard ride ahead and very narrow route, which a surgeon has to take. And what is left at the end, the reconstruction and the rehabilitation. So that is what matters most to the patient. So when a patient comes to us for like any cancer, so this is how we are looking at present. Define the person, not just the disease, so that we have to understand whether we are leaving back the same patient who has come to us before, like when he was, as like he was before the development of this disease. So we have to really understand whether he's back to his personality, the previous personality, his profession, his social role. Are we disrupting his financial position? All those things have to be seen. Then only we can understand whether we are leaving back the same person. And obviously we know that we cannot bring him back exactly like he was before. So we have to map the loss. We have to be kind to ourselves. So the loss has to be mapped, and then we can try to do what is best for the patient. So functions at risk during lateral skull base surgery, I am focusing on, there are a lot of issues, but I will be focusing on those things where we can really make a difference as a surgeon. The facial nerve part, the vagus, these are two areas we can definitely make a difference, especially a skull base surgeon, because we are all used to dealing with these anatomy and these surgeries. And the hearing. So it should be a balance of oncological safety with function. So coming to the facial nerve, the first thing is not after, it begins before surgery. Like you should have adequate equipment so that a facial palsy doesn't happen if possible. If it can be avoided, please avoid. But don't compromise on oncological safety. Like if a tumor is there, you take a decision to go ahead with the resection. So, so addressing a facial paralysis would depend on multiple factors, but I'll just go to two important points. One is the duration of paralysis. If a patient is coming to you with a facial palsy, you have to see whether it is less than 1 to 1.5 years or more than that, because that will depend on what procedure you're going to choose for this patient for a facial reanimation. And also the viability of the facial musculature. These would be working in tandem. The viable musculature, the procedures will vary accordingly. So the reconstruction matrix I would like to show in a for a facial nerve palsy would be, on table, if you're finding the nerve anatomically intact, if it's just a neuropraxia, you may consider observation with corneal care support measures. But if the nerve is cut, if the proximal and distal ends are available, direct repair or an interposition graft, cable graft would be, we'll go through each of these in detail. Direct repair on interposition cable graft should be considered. If the extratemporal part is not available, but intratemporal segment can be traced, please trace it and drill the fallopian canal to reach and isolate the cancer-free proximal stump, and still consider a cable graft to the distal end. And if the distal end is available and proximal end is not available, then you can consider nerve transfers like the mesenteric or hypoglossal. Mesenteric is usually done these days. If the distal end is not unavailable or resected, you should consider direct nerve to muscle neuratization or a mesenteric nerve transfer. And if it's a long-standing paralysis, it's at that point you would consider cross-face nerve graft or gracilis free functioning muscle transfer. So we'll go through each of these. Nerve intact, if it's a neuropraxia, we know that we have to give supportive treatment and follow an expectant line of management with serial follow-up. And delayed reanimation if it's not recovering beyond 6 months. If, we just gone through it. If the proximal and distal ends are available, if an immediate tension-free repair is possible, please do it. If a tension-free repair is not possible, you should consider doing an interposition cable nerve graft, which can be greater auricular nerve, sural nerve, because it has excellent length and it can address all the nerves. And medial antebrachial cutaneous nerve is another nerve which is considered. So this is a case where the proximal and distal stumps are available and an interposition nerve graft is placed. If the proximal stump is unavailable, at that point you can consider a mesenteric transfer, mesenteric to facial nerve coaptation, or a hypoglossal, or a dual innervation, which combines a combined mesenteric transfer with contralateral cross-face nerve graft. So in this particular case, the proximal segment is not available. So what is marked as a mesenteric nerve, this mesenteric nerve can be connected either to the distal nerve stump or to the facial muscles. And this was a case where the intratemporal segment is preserved and extratemporal segment was unavailable. So we should consider drilling into the temporal bone, identifying the proximal end and connecting it again with the sural nerve interposition graft. The video playing. Excuse me. Yeah. Sorry. I mean, I just wanted to show that interposition nerve graft works even 8 years after post-RT, is post-radiation also. There's always a doubt whether patients who are going for radiation would have a function. I mean, would these nerve grafts function? But it really functions. When the distal stump is unavailable, you can consider direct motor neurotization. That's the implant. You can use some mesenteric nerve directly to the viable target facial muscle bellies to trigger a neural rescue. And for a chronic paralysis, like if it is the proximal nerve is not available or unviable and muscle atrophy has happened, you can consider cross-face nerve graft. You usually use a autologous sural nerve graft, which is sutured to the healthy redundant contralateral facial nerve branch, like a zygomatic or a buccal. Then you will allow a period of 9 to 12 months for observational phase, so that the contralateral axons traverse the midline. And at that point, if the muscles are functional, you can connect it to the contralateral muscles, or if it is not functional, you can consider free functioning muscle transfer. So again, just coming to that reconstruction summary matrix. So these are the adjunct procedures like the lateral tarsorrhaphy, the gold weight, the eyelid weight, and temporalis transfer, which you can consider. Lateral tarsorrhaphy, if you have nothing at your disposal, this is something which is which you can easily done. You can buy time while you work towards the other procedures. Eyelid gold weight is something which you can do. Usual weight we use in our practice is 1.5 to 1.6 grams. Pre-op assessment would help. It is passive, may not be effective when the patient is supine, but usually the patients don't complain much. But one thing is, which is very noticeable is lower lid is not addressed and the risk of extrusion and passive drift are there. But the advantage would be like it is reversible and it could also be performed while waiting for the results of a nerve reconstruction to work. So this is a gold weight. Oh, and will the video work? Any chance? Any chance? Will the video work? Yeah. The next one, next video. So I just wanted to show this 2-year post-surgery video because just to impress on the fact that the lower eyelid ectropion, which doesn't get corrected with the gold weight, the upper lid is fine. So then now we'll just go to the temporalis transfer. I'll show the procedure. This temporalis transfer is relatively more morbid compared to a gold weight, not reversible, but both lids are addressed. So you have to really choose the patient who to do. Like if you're not going for if there is no possibility of a nerve recovery or the patient may not go for any other procedure, you should consider this. This is a temporalis muscle transfer when fascia slips are marked. And that along with the muscle retracted are placed towards the angle of mouth and the eye. You can use it with a fascia sling as well. Will the video play? It was playing, no? We had checked. Pardon? So that's the lower lid ectropion, which cannot be corrected with the gold weight. Temporalis tendon transfer is a procedure which again you can use, where the coronoid process is cut. And from there, fascial slings are attached to the angle of mouth and the eye. So this is a temporalis tendon transfer, and this one is a temporalis muscle transfer. Both produce similar results. The angle of mouth recovery is not really good. So just a comparison slide showing the different procedures for this. And rehabilitation is very important for all these functional nerve issues of cranial nerves. So coming to the vagus nerve, this is again something ENT surgeons can bring very good results when you're doing lateral skull base surgery. So all these patients, like if you have a ipsilateral vocal cord palsy, the patient aspiration may be the major issue, with supportive therapy you can improve it, but dysphonia can remain. So the clinical decision drivers would be that if the pre-op vocal cord function is normal, you may observe. But if preoperatively you're seeing a paralyzed cord, the compensation is unlikely. So consider augmentation, like if the patient is symptomatic, and also do a periodic assessment of aspiration before deciding on the procedure. So before going through the procedures, I'll just try to tell what do we aim to achieve in a vocal cord palsy, like restore mass, tone to the vocal cord, compliance, stabilize arytenoid and medialize vocal cord, and we are not aiming at arytenoid move action by these procedures. So we'll just go through the procedures. This is a fat injection medialization. I think, there's an issue with the audio again, but these are procedures as seen. ENT surgeons we can do and give good results give good function to the patients. And now between injection laryngoplasty versus medialization thyroplasty, injection, as you know, is a minimally invasive and repeatable procedure. Thyroplasty, though, gives a durable, adjustable and immediate improvement. It has a rare risk of extrusion, but you need the expertise to carve the implant and place it. Now just coming to the re-innervation part. In lateral skull base, what we would generally require would be a non-selective re-innervation. Ansa cervicalis, you can connect it to the recurrent laryngeal nerve. Any chance of getting the audio? Maybe getting an audio jack.
Three, four, five, 6, 7, 8, 9, 10. 2, 3, 4.
So non-selective re-innervation, answer to recurrent laryngeal nerve stump we can do. This is not related to lateral skull base, but this is answer to direct muscle neurotization is also possible. These can all give good results. So non-selective re-innervation should be a good choice in young patients, and it doesn't involve the inclusion of a foreign body, foreign material. So those are its advantages. Though the need of expertise and it's a little more time consuming can be considered probably a disadvantage. So as a take-home message, glottic incompetence is a major functional consequence, and aspiration may be more important than voice quality, but it can improve with swallowing therapy. And thyroplasty can provide durable correction, while re-innervation offers physiological and long-term benefit. So just coming to a last slide, this hearing rehabilitation, there are different options. Hearing also should not be ignored, but patients usually have the opposite ear hearing preserved, so patients don't complain much, but all these could be an option and should be considered for a patient who desires it. Thank you. Thank you for the patient listening, and sorry for the technical issues in between.
It's a very nice talk, Dr. Joseph. In an era we are talking much about organ function preservation and improving the quality of life. So any questions from the from the audience?
No. Just answer is no. And very few patients would choose it also. Or all the rest of it can be done, but cross-face nerve graft, gracilis, very few patients would choose.
Dr. Rupjyoti, you want to ask something? No more questions?
Non-selective reinnervation gives good results. Especially if done immediately, we will get good results.
It gives a good result.
Yeah.
Okay. Thank you.
Thank you.
Thank you, Dr. Joseph. The next topic is what's new in lateral skull-based tumors, innovations, technology, and future directions. Speaker, Dr. Prathamesh Pai. He needs no introduction. Thank you for coming.
Good evening, everybody. And I think Kabiri made me talk about this with the intent to summarize the whole day and not just talk about what's new. We are dealing with rare tumors, and the whole day around we have been discussing about investigations, the imaging, the surgeries, medical oncology and radiation oncology perspective. And we have run the entire gamut, including the surgery for these tumors. So when I was trying to understand what to talk about it, I thought the more we look back into what we have done with these tumors, the more we might get different perspectives into how we are going to manage these ahead. So way from 1883, where they first started doing these surgeries, we have come a long way. And we have realized that we don't want to operate these very extensive tumors in the deep recesses of very awkward anatomy and then having poor outcomes. So earlier on, everybody would be sent for radiation. And they realized that this radiation was not really very effective. And then when someone like the meta-analysis from Lewis started doing it, and they published their data on the first 100 cases, we realized that we were getting good results with surgery. And from then on, surgery has remained the mainstay of treatment. And then we realized that surgery alone was not adequate and that we needed to offer something more because we are dealing with tumors where we cannot get complete margins. In surgery for cancer, when you remove the tumor completely, you get the best results. All data across all head and neck has consistently shown that if I have a negative margin, my patient will do well. So we realized, and you have heard the radiation oncologists also talk about data where stage 2 onwards, T2 onwards, you might have to consider radiation alongside your surgery. And we have seen that surgery followed by radiation gives very good results. Now, I put up this data of R-block resections where radiation was not being considered. So survival rates are less than 40%. But then when we started doing resections along with radiation, and the later half of the data you're seeing where they talked about piecemeal or sequential resections, but they were also offered radiation alongside surgery. The survival rates have increased, and today we are hoping for 100% local regional control in stage 1 and 2 cancers. So when we reflect back and we understand what's happening with these tumors, we realize that there are certain peculiarities of the lateral skull base. 75% of these patients don't have facial nerve involvement. So when we are trying to treat this, we need to focus on the quality of life. You heard how Sean talked about rehabilitating the patient back to society, and that facial nerve is one of the most important considerations. And if we can avoid even resecting it, that much better. We can avoid even reconstructions. Another aspect is we need to focus on preventing cancers altogether. 30% of our patients have CSO. And we know that from our otologic practice, this occurs very early on in the age of the human. As a child, you start having CSOM and it continues. So there's a long duration for where the person can have chronic inflammatory processes going on, which eventually can lead to cancer. So we need to focus on preventing these kind of episodes. And many of our patients don't have this history of matchstick usage, exposure to radiation, none of them. But many of them do give history of CSOM. We need to focus on doing less. And that has been the consistent trend in the surgery in the past 2 decades. We are trying to do less for our patients. And that is because we are understanding more about how does this disease manifest, how it spreads, and how are we able to contain it. The Halstedian principles of en bloc resection really do not hold value today because we are focusing on removing the last shred of disease. So it doesn't really require to remove the entire organ at risk. And truly, you heard about how Deepa talked about the need for doing a sequential resection because disease doesn't follow an organ. Disease will not remain confined and may not really be there right in the center of that temporal bone. So just because you have removed the entire temporal bone completely doesn't mean this patient is going to be cured. And often we find that the tegment tympani is never involved. So there is never an extension going towards the cranial cavity. It is always, in most of the patients, hypotympanum and anterior. So we are left with a situation where you might remove that entire bone, but again, you'll have to drill the peripetrous ASL system. You might have to remove the tissue near the styloid process. You might have to remove the TM joint because the disease is creeping along the eustachian tube anteriorly. So keep in mind that you might have to do something less. 30% of the only 30% of our T4 cancers had intracranial extension. So if we did a craniotomy, and it is not a small craniotomy, we do 4 centimeters of temporal bone resection in order to reach into the subacute eminence for us to do the craniotomy, the osteotomies. So in 70% of patients, you will have to do this unnecessarily because the disease was never in that region. So disease extension at sites of osteotomy, and the osteotomy sites are the subacute eminence, the pre-sigmoid area, the stylomastoid foramen, and in the glenoid fossa. In order to reach all these areas, you're going to have to consider mobilizing the TM joint or resecting the condyle, a large craniotomy to reach the subacute eminence, going to the pre-sigmoid area, potentially damaging your sigmoid or rupturing the inferior petrosal sinus, and the stylomastoid foramen, wherein you might leave behind disease at the styloid. Another thing that we need to avoid is the redo surgeries. We in institutions will get referrals because these patients have been diagnosed to have squamous cancer following a regular tympanomastoidectomy. Today's day and era, we can avoid this. We need to do proper imaging for our patients, avoid doing unnecessary surgeries, and try to have a high index of suspicion that this patient may have something more vicious when you start to see granulations all along the hypotympanum, or something lurking only in the extrinsic canal. So you need to realize that in almost 50% of these patients, it arises from the extrinsic canal and then goes into the middle ear. So if you are finding that your so-supposed CSOM is predominantly in the extrinsic canal, you might not be dealing with a cholecytoma. Why should it involve the extrinsic canal skin and then bone and then go reach the tympanic membrane and stop? That means there's something wrong. This is not a cholecytoma. So if you can avoid a surgery wherein you then now have granulations which show squamous cancer, or maybe just the skin which you took for biopsy showing a cancer, and then referring it for further treatment, redo surgeries can be avoided. As I said, when we were doing subtotal temporal bone. So we had to remove the condyle and we had to enter the glenoid fossa for doing the osteotomy. So when we sent this condyles for examination, we found only one was involved. So unnecessary removal of these normal joints happened just because we had to conform to a particular surgery to remove a cancer. So subtotal temporal bone resection meant a larger craniotomy, obligate resection of the facial nerve, obligate resection of the TM joint, inadvertent injury to the sigmoid sinus and the inferior petrosal sinus. Wherever there's surgical, there was bleeding. Possibility of residual disease, which can be missed. We were doing heroic surgeries. We were knocking the bone and then having bleeding and then packing. And you have, or some of you may have experienced sigmoid sinus bleeds, and they are horrendous. And at that point, when you're just packing, imagine you have bone dust all around where you may have cancer cells in it, and you're packing. Now, this is a potential for a disaster. A chance of recurrence is very high. So we can avoid all this. And this is an elegantly done surgery, achieving the same clearance. We have cleared the tegment. We have cleared the entire otic capsule. We have removed the entire mastoid, exposed the sigmoid from the sinusoidal angle right up to the jugular bulb, and we have preserved the facial. Without much bleeding, you have removed the tumor, but yes, it has not been an nerve block resection. So this is something that we should try and endeavor to do, and this will happen only if you study your scans carefully to understand what is the root of that tumor. So we did find that the recurrence pattern, when we did modify it, was extremely low because we actually are chasing the disease rather than trying to remove the bone. We found that the median overall survival rates were very good. Stage 1 and 2 reaching 91% and stages 3 and 4, 69%. So survival is not affected and form and function is preserved in early cancers. And even in stages 3 and 4, you may have good survival if you do good resection. So this bore well with literature, and our results were similar to the ones that we saw. And then, of course, the radiation oncologist also alluded to. We realized that IMRT is a better therapy, and adjuvant therapy is required, and we would offer them to anyone T2 and above. And with a proper multidisciplinary thought process, the patients post-op would all go in for this therapy, and we had very good results. So surgery and adjuvant radiation is the mainstay of treatment, and IMRT is the preferred modality. The meta-analysis also bears that the 5-year overall survival in 31 publications was 60%, and the ones that were stages 1 and 2 reaching almost 82%. They, however, talked about neoadjuvant chemoradiation as inconclusive, and that's where we seem to have a point to think about. So when you look at the lateral skull base, anything that is superior and posterior, you can resect properly, because that's where you can get a good access to areas. You can remove the tissues. When it comes now going towards the temporal fossa, you have a little bit of worry. And then when it goes toward the infratemporal fossa, you are worried because now the tumor has entered into spaces where there are a lot of conduit of vasculature, neural tissues going back and forth. So this is something that we need to focus on. We have better technology in terms of imaging. We can address these areas better by discussing whether it is resectable and what actually prevents us from doing that surgery. Total temporal bone resection was a no-no, but today, when you are able to mobilize the carotid, you have better skills as endoscopic surgeons to handle the carotid at the clivus and at the clinoid. Why can't you deal with it in the parapharyngeal space? And of course, we need to look at collating the data. Every once in a while, each one of us has 1 or 2 cases, but if it is combined in a database which is there in each region, you might have better outcome analysis. So this has to be done, especially since there is an established skull-based center in the Northeast. This will be should be the nodal point to collect data from across the 7 states. So then when you look at lateral skull base, what strikes to you is biology still is the king. You will be defeated if the tumor is bad, high grade, and cannot be contained. Technology is there for us to use, and of course, precision medicine seems to be something that we all looking forward to. What strikes us is the biology of the disease is that we understand better if we know more about the molecular nature of your tumor. So we know from our head and neck squamous cell cancers that there's a lot more than your grades of tumor, your perineural spreads, the TNM classification. They are no longer something that we can use adequately to prognosticate. You need to know more about the stroma. You need to know more about the spread, the mutations, and possibly you might understand better why these patients develop the temporal bone cancer in the first place. Not every CSOM develops it. So why did this patient develop? So that is something that I would want to analyze, because this is something if we are going to get 20 or 30 cases in a year in a referral center, this is a rare tumor, and you need to know more about it. The moment you get a patient with temporal bone cancer, everything about that patient should be analyzed, because that's something which will help us treat these patients better in future. We need to know more about why this is occurring in the hypotympanum and why this spreads into the infratemporal fossa. We all talk about oral cancers and we say that supraanal disease is bad. But we know that diseases which are posterior to the midpoint at the sigmoid, diseases that are inferior to that notch, are not too bad as the ones that are supranotch, medial, anteriorly. So possibly these tumors which we are saying are not resectable or not worth resecting might be not true. As I mentioned, Peter's apex need not be a possibility, not a surgical possibility. We talked about pathology, and we know that there are a lot more tumors that occur in this area. not just the squamous cell cancers. And maybe we need to deal with them differently. The minor salivary glands, the adenoid cystic tumors, these also occur in the temporal bone. And we know that they behave differently. They can be managed with systemic therapies better, and maybe even different types of radiation better than surgery and radiation. So we need to possibly look ahead and redefine unresectability. We need to take on ourselves the task of studying each of these so-called unresectable tumors and trying to see, can we do more? In a hurried joint clinic, it is not easy for us to pay attention to these tumors. And I'm sure 25 patients in a year, it's possible for us to do more. Technologies are here, and I think in institutions where we have access to these, we need to do better analysis. We are doing MRIs, but again, we are saying that they fall short. We are not able to study the middle ear better. We have got dual energy CT scans, and we know that we can do CT angiographies, we can analyze the vasculature better. So in order to know whether the tumor is actually involved, the paraganglia around the jugular, where is the extent onto the carotid, just the way Bishwajit was talking about analyzing the vestibular schwannomas, the cancers can be analyzed better. Because you need to know where all the tumors can be resected. And these are skull-based at the junction of the viscerocranium and neurocranium. So the knowledge between the neurosurgeon and the head and neck surgeon needs to be re-looked at carefully, because you need to understand what are capabilities of each of the surgeons. There's a possibility that we are using virtual surgical planning for reconstruction. But the virtual surgical planning can also be used for resection. So there are models which are developed wherein you will practice either on the computer interface or physically with the tumors which are 3D printed, and test out your surgery before you actually do it. So this is something that has been done in the spinal cord, has been done in other complex areas. And I'm sure this is not something that is not doable. It's easy. It's easy for us to do the 3D printing. Everybody wants to get into robotic surgery, but I'm looking at it on the different perspective. When we are using the microscope, we are having a lot of issues, in the space that we are operating. But then when we use a device which is like an endoscope, like a VTOM, and you have magnification which is at least double or 3 times that of a regular endoscope, you will be able to see better. We are seeing futuristic ideas where on a large screen you're operating and you're actually seeing superimposition of your imaging, you're seeing superimposition of the tumor tract, and possibly that will help us do a better surgery. So there are now devices where you can use an endoscope as a microscope replacement, and with a robot, it actually will be able to plan out your pathways of surgery, and you can actually use that to do a better surgical resection. Artificial intelligence is here to stay, and we know that imaging pathology has completely been radically changed with AI. So in future, our pathologists and radiologists will be guided by AI in order to look at the problem areas on their screens. So they don't have to actually look out for that whole problem. They already know that this is the area that we need to look into. So we can possibly use this kind of imaging, and TMH already has a biobank of images of pathology and the clinical. So these kind of approaches using the artificial intelligence to direct us as to look out for the disease in certain areas can be a future direction. So maybe also we can use this to predict outcomes so that we can counsel our patients better. So I leave you with some food for thought, and we have had a great day so far, and it's time to reflect and understand how we can do best for our patients. Thank you very much.
Thank you, Dr. Pai, for the excellent and thought-provoking talk. Is there any questions from the audience?
So one question. So what is this radiogenomics which is coming up nowadays?
So the same thing we are talking about, the data which are being collected. So radiology images, the pathology data is being collected and analyzed. So you must have heard of the genomics data. The genomics is something to do with the molecular signatures of the tumor to understand the changes in the mutations that have happened that have led to this tumor, or understand what are the different changes in the DNA structure. So combining the radiology with these changes, we can actually understand where is that change that has occurred at the genetic level and how it is reflecting in an imaging form. So biobanking is what is being the main thing that has happened in the field of medicine in the last 10 years. So clinical data, which is your gold standard, is now supplemented with radiology and pathology in order to develop futuristic models of prediction of how this patient is going to do well. We heard of nomograms which are developed, and that's based on standard clinical and pathology data. But combining that with the genomic signatures will help us understand how these patients will do well. We have got new targeted therapies. We have got precision radiation like proton beam. We have got better surgery. Now, how will all of this integrate into doing well for the patient? And to top it, we know that the biology defeats all these three. So if I know more about the tumor and I then understand where is that tumor and how we have dealt with it, we might be able to explain to the patient better what's going to be the outcome.
Thank you, sir.
Thank you. Thank you very much.
May I request Dr. Jyotiman sir, Dr. Ankur sir, and Dr. Sean sir to come onto the stage for a group picture? And sir, Dr. Prathamesh sir.
One second, please. With the permission of the organizers, I'd like to take 1 minute. I'd like to extend a cordial invitation to All India RhinoCon to be held in Guwahati on 31st October and 1st November. And I request all the esteemed delegates who are interested to submit the abstracts for the conference. And the conference is going to be in Radisson Blue, Guwahati, and the date will be 31st October and 1st November. Thank you. Thank you very much.
Moving on to panel discussion, I would like to invite Dr. Prathamesh sir to moderate the panel. Panelists for the session, Dr. Sean sir, Dr. Brian sir, Dr. Gautam sir, Dr. Rupjyoti sir, Dr. Ankur sir, Dr. Pratap sir, Dr. Rajeshri Das.
Hello.
We can call them ahead. So we have got 45 minutes, 44, 41 now. So we have with us the surgeons, Brian and Gautam Khan, sir, Dr. Rupjyoti Hazarika, neurosurgeon, right? Yeah. And then Dr. Gautam Sarma, radiation oncologist, Ankur Bhattacharya, medical oncologist, Debjani Phukan as radiologist, not yeah, I'm sorry. Oh, it's different. Okay. Okay, Dr. Pratap Kakati is a radiologist. Dr. Rajeshri Das is a pathologist. And we have Sean who's joining us also for the panel. So please feel free to ask questions and, please hand over the mics in the audience also so that they can ask questions. So I'm going to start with discussing each of the lateral skull-based tumors that we normally deal with, and let us understand how the group will plan out the treatment. So 25-year-old mass, 25-year-old male presenting with a mass in the extraordinary canal, a biopsy proven as a squamous cell cancer. Patient has no facial nerve palsy. So this patient presents to us in the joint clinic. How do we plan the treatment? Sean? He gives past history of CSOM and all that.
Yeah, so, I mean, you're asking from now on how.
Yeah, now on, what will you do?
I would be interested to know the extent of the disease. So the radiology planning, and depending on the extent, how to plan the surgery and what could be the
audiogram. Would you do audiogram?
Yeah, definitely I'll do an audiogram.
So why do we do audiogram?
Two things, like that will also give a hint towards the extent of the disease.
Right. Okay. Dr. Gautam Khan, sir, why would you do an audiogram?
Yeah, first of all, I would do a general examination of the patient. I'd look at the cranial nerves, the facial nerve weakness, etc.
Right.
That will give me a guidance in the very beginning. And then, as Dr. Sean has said, radiological investigations like a CT, high-resolution CT, and then MRI definitely, to know the extent whether I'm going to refer the patient to somebody else or try to handle it myself. And audiometry, yes, to know about the hearing status and also to sort of counsel the patient that what would be his post-operative outcome. And also that will also give us an idea whether there's some intracochlear invasion of the disease.
Right, and also about the residual hearing on the other side, so that we can counsel the patient. Dr. Kakati, what would be our imaging of choice in this kind of patient?
There is a mass in the external auditory canal. So first choice is the SSCT, basically to, I will be happy if we have a contrast along with contrast and MRI.
So the common perception here, everyone sends for HRCT and thinks that they will not do a contrast. So is that something that we need to change?
In contrast, CTs cannot make out whether it is secretion or mass. So CT is for detailing of the bones, basically. In MRI, basically, where is the actually mass, where is the culprit, other than the secretions of the other things. So both imagings are very important in this case.
So it is very important to understand that when you say high resolution CT scan, your radiologist may not do a contrast scan. So you need to ask the radiologist to do a HRCT as well as a contrast enhanced scan, because you want to know everything about that patient. Yes, sir. So there's a mic there.
Yeah, sorry. Just for the information of the youngsters, many of them just write a CT scan temporal bone. That HR is often left out.
Right. Dr. Kakati, what exactly is HR? I mean, we need to get these messages across.
Yeah, HRCT is a high algorithm CT. Basically, we have a very thin section, 0.6 mm thickness with 1 mm interval or 0 mm interval. Basically, we do in 0 mm interval with 0.6 mm. So it gives you a very better details of the bones. If you do 5 mm sections, it's difficult. Even differentiate from a soft tissue mass is also difficult. So HRCT is the most important. HRCT is nothing but a very high resolution thin cut CT.
So we know that our entire area of interest is 1 by 1 square centimeters. And in that, if I miss by doing a 3 mm cut, I will lose out a lot of information. We talked about doing VSOP and all virtual planning. You can't do it if there are gaps in your imaging. So as Dr. Kakati said, you need 0 gaps and
no
as thin cuts.
No interstitial gapping. This should be overlapped, basically.
Right. So we are going to do a high resolution CT and we are going to also do a contrast scan. So this is something that we will want to do for our patient. And this is how we are going to get that image. Dr. Kakati, can you tell us? I just have one image for you.
Yeah. You have this coronal scan. You have seen the soft tissue lesion in the posterior aspect of the EAC going towards tympanic membranes. It's not going into the hypotympanum or mesotympanum. So you have to modify the window to see the whether body destruction is present or not. The main important for radiologists you do not know whether it is you are dealing with a cancer, your cholesteatoma or keratosis occurrence. So based on the bony erosion, we usually decide to know the etiology of this particular lesion. So here you have a soft tissue mass in the posterior wall of the EAC. Bony part, I don't know what it is or not.
Yeah. So my next question to you is about the bony canal. How will we know more? Because we know that in the Pittsburgh staging, we have to document whether that bone is eroded or not.
Yes.
So how important is it for the radiologist to report this?
Bony erosion is the most important part.
Yeah.
So we see all around sagittal, coronal, axial, all around you see any subtle bony irregularities caused by this mass, particularly in relation to this mass.
Right.
So generally periosteum is a smooth contour. So any abnormality in irregularity is suspicious for bony erosions.
Okay. Brian, you want to add anything? When you're seeing a lesion like this, which has got a soft tissue mass at the floor of the axonodic canal, what are your thoughts about it? the disease.
I would like to know, it look like it has gone to the middle ear. The ossicles seem to be involved according to the scan. So if the TM is being bypassed, then see our treatment will be different. So this seems to be like encroaching into the ossicles. Of course, not going to the middle wall of the middle ear. So I think we'll like to know the extent of the tumor medially on the radiology point, on the radiology side. We would like to know the extent of course, it's not going medially to the inner to the hypotympanium, but basically it is going to the this one. It has destroyed the TM and it's gone to the ossicle. So I think this point we'd like to know from the radiology because it will change.
So Dr. Kakati, how will we solve this problem? He feels that there might be some disease in the middle ear.
Here you can see the all scans. I don't think it's going to the middle ear because it's limited to the implant membrane medially.
Right.
Okay, there is no soft tissue in the hypotympanium region of the major tympanum. It is just about the attachment side of the handle of the malleus. It's not going epitympanum also. It's not going to the scrotum also. So it's a limited disease mainly in the external body, the bony canal.
Bony canal. Okay.
Yeah.
No, just to add, as we can see on the scan, there's definitely some bony irregularity in the floor of the external canal. It's not a smooth contour as Dr. Kakati has pointed out. The soft tissue is attached to the tympanic membrane, so we know that the tympanic membrane should be involved, but it is also touching the tip of the handle of malleus.
Right.
So most probably the ossicle is also involved.
Right. So we know that, yes, sir. Patient presented with a history of CSOM and the mass seen in the external canal.
And your hearing status?
Hearing was reduced in that year. He's a 25-year-old male.
Do we have an audiogram or?
No, sir, I have not put up an audiogram. But he had decreased hearing. It was about 30 dB hearing loss in that case.
Okay.
Yeah.
Conductive loss.
So whenever we have this kind of imaging, and you know that your lesion is coming onto the bony canal, abutting the tympanic membrane, as Dr. Count said, is a possibility of middle ear involvement. Brian felt that it might be going into the middle ear. You also need to document where is it, anterior canal wall or posterior canal wall. Is it circumferential? Because it is important for us to know whether you will do a parotidectomy. We heard about parotidectomy. You heard Deepa tell us that parotidectomy might not be required in all cases. But we are aware that there are natural canals in the tragus that will allow the spread of the disease. And also if the lesion is abutting the anterior canal wall, you might have to consider doing a parotid resection. So generally, when I do a CT scan, this is the algorithm that we will follow. We'll see whether it's only limited to the external canal or is it going into the middle ear. If it is involving the external canal, is it only limited to cartilage or is it going into the bony part? And when it goes to the middle ear, is it involving the petrous apex or not? So these are, your immediate discussion points when you are seeing a scan. So when we are discussing with the radiologist, it is incumbent on us to tell them that these are the things that we are looking for. So we are working towards synoptic reporting, and they will do the synoptic reporting if they know what you want out of that scan. So when you tell them that I'm dealing with a cancer of the middle of the ear, and I want it in this format, they will give it to you in that format. Of course, it's not taking away from their description of the disease, but it helps you eyeball that report and make a quick decision. So, Ryan, I'll start with you. Will you operate this patient or give radiation?
See, surgery will be first thing I have had to do surgery for this case. It's a good case for surgery. In fact, I will be.
So your hands are itching. Like all surgeons want to operate.
No, but this is if there is no, I think this is a good case for surgery because see, the tumor is onto the canal wall of the canal, and the canal is a bony canal, and radiation given may no work very fine.
But so Dr. Sarma will say, I'll radiate.
But still radiation may.
For him also, it's a nice case.
Yeah, it's Pittsburgh 1.
Yeah.
So bone is
T1.
not,
But bone is not involved.
Yeah.
But
So we can go for.
It's a T2 because of the size.
Yeah, size is little more, but bone is intake, whatever I have seen.
Yeah.
So we can go for brachytherapy also. That
So
is
what brachytherapy?
So HDR brachytherapy, 4.5 gray daily for 5 fraction we can go.
But is it available freely?
It's in all the centers it's available.
So you do a year mold and you will do this?
Yes, we have to, now to 3D printing has also come, so we can take help of that also to place our catheters.
So what is the advantage you see if you radiate this patient?
So first of all, like...
will you combine it with external radiation or only?
No. Only HDR brachy only. No external beam radiation.
So would you tell us the difference between external beam and brachytherapy?
So in external beam, the beam has to come from outside. So once it hit the tumor, it has an exit dose also. So there is a chance that his hearing might again go a little low after the radiation. There is a chance. But in HDR brachytherapy, since we'll be placing a catheter and giving a dose to just to local area, so the other complications are actually low, and dose fall-off in brachytherapy is very sharp. So that saves the other structures, nearby other structures.
So Brian, why would you not radiate?
I think this is really, I think radiation also do equally good job. But as a surgeon, if the patient come to me first, I will take him out for surgery. For me,
Brian, we are in an MDT. We can't make this decision.
But we have to look at the age of the patient. He's a very young patient, only 25 years old.
Right.
So he has got his life ahead. So you occlude his ear canal. He cannot wear a earpod.
Right.
So earpod and listen to music. So you have to take the option. You have to explain to him that these are the two options before you. If I do a surgery, you're going to close your ear canal. That will be forever. Or if you're going to radiation, you might need the surgery, no doubt, if it doesn't work out.
My only concern will be his age for a secondary cancer. Right. Otherwise, like disease-wise, we can easily treat by brachytherapy. Temporal, so age, if it is more than 40, I would be happy to treat with radiation. Secondly, for temporal lobe necrosis, since I'll be using brachytherapy, doses won't go to
6 weeks of radiation.
No. For brachytherapy, it's not 6 weeks. For external beam, it's 6 weeks. It's 5 fractions, 4.5 gray. So we can always control it and control the dose. Nowadays in brachy also, like IMRT, we can reduce the dose to this structure. So we have that optimization available nowadays. This paper said that almost equal outcomes, HDR brachytherapy and surgery for T1. adjuvant. Yeah, but it's so from T2 onwards, this thing is recommended, T2, T3, T4, then node positivity. But seeing his age, actually, I'm a little, this thing, 25 years, and then now already resected. So I have to use external beam radiotherapy for this patient.
Right.
So there will be a higher chances of osteomyelitis, osteoradionecrosis, then secondary cancer, all these things. So we have to counsel the patient regarding the late side effects of radiation.
So suppose I send this.
Oh, like in all cases, we look for the operative nodes. And since like already margins has been this thing written, like its closes is only 0.5. So I'm like quite fine of keeping him on observation.
So, Sean, what would you actually write in the notes that will help the radiation? What should we actually write if you want to avoid it?
Probably there is extension into medullary cavity. Vesicles are not seen actually in the cuts. This scans, I don't.
I'm sorry, but I'm putting in a spot, but this is the best I could do.
This is soft tissues window only like that.
Yeah. Is there any concern for the anterior tympanic ring erosion?
Yeah. Yes, yes.
And the eustachian tube is okay?
Eustachian tube is okay.
So what other imaging would you want for this patient?
Basically, we don't know. Along with the CT, we need a MRI also.
Okay.
To see the extent of these soft tissues, basically to see the involvement of this inner ear structure also, then TM joint, then medially skull foraminal cells are okay.
Yeah. Okay, so we will ask for the images because we want to know about the full thickness involvement of the exonotic canal and whether there's an involvement of the mastoid. And as I was prodding Dr. Kakati, I wanted to know whether there is involvement of the eustachian tube, whether there's involvement of the cochlea, whether there's involvement of the anterior tympanic ring. Yes, sir. Yes.
Yes, all around.
All around, sir.
All around.
So the anterior ring, anterior tympanic ring, posterior canal wall, all eroded. There is suspicion of the TM joint involvement.
In this case, static images is difficult, but if you scroll the images from anterior to posterior, from superior to inferior, then we will get all information.
So we'll need soft tissue, this thing, delineation all around then.
Yes.
In that case.
So we will require an MRI, and I asked the question in the morning, would you do a venogram in these patients?
Yes, I because probably mastoid is involved.
Right.
So to rule out this sigmoid sinus, the venogram is very important.
So the MRI is
sinus and straight
right.
sinus and canvas and sigmoid. And these are big sinuses. You have to rule out the thrombosis and other things.
Right.
Layering of this.
So we will do an MRI. We want to know about the TM joint. We want to know about the parotid. We want to know about the eustachian tube. We want to know about the sigmoid sinus. And we want to know about the neck nodes. So one imaging that will help us sort all this would be an MRI. And that is something that we should order. We should, whenever you get a patient coming to you with just 2-3 CT scans and you are seeing this, please redo the CT scan because that is important for your decision making, and at the same time get an MRI done. So I think whenever you are in doubt, please repeat the scans because that's going to be important for this patient. Remember, only 25 to 30 cases you're going to see in a year. Please investigate thoroughly. So now, this patient has a middle ear involvement. I would ask the medical oncologist, would you consider giving now, with the new information that we have, whether this is suitable for neoadjuvant chemo?
Certainly, sir. That the disease extent is very high in T3, and along with that, we want to conserve.
The patient is operable, right?
Okay.
So,
concerning the facial nerve preservation, definitely we should go ahead with the neoadjuvant so that we can clear up the surrounding tumor bulk so that we can safely preserve the facial nerve. So definitely
do we
should
have
go
any
ahead.
data for facial nerve preservation with chemotherapy?
So that is the main gray part. There is no definite data. Actually, all the trials, they majority of skipped temporal bone SCCs.
Right.
But from extrapolating data from the other head-and-neck trials, so we can expect some good results with the chemotherapy-based regimen.
Okay. So as of now, there is not much of evidence and to give pre-treatment chemotherapy, pre-surgery
Yes.
chemotherapy. So for the surgeons, if we can't give chemotherapy, how do you counsel for facial nerve preservation?
Since the facial nerve is not involved pre-op, so we are expecting most probably we'll be able to preserve it, but at the same time we should counsel the patient regarding a possible facial nerve sacrifice on table. And in that case, We will be planning a subtotal temporal bone resection, a drill-out procedure for this patient. So a facial palsy, and if required, any procedures for that need to be explained to the patient. So that will be what I will do.
Brian?
This case, I think though the CT scan, the film is showing not involvement of the bony covering the carotid, and also the eustachian tube is free. But see, behind it, a lot of soft tissue. I think the facial nerve may have to go in this case.
Okay.
But of course, I think the facial nerve have to go in this case.
So you will sacrifice the facial nerve.
Otherwise, we will not be able. I think otherwise we will be missing. I think a lot of. I think we will not be able to do a good job at this case.
Okay. So on imaging, would you be able to make out if the facial nerve is involved or not?
By imaging, I don't think we'll be able to make out, but the way the soft tissue involved in the whole middle ear, and then.
So Dr. Kakati, if I show you this scan and I ask you to comment, is the facial nerve involvement possible? Would you be able to comment?
The plain one, no?
It's too
Actually, I need actually contrast.
Okay.
Contrast. Anyway, any CT scan, definitely you can make out the
This is a contrast enhanced scan.
So we rely on basically two things. One is thickening and enhancement of the nerves.
Okay.
So if I see diffuse enhancement along with the tumors and thickening, definitely facial nerve is involved.
So
Then,
this is the facial nerve. I mean, this is the scan, contrast enhanced scan.
Typical, I have to see.
Oh, it's good. It's too difficult for you to see.
I think some widening in this one, stylomastoid foramen region.
Right.
So this is one of the clue of the involvement of the facial nerve.
Okay. So even though you might not see it on your imaging, please ask the radiologist because you will need to make that decision and counsel the patient whether you want to sacrifice the facial. As Brian rightly said, this seems to be going into the hypotympanum and the facial recess area. So you might not be possible to save the facial nerve. So though the patient may have an intact facial nerve, you know that intraoperatively you might have to sacrifice it. Okay. So let's go to the reconstruction. How do you reconstruct the facial nerve, Tom?
For this particular patient, we can consider, like, we are not really sure. For me, like, I wouldn't.
So we did a resection of the entire middle ear and everything, but facial nerve was normal. So we got that entire facial nerve stump in front. So how do you reconstruct this?
The facial nerve stump is intact. We can consider an interposition nerve graft with the distal end.
Okay.
So that would be a good option. Greater auricular nerve, if it is available, or a sural nerve.
To which nerve?
From the proximal facial nerve stump.
No, but we have taken off the whole temporal bone right from the first genu onward.
There is no facial nerve.
No facial nerve.
No facial nerve stump. So in that case, we can consider doing a mesenteric nerve to the facial nerve distal end.
So we have done, in this case, an answer to the facial nerve. So this was done almost 15 years ago. So do you think we would have done this today? To the main facial nerve trunk. Should we do this or?
I think today most probably people would consider doing a mesenteric nerve, which is available and safe there.
Right.
And also for a temporary solution, maybe gold weight for this patient.
Right. So it's very important to understand that when you do a reconstruction of the main facial trunk directly, there will be cross innervation, and this patient will have a lot of synkinesis going ahead. So this seemed to be a good idea in the past, but today you know that if you can provide two different electrical sources, one for the upper division and one for the lower division, you will have a better facial nerve function. So mesenteric nerve graft to the upper trunk and an answer to the lower trunk will give a better outcome to your patient. So this is how the patient had, and see, this patient had a pinna necrosis. So though we had raised the proper skin flap, This patient had had some sort of surgery in the past, and the lower pinna tends to necrose. So remember that the blood supply coming on from the posterior auricular artery, coming from the superficial temporal artery, should be preserved. And please avoid giving a mastoid dressing, because this is what we have faced a problem. And we had a lot of morbidity early on when we were doing these surgeries and giving a regular dressing. So try to avoid giving the tight bandages. To the neurosurgeon, when we are doing a subtotal temporal bone resection, how do you actually address the intracranial, components of the bone osteotomy?
Regarding
subtotal temporal bone.
Actually, we need to plan up to what extent we need to go and what are the other structure associating to the tumor is involved.
It's encased within the temporal bone. There's no spread outside. The tegmen is intact. The mastoid is intact. There's no spread into the glenoid fossa. Now we know it's well contained, but middle is involved. So we have to do a subtotal temporal.
So any dural involvement is there?
No dural involvement.
Or any sinus is also free?
No sinus involvement. Because this is the classic indication for a classic subtotal temporal bone resection.
Yeah. So in that case, actually, neurosurgeon has very least thing to do there.
Of course, we have to work with the neurosurgeon. So the point I wanted to make was precisely that though we feel that it's a well-contained tumor and you need to do it yourself, please do not work in isolation. You need to get a neurosurgeon, because the craniotomy, the access to the subarcuate eminence, the osteotomies at the glenoid fossa, which is lateral to the carotid, all should be done in tandem with the neurosurgery colleague. And I think that's something that we need to inculcate in our practice. You're going to retract the sigmoid sinus. You're going to come across the endolymphatic sac area, and you're going to do the osteotomy there, posterior and superior. Medial and inferior, all of us will do. But irrespective of this, and then when you have an inadvertent dural tear in the posterior fossa or the middle cranial fossa, or you have a tear in the inferior petrosal sinus, you will have a problem. It's better to have a colleague with you who can tackle these. Any comments?
I just like to add here. Actually, when you are doing the drilling box or bipolar box, suction box, nearing to the vital structure, particularly near to carotid, or near to even when we go for the sigmoid sinus or transverse sinus, then in that case, your all equipment need to be very precise. For example, when I've seen many of the surgeons, when they are using the same suction while doing the skin incision, and when they are going inside and suction remain the same. Actually, the suction pressure, then tip of the suction, all need to be changed. You need to be, because most of these injuries, what we see, it's because of the instrument. Thirdly, the bipolar setting, it should reduce your bipolar setting. Actually, I am very thankful to my teacher, Dr. Raza. He used to say, when you go inside, your bipolar tip should be very small. Suppose you need a very precise current here. So bipolar tip should be small and your current should be very low. Normally, near to CP angle, we usually coagulate it in bipolar setting 1 and 2. So bipolar machine should be very good. Thirdly, while you are drilling there over the carotid, so your drill, you need to see size of the drill, sharpness of the drill, and speed of the drill. And drilling should not be point out there, because most of what I see was junior colleagues, they used to directly go and the high speed drill, and drill set doesn't last for the long, and you are injured the vital structure. So drilling in that area is something like you are painting a photograph.
Right.
It should be very slow.
I think that's a very important point. And everybody has different skill sets. You want to ask a question? Yeah. Yeah, we'll just come to that. I just wanted to get across this point of collaborative usage with resection. I would ask the radiation oncologist, now how would you radiate this patient? What is your thought process the middle ear is involved, the dura comes as involved, and you have got neck nodes which are free. Now, is there a standard radiation to be given to this patient? And do we consider proton beam radiation? Because all patients are coming and asking us, I want proton radiation. How should we answer them?
First of all, he requires adjuvantarity. Secondly, since Dura was involved, so while making our plan, we should be like very cautious whether that area is covered by the dose that we wish to give. That should be like in planning, we have to specifically see those areas that are involved and which are like little difficult for the surgeon to resect or go beyond certain anatomical landmark. Secondly, like proton you are asking, sir?
Yes, because
So-
now we know that if you're going to radiate right up to the middle cranial fossa, you will have a possibility of temporal lobe necrosis.
Yes, sir. So data are there that it has shown a few positivity over the photon beam, that is IMRT, that we use. But again, if it is available and patient can take, he should take it because there is no exit dose. Side effects are also less. And since the area of irradiation becomes less, so chances of secondary tumor is also less.
So what is that exit dose you're talking about?
So those, if there is this thing, no positive disease left, so 60 gray is to the tumor board is to tumor bed is sufficient, and we should always use higher techniques, whatever is available with us. Minimum to IMRT we must use, and 60 gray in 30 fraction is enough. But if like some microscopic positive disease there, then we have to escalate the dose to 66 gray.
So how does a proton score over a photon radiation?
So the advantage of proton over photon is there is no exit dose in proton. So like rest of the brain, they are not going to get any radiation because the radiation ends where the tumor bed is in case of proton. But in photon, there will be entry beam, so there will be exit dose also. So like the number of beams that we are using, so like the volume of irradiation means normal tissue receiving low dose becomes more, and more the normal tissue gets irradiated, more the chances of secondary cancer later on life.
So for the pathologist, I want to know, when you all are processing the temple bone specimen, is it easy for you all to report it? Have you seen temple bone sent to you?
Yes, we do receive, not very frequently though. But when we are grossing, the first thing that comes, which is there in our minds, is the TNM staging and what our focus should be on. And the major areas are the bone and soft tissue extent, because the moment we see soft tissue more than 5, it is the highest stage of T4. So margins, if it's a well-removed specimen, at times we do face a little problem with the margins. Body margins are quite clear most of the time. Other than that, these two main factors are always behind our mind.
What is it that you want the surgeons to send to you to make your life easier?
The foremost thing would be the margins, so soft tissue, so that we are able to document an extent of more than 5 millimeter, that is. Other parameters, they are all clinical based of 4. From a pathological point of view, I think the bone and soft tissue is what we are looking at.
So I used to trouble the
Issues which you mentioned of regarding the clinical, those are sent to us separately in the containers. This I was talking of the main specimen that we gross. Rest are also sent in containers labeled separately.
And the nodes, please remove the parotid separately and then send it as a first echelon node and the level 2 as a second echelon. We'll go to the last case. We have time? Last case. 65-year-old female presented with a mucoepidermoid carcinoma of the parotid. She had facial nerve paralysis since 6 months, and the MRI showed the lesion involving the masseter close to the mandible and involving the external canal. The CT scan showed involvement of the external canal and the middle ear. So this is just 2 sections. Sorry, Dr. Kakati.
I have a tumor in the parotid gland.
Yeah.
Right thing, I think. The lobulated tumor here. Is it post-contrast?
This is post-contrast.
Post-contrast. Yeah. It's enhancing mass in the parotid gland.
Yeah.
I think it's involving deep lobe also. Medially, some lobulation is there.
Right.
The middle part.
Yeah, yeah.
This part, yes, yes. So the facial neurovascular is almost embedded within the mass.
Right.
Basically.
So we are seeing that the external canal is normal. Patient didn't complain of decreased hearing.
To see the sagittal scan, okay,
Coronal this is all that we have. Sorry.
I don't know, but then superiorly it's but in this mastoid, the dark bone. Yeah.
Definitely.
Yeah. So you have to see the further superior extension. Very clinically, with this present, definitely something is there.
Right. So external canal, there's nothing inside.
Nothing inside.
So how do we plan this surgery, Dr. Khan? Would you do just a parotidectomy and remove the masseter and the mandible?
First of all, I would not be doing this case.
Suppose you were doing
it. Yes, since it is number one, even if the patient does not have a facial weakness, we'll have to tell the patient that your facial is going to go because it's embedded within the tumor mass. We'll try to save, but there's 90% chance it won't be saved. Now, the dilemma remains regarding the external auditory canal because we do not see an indirect involvement of the external auditory canal. But since it's abutting so closely, I think if we do not do anything to the external auditory canal, it's going to, we will be probably leaving out disease since the tumor is almost, abutting. So I think we have, the patient has to be counseled for at least, I do not know, at the most maybe a sleeve resection.
Brian, what would you do?
This is really a difficult case because the CT is showing involvement of the external canal and the middle ear. Pardon, sir?
That's why they come to you. It's difficult.
I said this is really going to be a difficult and blood resection should be planned, but still radical resection of the parotid, then have to also, I think the lateral temporal bone resection also is not feasible this case. It has to go for subtotal temporal bone resection, I feel, because it is going to the middle ear CT scan is showing. It's difficult, but it should, as far as possible, we should go for M block this case.
Okay.
I don't know how feasible.
Sean, what would you do?
I would be considering a systemic workup beforehand because it's a mucoepidermoid carcinoma. The grade is not mentioned.
Would you ask pathology to review?
Would, but many a time they won't be able to report on an FNA or if it's an FNA. So if they're able to tell, well and good, but it could be a high-grade mucoepidermoid carcinoma, in which case I would definitely want to do a systemic workup first.
So that's a very important point that she would ask for a review of pathology because it's not a common presentation of a mucoepidermoid carcinoma. Rajshri, how would you require true-cut biopsies or FNAs is adequate?
So FNAC won't help. We would require a true cut because the differentials, if you're talking of a low grade, the differentials fall more with the mimics, benign mimics. And if you're talking of a high grade mucoepidermoid, then its differentials are completely different. So we would need as much tissue, as much architecture as possible. FNAC would not suffice.
So we will do a true cut in this. And we will do a systemic workup also in order to see if there's any disseminated disease.
It's not the frozen will not help in the table, on table. Frozen. Because through Kasi malignancy, we do through, rather than they came, we no go for the scene FNC is showing, came, we no go for the frozen on table. These kind of cases.
If we are talking of a high grade, we can only say that it looks like a high grade carcinoma. We won't be able to comment on the type exactly. If we are seeing a very well-defined cystic lesion, which is again correlated with the radiological aspect, then we can suggest the possibility. But its differentials goes towards the benign mimic, so that's a major risk factor in frozen.
Right. So we resected this, and as Brian said rightly, it was coming onto the hypotympanum, and we ended up doing a resection of the external canal. We resected the condyle, we resected the parotid, of course, completely, and we did a complete neck dissection. Sean, how would you reconstruct all this?
First, could we get a margin on the nerve?
We got a margin everywhere, negative.
Okay.
So we are on table now. Still.
The reconstruction, and is there a skin loss?
Yeah, that's the skin loss.
That's the skin loss, okay. So we would need a soft tissue cover for this patient. It could be a regional flap or a free flap. So depending on the patient factors, we can take a decision. Could be a supraclavicular flap or any free flap. Maybe an
submental.
Submental is quite okay. Female patient. About the nodes, I would be concerned. If the nodes are clear.
Nodes are clear.
Nodes are clear, then if the submental artery can be preserved, then we can consider submental, supraclavicular would be good options for this patient.
Right.
But free flap also could be an option. Then other thing would be the nerve reconstruction.
Right.
So if the nerve is free, then again, as I told before, we can consider an interposition nerve graft if the proximal and the distal ends are there.
Right. So it's very important that when you go in for this surgery, you would have planned what type of reconstruction you will do, facial nerve rehabilitation, as well as the hearing preservation. So we need to study all the scans. I unfortunately didn't put up everything. So the middle ear was at risk. So the patient should have been counsel of loss of hearing, because this will be like a cul-de-sac closure. You will have a possibility of doing a facial nerve rehabilitation, because she will require some sort of eye cover. And of course, this large skin defect which is there needs reconstruction. So all in all, you need to first look at local flaps. Submental artery flap is a very suitable flap for reconstructing lateral skull-based defects. If that is not feasible because of nodal clearance at a level 1B, then you would consider doing a supraclavicular or a free flap. Of course, this came as a high-grade mucoepidermoid carcinoma, and the parotid, intraglandular parotid nodes were involved, and the masseter was involved. So would you give this patient chemoradiation or just radiation?
Certainly, actually, in this scenario, we should give the chemoradiation in this patient. Not because of the biology, but as a radio enhancer only we should give.
Okay. And radiation, would it change portals of radiation?
So the most important thing will be before contouring to see the pre-op scans, because the disease was so extensive and then reconstructed. So just with the post-op CT simulation scans, so it will be very difficult to appropriately mark out the tumor bed. So we need to take the pre-op scans, and if possible, if the system allows, we should fuse it to reconstruct the tumor bed on the CT simulation scans.
Right. So I think we'll end this panel here, and we have had a good discussion. We've heard about lateral temporal bone, the subtotal temporal bone. Yeah, Dr. Shubdas, final comments?
Just to clear one query. Regarding that margin, because taking a bony margin in temporal bone is absolutely different from like how we take a cut in mandible or maxilla. Because many a times we take a lot of bone in drilling and all. So do we consider that part of bone as a margin? Like suppose in a final histograph 4 mm, 5 mm bony margin, but it's eventually not 4 mm. A good amount of bone we actually drill out. Do we consider that part?
So the question is, you have done a drill out and you have removed bone after you have removed the specimen and sent to pathology. Now, how do you quantify the clearance that you have achieved, right?
These are situations where we wouldn't really go by the margin definition, but we know that it is a drill out procedure. We would definitely consider radiation.
So you will consider this as a margin positive disease. So you will know that and you will document. That's why your surgical notes are important, because the pathologist will never get that specimen which you have drilled out. So we need to document that that patient had a disease reaching, suppose at the eustachian tube, and then I drilled out the entire eustachian tube, the canal for tensor tympani, and I have exposed the carotid. So that note on the surgery note would then help you understand that yes, there was disease reaching there, and that's the area where you have to include in your primary tumor volume. And that is of importance in a MDT, where your surgical notes correspond to what will help the radiation oncologist plan the radiation therapy.
Sir, I wanted to comment some. Suppose in the CT scan preoperatively, like our case, the bone covering the internal carotid is fine, eustachian tube is fine. If you do a good drill out, then as a surgeon point of view, margin is, we consider it to be free. So
Yes, Brian.
Because
you are cleared it. You have seen it clear. But then we need to document it, and then we need to act on it, because having cleared all that disease from all that area, it's still not with a margin of 5 millimeters. The bone also is not 5 millimeters, because you exposed the carotid. Now there's nothing more to do. So that's the point is not of the surgical clearance. We have no doubt that you have cleared it adequately, but in all documentation, it will still never be a margin negative or a negative margin resection. Thank you very much, everybody. Thank you.
What doing is, suppose that patient cannot able to close these eyes, so you should consider for early fracture of it.
because eye preservation is very, very important. And nowadays you can do a lot of facial nerve stimulations are coming up, dance therapy and all also coming up. So rehabs is very important, and modern rehabs, you have to counsel the patient, you have to motivate the patient. That's how really help. That's how really help.
Thank you very much, everybody.
Thank you, sir. May I request our panelist and the moderator to stay back for a group photograph?
Also requesting whoever is present in the auditorium to kindly stay back. We'll have a group photo at the end. Everyone, please come on the stage for the group photo. Yeah.
The recording has stopped.